Chapter 16 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by MaryAnn Spiegel. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 16, Nursing on Active Service by Miss C. T. Bilton, QAIMNS. Probably never before in history has the nursing profession had so thorough an awakening as it has experienced, and is still experiencing, in this great war. Nurses have had to move quickly, by themselves, from place to place, under circumstances both difficult and inconvenient, and amongst people of unknown ways and languages. They have had to put up with worries and anxieties never imagined or dreamt of before, but this has been the golden opportunity for a woman to show what she is worth both as regards common sense and resource. Many of the profession have experienced both enemy shell fire and aerial raids. A number have joined the great majority, the result of wounds or disease, leaving behind them a memory and an example which will be cherished by those who are left to carry on. Duties of the nursing staff. As a whole, nurses are difficult to move out of a regular routine. One might almost call it a rut. They have gone through a course of training in civil life, where everything runs smoothly and all the requisite necessities are immediately forthcoming. Most nurses who have joined the Army do not reckon with the fact that highly important duties other than nursing and the care of their patients come within their province, and that these require careful thought, coupled with no small knowledge of organization and administration. Initiative and good management are the greatest necessities of the Army Sister. New ways, new ideas, new treatment, differing from what she may have seen or have been taught at her training school, meet her every day. New methods, revealed and practiced as a result of early failures in the treatment of wounds and diseases, have sprung into existence and are still being improved upon. The nursing staff must, then, give obedience and ready attention to carry out orders which may seem at first sight meaningless, but which will always appeal to them in due course. Unless a nurse is sufficiently intelligent and interested to grasp the fact that she is, of necessity, for the good of the Army, learning new and quicker methods of restoring wounded and sick men to health and strength, and so enabling them to carry on in as short a time as possible, then she is a drag on the wheel of her unit, and the work must inevitably suffer. My chief work has been in the Balkans, where the staff worked under great difficulties in a bad climate for 10 hours a day over many weeks. The way they tackled the work was extraordinary, and no praise can be too great for them. Want of water, the difficulties of heating, everything having to be boiled on a Primus stove, the despair of a nurse on active service, and the difficulties of working by the light of a hurricane lantern only, is beyond all description, and can only be imagined by those who have done it. Discipline and management are the most essential assets in a charge sister. Discipline is easily kept, as the sister is dealing with men who understand what an order means, but she must always maintain this discipline. The sister, although entirely responsible for the nursing, has also to requisition for the diets, to arrange and apportion the work of the ward to her nurses and orderlies, and to see to the cleanliness of her ward and to the care, upkeep, and replacement of the ward equipment. She should always remember and impress on her nurses and orderlies the importance of ward cleanliness and hygiene, for neglect of these, especially in the East, favors the presence of flies, which are a potent source of disease and a dangerous menace to wounds. The methodical arrangement of her own work, as well as that of her staff, is the solution to coping with the enormous amount of work that there is to be done. Work of the ward staff. On active service, a far greater number of patients come under the care of a sister than obtains in any civil hospital. In the particular hospital of which I had charge, a sister on the medical side was responsible for 90 patients, her assistants being a staff nurse or a VAD and 3 orderlies. On the surgical side, one sister had charge of 60 beds, and she was helped by a staff nurse, 1 or sometimes 2 VADs, and 2 orderlies. All patients, when convalescent, were transferred to convalescent wards. The orderly's time was practically wholly absorbed in cleaning the ward, carrying the meals, drawing kits, or handing them into store, as well as convoy duties, thus leaving practically all the nursing to be done by the female staff. Orderlies were provided at the rate of 1 to a 30-bedded hut. This staff may sound inadequate, but the work was done and the patients were well looked after and cared for. Economy. Economy we practiced in every way, since the difficulty and uncertainty of transport added tremendously to the anxiety of keeping up the demand for stores. Everything that was possible to be used again was put to a second or third use. Ends of bandages, odd ends of wool from the disused padding of splints, if not stained, were collected in bags, and after sterilization were made up into absorbent, gamgee-like tissue. This tissue, after being again sterilized, was used as an outer dressing instead of fresh wool. Sawdust was tried in bags, but was not very satisfactory, as the dust, being coarse and from miscellaneous specimens of wood, was both heavy and difficult of management. Nursing of wounds. The nursing of wounds has certainly been made easier by the method advocated by Carroll and Dakin, because the suffering by this method has been reduced to a minimum, and the dressings are painless. This not only benefits the patient, but minimizes the nervous strain on the nursing staff, which has constantly to witness suffering. The Carroll-Dakin treatment of wounds also decreases the work of the nursing staff considerably. The hourly or 2-hourly installation of the antiseptic into the wound is easily taught, and can be readily acquired by an inexperienced person. And if it is the duty of this person to see that it is regularly carried out, this will relieve the trained staff. The hourly or 2-hourly watering of the wound refreshes the patient, and the time for his next drink, as he generally terms it, is eagerly watched for. The patient is not disturbed at night by the treatment, but continues to sleep through it all. The greatest difficulty, especially in wounds of the buttock or thigh, is to prevent the bed from becoming too wet. The proper padding of the wound at the dressing, and care that the correct amount of antiseptic only is instilled, with the precaution that the free ends of the tubes are not allowed to occupy a dependent position and so act as a siphon, will, for the most part, obviate this difficulty. We found that a rubber ring pillow to a great extent prevented the patient from lying on the wet bed. Draw sheets we abolished, as even with a mackintosh this always meant an additional wet sheet to change. It was quicker and less disturbing to the patient when the foot sheet only required changing. Cleanliness is essential not only to prevent bed sores, but to abolish all potential sources of infection. All that can be done towards preserving bodily cleanliness must be ever kept in mind. Dirty feet and uncut toenails, dirty hands with uncut fingernails, long, unkept hair with its concomitant scurf, unshaven chins, a soiled condition of the anus and perineum, especially if such be allowed to exist in a surgical ward, not only denote carelessness and neglect, but also act as a very grave reflection on the school at which the sister in charge was trained. Not only is it the sister's duty to have at heart and to see to the cleanliness and hygiene of the ward, but the cleanliness and personal hygiene of her patients are of equal importance, and if these latter be neglected, it spells disaster to the aseptic progress of wounds. This is a point of extreme importance, and cannot be too strongly emphasized. An untidy ward, with an untidy and neglected condition of the patients, indicate an untidy sister. Amputation stumps and badly wounded limbs, from which hemorrhage is likely to occur, ought never to be covered with the bedclothes. Not only is it alarming to the patient to be constantly looked at, but it is easier to watch the dressing for any sign of hemorrhage without disturbing him. Morale of the patients and the ward. Cheerfulness is an essential part of nursing. The patient must be encouraged to think that his one aim is to get well quickly and to be fit again. The morale of a ward can be kept up by a sister who, by her demeanor and work, can show that it is her one aim to get her patients fit again. It may mean a lot of extra work to get a wounded man out of bed, if only for half an hour, but it must be remembered that this one act does an infinite amount of good in improving the patient's morale, for he immediately begins to think that his injury is not as serious as he thought it was. In consequence of getting these men out of bed, they sleep better, eat better, and their spirits and general condition rapidly improve. In this hospital it has been the rule to get wounded men up at the earliest possible moment. In one ward, where some of the heaviest cases were nursed, such as compound fractures of the femur, gunshot wounds of the knee joint, compound fractures of the leg and upper arm, the average time in bed worked out at 13 days. No disaster occurred from getting these men up early, but, on the contrary, the greatest benefit seemed to result in that it had a marked effect for good on the patient's morale and his general condition, besides allowing of proper and thorough attention to his bed. The average time spent in bed for 2,000 consecutive patients, over 80% of whom were suffering from severe wounds, worked out in this hospital at 17 days. This is a great saving of time, labor, and expense, both to the unit and to the state, besides exerting a marked effect for good on the morale of the wounded men. The feeding of wounded men is comparatively simple, for nearly all, except those wounded about the jaws or the abdomen, prefer and can take ordinary diet, and are far better for it. A prolonged course of slops or a chicken and fish diet for wounded men, unless absolutely essential, is to be strongly condemned. Treatment on admission. On admission, the first essentials are to make the patient comfortable, to feed him, to wash him, and to let him rest. Most wounded and sick men arrive in a very tired and worn-out condition at the base hospital, especially if their stay at the casualty clearing station has been short. They have come straight from the battlefield, often a long distance, and with the shock resulting from their wounds, rest is most essential. They have usually been treated at the field ambulance or casualty clearing station, so that it is a mistake, unless absolutely necessary, to dress their wounds at once. Rest and sleep are far more essential at this stage. Tented hospitals and huts. Surgical cases are far harder to nurse in a tented hospital. It is very convenient and often beneficial to be able to open the tent and practically nurse in the open, but when the weather is bad, the tent has to be closed, which renders it airless, dark, and dismal. The huts, as usually built, are not altogether as satisfactory as might be. Those I had charge of were built for 24 beds, but of necessity the number of beds had to be increased to 30. This allowed only just sufficient room for a locker between two beds. The width of the huts was insufficient, for when many Balkan supports or extensions were in use, and this was usually the case, the center of the ward was very narrow. Sweeping the ward under these conditions is difficult, as it is impossible to move the beds. The arrangements for sanitation, especially in hot climates, are most important, as the drainage is not of the modern system one knows at home, but field appliances. What would seem to be the most suitable arrangement is that one end of the hut should be portioned off as a room for utensils, etc., into which the bedpans can be emptied. This must be well ventilated, with a door leading to the outside by which the sanitary brigade can enter when they come to empty the excretia and refuse. In this room there should be a covered tin into which the excretia can be emptied from the bedpans, a bath of disinfectant for washing the pans, and a bath in which soiled linen can be steeped. This apartment should be at the opposite end of the hut to that occupied by the scullery, and from which the food is issued to the patients. All patients able to get up should go to the latrines and washing houses built outside for their use. Nursing in the Balkans has been harder than many imagined. There was much sickness, which made matters just as severe on the nursing staff as on the troops. When a nurse went down with the sickness, this always entailed extra work on the others. Yet through it all, we enjoyed the work, and the great majority of the nurses will always look upon their work in Macedonia as the event in their nursing career. End of chapter 16.
Chapter 17, Part 1 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jill Engle. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 17. Gunshot Injuries of Joints. Part 1. General Anatomical Considerations. Joints are conveniently divided into A. Mobile or diarthrodial joints, B. Immobile or synarthrodial joints. Class A, which forms by far the greater percentage of all body joints, may again be subdivided into 1. Glabrous or gliding joints, for example, the temporomandibular and vertebral articulations. 2. Ginglymus or hinge joints, for example, the ankle and wrist. 3. Ball and socket joints, for example, the shoulder and hip. 4. Rotary joints, for example, the superior and inferior radio-ulnar articulations. Class B includes all suture joints, such as are seen in the skull, the joints formed between the epiphysis and diaphysis of long bones, synchondrosis or synostosis, the symphysis pubis, and the like. Any injury sustained by a synarthroidal joint is but part of a more severe lesion of the bone or bones which form it. Hence, these injuries will be dealt with in the chapter dealing with gunshot injuries of bone. Diarthroidal joints. The general plan of all diarthroidal joints is the same. They are formed by the cartilage-covered articular ends of bone. Each is supplied with a synovial membrane, and some possess certain accessories in the form of intra-articular ligaments and cartilages. Compare the knee and hip joints. While surrounding all there is a fibrous capsule. Muscles and tendons operating upon a joint take their origin or gain their insertion into the bones in the immediate vicinity, and often, by sending tendinous slips into the capsule of the articulation, they enhance its strength. Around the larger joints is a rich arterial anastomosis, and in close relation are the main vessels and nerves of the limb. The articular ends of the bones are, for the most part, epiphyseal, though this is not always the case. The synovial membrane lines the inner surface of the joint capsule and is reflected from this structure on the intracapsular portion of the bone as far as the articular cartilage, where it terminates in the synovial fringes. In a unilocular joint, the reflection of the synovial membrane is simple and uncomplicated, but in a multilocular joint, for example the knee joint, the reflection is both complicated and difficult. The synovial membrane is richly supplied with blood, the vessels running and ramifying in the subsynovial connective tissue. Thus, it will be seen that these vessels lie between a yielding space, the joint cavity on the one hand, and an unyielding structure, the fibrous capsule, on the other. The capsule of a joint is not of uniform strength throughout, but is reinforced in certain directions by thickened fibrous bands, which constitute the ligaments. Such, in brief, are the main anatomical features of a diarthroidal joint. Physiology of the synovial membrane with regard to infection. Normally, the synovial membrane secretes an oily fluid, which not only lubricates the joint, but is responsible for the vitality of the articular and intra-articular cartilages. The amount of synovial fluid secreted is just sufficient for the above needs, and normally its presence in the joint is neither visible nor palpable. Should the joint be subjected to injury, the synovial fluid is secreted in excess, and its presence at once becomes noticeable. The joint assumes a position in which its capacity for holding fluid is at a maximum, and remains thus until the excess fluid is partially absorbed. The intra-articular tension in the synovial fluid of an injured joint varies, but it may be so great as to seriously interfere with the circulation in the vessels which run and ramify in the subsynovial connective tissue. If this is the case, the synovial fluid already secreted will become of low vitality, and therefore prone to infection. Normally, the synovial membrane, like the peritoneum, possesses a high power of resistance against infection. But if its vitality is interfered with, and this must inevitably occur, when the joint cavity is distended with fluid under pressure, then infection of the joint contents is almost bound to follow if the joint has been penetrated or perforated by a missile. Should infection of the synovial fluid follow, then death of the articular and intra-articular cartilages will result, as upon this fluid they are dependent for their maintenance. If, on the other hand, there is an escape for the synovial fluid, and thereby a relief of the intra-articular tension, the circulation in the subsynovial vessels will be maintained and its vitality thereby enhanced. Foci of infection in a joint under the latter conditions tend to become shut off by adhesions, in the same way that an appendix abscess is shut off from the general peritoneal cavity. This we have seen happen time after time in damaged joints, when the intra-articular tension has been early relieved, either by aspiration or through the joint being laid open by a missile in such a way as to permit the escape of synovial fluid. To sum up, the synovial membrane of a joint resembles the peritoneum in its powers to resist infection and to shut off or localize foci of infection by the formation of protective adhesions, provided the intra-articular tension be early relieved and the joint put absolutely at rest. Wounds of joints. These may be 1. Penetrating, 2. Perforating, 3. Indirect. Penetrating wounds may be caused by rifle or machine gun bullets, shrapnel balls, or pieces of high explosive. The missile may damage the soft structures only, or it may lodge in and fracture a bone. The extent of bony involvement may vary from chipping or guttering to most extensive comminution. On the other hand, the missile may penetrate the bone and come to rest in its substance. Perforating wounds are the result of machine gun or rifle bullets or small pieces of high explosive, and they may or may not involve bone. Perforating wounds of the soft parts only, the result of rifle bullets, are often sterile, though a number have given rise to infection. On the other hand, perforating wounds, the result of high explosive, are practically always infected. Damage to bone may range from a clean perforation to most extensive comminution. Indirect wounds are brought about by a missile striking and fracturing a bone at some distance from the joint cavity, causing a fissure in the bone, which communicates with the joint, and bringing about a hemarthrosis. The original wound is usually infected, and infection slowly travels along the fissure toward the joint at a fairly average rate of 1 to 2 centimeters per 24 hours. Wounds in the neighborhood of joints, which neither involve the joint cavity nor bone, will often give rise to a synovitis with effusion. The effusion is either pure or slightly blood-stained, and is rapidly absorbed. This not infrequent occurrence has been called by Makins a fibrillary arthritis. Dislocation of joints is by no means uncommon and results either from being buried or tossed by a shell. Dislocations caused by these means differ from those seen in civilian practice in that there is present considerable contusion of the soft structures and very commonly fracture of bone. Avulsion of limbs through joints. These ghastly wounds appear to be caused by the rending force of high explosive and were seen as the result of the bursting of Minenwerfers. For instance, a Minenwerfer exploded on a signaler's dugout at blank. Nothing was seen of either of the two occupants of the dugout beyond a leg in the German barbed wire some 200 yards away. The limb was recovered after dark by a patrol and was found to be cleanly disarticulated at the hip joint. On another occasion, one of these missiles burst in the middle of a platoon proceeding along a communication trench at blank. Some of the victims showed avulsion of the upper extremity through the shoulder joint, whilst others showed avulsion through the hip joint. It is noteworthy that the two joints at which avulsion was most common were the hip and shoulder, that is to say, the ball and socket joints. Infection of joints. Practically all penetrating and perforating wounds of joints, with the exception of some caused by rifle and machine gun bullets, are infected. The course of the infection will depend upon several factors, which are in the main as follows. 1. The general condition of the wounded man prior to receiving his wound. In other words, the presence or not of fatigue or other debilitating causes. 2. The presence or absence of other wounds complicating. 3. The length of time that elapses between receiving the wound and the beginning of treatment. Many men hit in the knee joint have been known to crawl to safety and lie for hours with a distended and mobile joint before being rescued. 4. The retention of the foreign body with its concomitant piece of clothing in the joint cavity. 5. Severe damage to the soft structures surrounding the joint. 6. Involvement of bone. 7. The degree and duration of a distension of the joint cavity. 1 and 2 are concerned with the general resistance of the individual, and, as already pointed out, fatigue, shock, and hemorrhage greatly enhance infection. The interval of time that elapses before treatment commences is very important, for up to a certain point the synovial membrane can successfully deal with infection. If, however, a high intra-articular tension be not early relieved, infection and toxemia of a very grave nature will follow. Death of the cartilages will be rapidly brought about, and at the best, ankylosis must result. A retained missile with its piece of clothing is a potent focus of infection. Sometimes the missile is lodged in that piece of bone which is intra-articular. In this situation, it is not so serious a menace to the synovial cavity. There are many instances in which the missile has traversed the joint cavity and come to rest in the bone, infecting the latter structure, but not the joint cavity. For the synovial membrane, by adhesions, has shut off the general synovial cavity from the track of the missile. Severe damage to soft structures surrounding a joint and forming part of a penetrating wound is a serious source of infection, for not only is there a large infected surface directly communicating with the joint cavity, but there is very often, in addition, severe damage to the arteries and nerves supplying the joint. Injury to bone is a serious complication of all joint wounds from the point of view of infection and subsequent utility. For bone, under these conditions, is readily infected and very difficult to sterilize. Pathology of infected wounds of joints. The question of infection in gunshot wounds of joints is dealt with in the chapter on wound infection and is also considered in some detail in connection with gunshot wounds of the knee joint. The general features may be restated. 1. Resistance to infection. The defensive powers possessed by joints against invading organisms appear to be very similar to those possessed by other serous membranes, such as the peritoneum, meninges, pleura, and pericardium. The resistance to infection in all such membranes is of high order. This is partly due to the character of the exudate, which is so readily poured out in response to infection, and partly also due to the anatomical structure of the membrane itself. The serous exudate is rich in antibodies and in actively phagocytic endothelial cells, and in addition it contains fibrinogen, which acts as a basis for plastic adhesion of the synovial surfaces at certain points. The living membrane of the joint is thus enabled to act in the same way as does the peritoneum when it shuts off infected foci by the formation of adhesions around them. While the range of mobility of the synovial membrane is naturally somewhat more restricted than that of the peritoneum, this act of localization of infection is to some extent assisted by the rigid character of the synovial surface, whereby the division of the joint into pouches and loculi is rendered possible. These ridges are readily demonstrated in specimens in which the joint has been distended with formalin under pressure, and sections made through the hardened tissues. 3 or 4 of such ridges exist in the subcurial pouch alone, and the other pouches of the joint are constructed on similar lines. The loculation of the synovial membrane makes it possible for 1 or more pouches to be shut off from the general joint cavity. This condition actually occurs in certain cases of infection following penetrating wounds of joints. Examples of joint pouches which may be shut off in this way are, in the case of the knee joint, the subcurial pouch and the posterior pouches, the latter by obliteration of the lateral channels formed by the reflection of the synovial membrane off the condyles of the femur. Thus, when infection invades a joint, the whole extent of the joint surface need not become involved, and in many cases the infection remains localized to 1 or more parts of the cavity. This is possible in a large number of gunshot wounds of joints, for in most of these, in the first instance, the infection invades only a small part of the joint, for example, 1 or more of the anterior pouches, in the case of the knee joint. Conditions favoring localization of infection within joints. These are 1. Perfect immobilization of the joint. 2. Reduction of the amount of exudate, if excessive. 3. Injection of certain antiseptics, for example, ether. 4. Complete closure of the wound in the joint capsule so as to prevent continued access of infecting organisms from the outside. 5. Fixation of the joint in such a way as to prevent spread of infective fluid by the action of gravity. Most of these conditions are considered elsewhere. 1. The first is self-evident. It admits of very wide application in connection with all foci of inflammation. 2. It is obvious that though the arthritic exudate contains protective substances, an excessive bulk of fluid is bound to distend the whole joint and break down all barriers to the spread of infection. To obviate such a condition, aspiration of the fluid is indicated in these cases, wherever it can be carried out. 3. Injection of ether, formalin, and glycerin and other antiseptics into infected joints has probably a harmful action upon the phagocytic cells as well as upon the organisms. The injection of ether has, however, 3 advantages. A. It bubbles out through the wound in the capsule, thus showing clearly the position and extent of such wound. B. In its exit from the joint cavity through the opening in the joint capsule, it not improbably washes out infected material. C. It evaporates and is absorbed with great rapidity, usually within a few minutes. 4. This is an essential point in the surgical technique. If the aim is to prevent suppuration, the joint must be completely closed in order to allow the complete defensive mechanism to act. Only if suppuration occurs should joints be treated by an open method. 5. This refers in particular to the knee joints, in which, with the patient in the dorsal decubitus, intra-articular fluid readily gravitates into the posterior pouches. The fluid tends to pass in the lateral synovial tracts, extending from anterior to posterior pouches on each side. Unless the limb is in forcible extension, fluid does not pass between the bones into the posterior pouches, for the articular surfaces tend to remain closely opposed. Examination of many infected joints after amputation has clearly demonstrated this point. The method of fixation of the various joints is described elsewhere. Suppuration within joints. Attention to the foregoing principles will, in the majority of cases of penetrating wounds of joints in which they can be carried out, result in complete subsidence of the infection, the joint remaining a movable one. In a small minority of cases, in particular those in which a long-chain streptococcus has established its growth, the intra-articular inflammatory exudate will become purulent. If a joint exudate becomes frankly purulent, not merely turbid from increase of cellular content, it loses, among other things, its nutritive properties, on which the nutrition of the articular cartilage depends, and that important structure thus becomes devitalized. Both cartilage and synovial membrane are further acted upon by the locally produced toxins and organisms, and a certain amount of necrosis occurs. Necrosis of cartilage is liable to occur first in the line of junction of cartilage and bone, but may appear early in any part of the articular surfaces. It is followed by sloughing of pieces of cartilages, and these act as infected foreign bodies within the joint, that is, as a nidus for organisms. Sloughing of cartilage in time exposes cancellous bone and may lead to necrosis of bone or even to septicemia by entrance of organisms into the circulation in the bone. At the same time, the endothelium of the synovial membrane becomes damaged. It becomes thickened and infiltrated with leukocytes, and gradually becomes converted into granulation tissue. Healing in such joints is bound to be accompanied by some degree of fibrous or osseous ankylosis. It is obvious, therefore, that when frank suppuration occurs within a joint, the joint cannot be treated by any closed method. It must be converted into an open wound and treated as such, an active sterilization instituted in order to overcome the infection with a minimum loss of tissue and a consequent minimum disability. Bacteriology of gunshot wounds of joints. This is considered fully in connection with gunshot wounds of the knee joint, and the principal points only need be mentioned here. Closed joints. The aspirated fluid, if such can be obtained, should be examined systematically as follows. A. Physical examination. B. Examination of direct films. C. Cultural examination. The presence of a long-chain streptococcus, either in direct films or in cultures, is an indication for opening the joint and applying active measures of sterilization. Occasionally, gas-producing anaerobes may be found in the fluid, but these, if active, are nearly always accompanied by streptococci. No bacteriological finding other than the presence of these two types of organisms is, in our view, sufficient indication for opening the joint. Open joints. These are, for all practical purposes, open wounds lined by granulation tissue, and their bacteriology does not differ from that described for wounds in general. Complications of joint injuries. A. Immediate complications. 1. Acute infective arthritis. 2. Acute infective periarthritis. 3. Acute infective osteomyelitis. 4. Septicemia and pyemia. 5. The presence of other wounds complicating. 6. Secondary hemorrhage. 7. Injury to large nerve trunks. Acute infective arthritis has already been referred to. In complicated joints, such as the knee, this is an extremely grave complication, and often, in spite of active treatment, the result has been amputation, owing to the presence of grave toxemia or threatening septicemia. Acute infective periarthritis results from extension of the infection either from the original wound in the periarticular tissues or from the joint cavity. Thus, an infected joint, through destruction of the continuity of its synovial membrane at any one point, may disseminate infection into the neighboring muscular planes. Again, infection may travel along the sheath of an intra-articular tendon and give rise to an extra-articular abscess. For example, the biceps tendon in the case of the shoulder, and the popliteus tendon in the case of the knee. Suppurative periarthritis is most persistent and difficult of treatment when once established. It may involve tissues immediately adjacent to the great vessels of a limb, leaving them without support, and thus be the cause of a serious secondary hemorrhage. Acute infective osteomyelitis. This grave complication is apt to follow the gross infection of a joint, especially the knee. Unless prompt amputation be undertaken, septicemia and pyemia, followed by the death of the patient, is the almost invariable result. Septic infarcts in the lung, with localized abscesses in the pleura and pericarditis, have been most constant in connection with osteomyelitis, the result of war wounds, especially when the femur has been the bone in question. The medulla of the affected bone, examined post-mortem, shows acute congestion, with beads of pus the size of a pin's head, scattered irregularly and sparsely throughout its substance. The periosteum is congested and peels readily from the bone. The infection is usually mixed, but Streptococcus pyogenes has, in fatal cases, invariably been present. In no cases have we seen gas in the medullary cavity or gangrene of its contents. Septicemia and pyemia. These fatal complications may be associated with infection of joints with or without osteomyelitis. The knee joint is most to be feared in this connection, especially when infection is established in the posterior pouches. Abscesses may form in the lungs, in the pleura, the kidneys, or the spleen. It is of interest that in cases dying from septicemia as a result of war wounds, we have not yet seen a case of endocarditis. The heart muscle shows fatty degeneration, and the liver is fatty to an extreme degree. The kidneys are congested and often show multiple small abscesses. The causal organisms have in many instances been isolated from the bloodstream before death. Septicemia and pyemia vary in degree, and since employing the Carroll-Dakin system of wound treatment, it is now fortunately of rare occurrence. During the sterilization of an extensive compound fracture of the femur, the patient may contract a pulmonary infarct, but the infection, owing to a continuous sterilization of the wound and the consequent improvement in the general condition of the patient, has never proved of a serious nature. A not uncommon accompaniment of septicemia is a red, painful edema in the neighborhood of the large joints. The condition appears to be wholly periarticular and flits from joint to joint, just as one sees in acute rheumatism. We have never seen one of these edematous areas go on to suppuration. The condition at one time was so common that we designated it migratory periarthritis. On the other hand, abscesses may form beneath the skin in various parts of the body. The contents consist of dirty-looking pus with broken-down, semi-digested tissue. Culturally, the contents were, for the most part, sterile. When septicemia becomes established, the original wound presents an indolent aspect. The surface is dry and covered with a glary mucoid material, and there is no wound secretion. The presence of other wounds complicating. Wounds of joints are seriously handicapped by the presence of other wounds complicating, especially if hemorrhage to any extent has occurred from them. Should the joint condition be progressing well, the synovial cavity is very prone to become reinfected if other infected wounds be present. It is highly probable that in this case, the infection is taken to the damaged joint via the bloodstream, for we have seen it occur in instances where every possible precaution had been taken in the dressing of these wounds. A wound of the thorax involving a lung militates strongly against the progress of wounds in other parts of the body, due, no doubt, to a less perfect oxygenation of the blood and an impaired heart's action. Wounds of other parts of the body, which are complicated by wounds of the lung, take longer to sterilize than similar wounds uncomplicated. Secondary hemorrhage. This is by no means an infrequent complication of large wounds involving the large joints, especially if bone is involved. It may occur from a large arterial trunk, the result of periarthritic separation. It may originate from a fractured bone or from the arterial anastomosis surrounding the joint. Each hemorrhage further lowers the general resistance and so aids the spread of infection, both locally and generally, for indeed in this connection septicemia has, on more than one occasion, followed upon a brisk secondary hemorrhage. Fortunately, since the adoption of the Carroll-Dakin system, this complication is now a very rare event. Injury of large nerve trunks. In close relation to the large joints are the main nerves of the limb. Consequently, they are prone to injury. Foot drop and wrist drop should always be looked for, and necessary measures taken for their correction. Pressure sores must be guarded against, and trophic conditions of the skin treated should they occur. As soon as possible after sterilization and suture of the wound, measures must be taken to maintain the tone of the paralyzed muscles. Rapid sterilization and suture of these wounds is most desirable in order to reduce to a minimum the formation of scar tissue, with its consequent stiffness and adhesions in the muscles which follow in its wake. B. Remote complications. 1. Stiffness and limited movement of the joint. 2. Ankylosis. 3. Deformity. 4. Flail joint in cases where excision has been practiced. Stiffness and limited movement may either be intra- or extra-articular in origin. If intra-articular, the cause is most often due to adhesions. The adhesions with patients tend to stretch, and the range of movement will increase. In the case of men who are 30 years and over, the synovial membrane often remains thickened for some months after injury, and a degree of rheumatoid arthritis may ensue. If the adhesions and fibrosis be extra-articular, the case is more difficult, for muscles, nerves, and fascia may be all involved. The extra-articular structures in the case of wounds which have been healed by secondary intention are welded together and involved in dense, unyielding scar tissue, which is often bound down to the ligaments and bone. Increase in the range of movements is extremely slow and limited. The limitation of movement eventually becomes permanent unless a subsequent operation be undertaken for removing the scar tissue and freeing the periarticular structures. Ankylosis is the best result that can be obtained in some joints that have hopelessly suppurated. Many joints which have become infected and suppurated freely have been saved by the Carroll-Dakin treatment, provided the synovial cavity has not been obliterated. Thus we have had instances of suppuration in the shoulder, ankle, and elbow joints, and yet these joints have completely recovered their function after sterilization by the Carroll-Dakin method. Ankylosis may be either fibrous or bony, depending upon the degree of damage sustained by the articular cartilages. Deformity results either from adhesions fixing the joint in a faulty position, or from faulty ankylosis. Thus, if a knee joint be allowed to ankylose in a position of flexion, There will be a faulty transmission of body weight. The limb will be shorter than its fellow, and further deformity will occur. Incapacity of a serious nature will also result when the joints of the upper extremity are allowed to ankylose in faulty positions. Deformity is a late complication, which falls to the lot of the orthopedic surgeon, and so will not further be discussed here. We would, however, urge that if proper measures be taken to sterilize a suppurating joint, other than the knee joint, ankylosis will occur in only a very limited number of cases. 4 out of 300 consecutive cases of suppurating joints, other than knee joints, treated by the Carroll-Dakin method, ankylosis occurred only in 2. Flail joint results when an extensive excision has been undertaken, owing to severe destruction of bone in the neighborhood of a joint. We have personally seen very few such cases, for extensive excision has so rarely been necessary when joints have been sterilized by the Carroll-Dakin process, however fractured the bone may be. The wound has been sterilized in the usual way and secondary suture performed. The results on the whole have been astonishing, as what seemed at first irretrievable damage has proved to be retrievable both as regards the limb and the joint. These cases have been followed through, and their progress watched at an orthopedic depot. Damaged shoulder and elbow joints have especially surpassed all previous expectation. The hip joint. Anatomical considerations. The hip joint is of the ball and socket variety. Passing from a depression in the head of the femur to a depression in the floor of the acetabulum is the ligamentum teres. The synovial cavity is one large space, interrupted only by the ligamentum teres, and postero-inferiorly, the neck of the femur, is in part intra-articular. The joint occupies a position in the wall of the bony pelvis. Consequently, wounds involving it are very apt to involve intrapelvic structures. The capsule of the joint is strengthened by the Y-shaped ligament of Bigelow anteriorly, whilst the pubofemoral and ischiofemoral ligaments strengthen it on its inner and posterior aspects. Closely related to this joint are the femoral vessels, the great sciatic nerve, the crucial anastomosis, and the external rotators of the thigh at the hip joint. Frequency of occurrence. Out of a series of 1,000 cases treated at a base hospital, there were 7 cases of injury involving the hip joint. This gives a percentage of 0.7. This percentage is deceptive, for many cases of hip joint injury, involving as they do the innominate bone and pelvic viscera, are rapidly fatal and never reach a base hospital. From a series of 18 cases seen in the line, 6 reached the field ambulance. 3 of 6 reached the casualty clearing station, and only 1 of these 3 reached a base hospital. Thus, from one small series of 18 cases, there is an appalling death rate of 94.5%. Wounds involving the hip joint are probably today as fatal as any. The series quoted refers to men wounded during quiet times in the line, when there was no undue rush of work, either at the field ambulance or casualty clearing station, and consequently at a time when more individual attention could be given. The series, again, occurred at a time when the Carroll-Dakin treatment was not being practiced, but when drainage tubes, salt, and the older antiseptics were in use. Of the 7 cases which reached a base hospital, 3 died, the cause of death being shock and toxemia. 2 died within 72 hours of admission. The 3rd died a few days after admission from osteomyelitis of the innominate bone, complicated by general septicemia. It had been necessary in the last case to disarticulate at the hip joint. The 2 cases which died within 72 hours of admission had both lain out and arrived at the casualty clearing station, suffering from an advanced gas gangrene infection. The 4 cases that survived reached the casualty clearing station early. Their wounds were immediately excised and a Carroll-Dakin dressing applied. 3 of these 4 cases were completely sterilized and healed after second suture at the end of the 3rd week. At the end of 1 month from the date of injury, these men were getting about well with the aid of crutches. The remaining case was up on crutches at the end of the 12th week. This small series, seen to the finish at a base hospital in the East, and differing in no respects from many cases seen and treated at a casualty clearing station in France, gives a recovery of 57% and an average stay in bed of 5 weeks. The end result in each case was a movable joint soundly healed. Nature of hip joint injury. An injury of the hip joint may involve 1. Bone, 2. Periarticular structures, 3. Intrapelvic or intra-abdominal viscera. Bone. The innominate bone or femur may be fractured either separately or in combination, the injury ranging from a clean perforation without comminution or loss of continuity to a breach of continuity with or without comminution. A clean perforation without comminution or loss of continuity is the result of rifle or machine gun bullets, though these missiles may be responsible for the most extensive laceration of the soft parts and comminution of bone. A common sort of wound in this connection is one in which the great trochanter and neck of the femur have sustained a fracture communicating directly with the hip joint. Again, the missile may enter the head of the femur without causing a breach in continuity of bone. More extensive wounds, the result of shell or a Minenwerfer, occur in which a large piece of the neck of the femur, with the great trochanter, may be pulverized or carried completely away, and on more than one occasion the lower extremity has been completely avulsed from the trunk through the hip joint. Dislocation of the hip has not been of infrequent occurrence during the present war. It has been the result of being buried in a dugout, from being in the neighborhood of an exploding Minenwerfer, and from airplane accidents. These dislocations are frequently associated with fracture of the upper and posterior borders of the acetabular cavity. Again, soldiers with congenital dislocation of the hip are occasionally met with. Periarticular structures. Wounds of the soft parts, which also involve the hip joint, differ but little from wounds of the soft parts elsewhere. The wound of entry may be situated in the buttock, upper thigh, scarpus triangle, or in the immediate neighborhood of the great trochanter. Wounds of the buttock are of a serious nature and very prone to gas infection, as also are wounds in the region of scarpus triangle. Wounds in the neighborhood of the hip joint are likely to involve such structures as the femoral, gluteal, and sciatic arteries, and the sciatic or other large nerves. The large arteries may be either completely severed, buttonholed, or contused, whereas the nerves may be contused, partially torn, or completely divided. Intrapelvic or intra-abdominal structures. A missile entering the pelvis after traversing the hip joint may either come to rest in the extraperitoneal connective tissues, or it may penetrate the peritoneum and inflict injury on the intrapelvic or intra-abdominal viscera. After penetrating the innominate bone, the missile carries in front of it not only its concomitant piece of cloth, but also spicules or plaques of the fractured bone. The intrapelvic lesion is not so much the result of the missile itself as of the piece of bone it carries before it. The pelvic viscera, most frequently damaged in this connection, are the bladder and rectum, though the small intestine and pelvic colon have been involved. In close relation to the acetabular cavity are the large intrapelvic vessels, which are undoubtedly ruptured in quite a number of these wounds, and this in all probability accounts for the sudden death in the line of men who have been hit in this region, for these men all died very rapidly, with symptoms of hemorrhage. Complications of hip joint injuries. A. Immediate complications are 1. Shock, 2. Hemorrhage, 3. Implication of pelvic or abdominal viscera, 4. Other wounds complicating. Shock of a severe degree is an invariable accompaniment of hip joint injuries, especially if the sciatic nerve has been torn or divided. Hemorrhage may be slight or severe, visible or concealed. If smaller arteries only are divided, the shock occasioned by the injury causes a sufficient fall in the blood pressure to prevent serious and immediate hemorrhage. If, however, large trunks, such as the femoral or iliac arteries, are torn, then hemorrhage is immediate, and in the latter case is nearly always rapidly fatal. Implication of the pelvic and abdominal viscera has already been referred to. It may be added that such a complication calls for immediate laparotomy, which necessitates further shock and militates against the patient's chances of recovery. B. Remote complications are 1. Septic arthritis, 2. Osteomyelitis, 3. Infection of the soft parts, 4. Septicemia. An open joint in contact with infected tissue is itself bound to become infected, and the danger in the case of the hip joint is not so much the infection of the joint itself as infection of bone and the spread of infection to the intrapelvic connective tissues. Osteomyelitis may occur either in the femur or innominate bone, although in wounds involving the hip joint, the innominate bone has been the one of election. At a casualty clearing station, a few cases of infection of the head and neck of the femur were seen, but the condition was far more frequent in the innominate bone. Osteomyelitis of the innominate bone is an exceedingly grave and fatal complication, as septicemia is very prone to follow. Infection of the soft parts has already been dealt with. Treatment. A. On the battlefield. This consists in 1. Relief of pain, 2. Arrest of hemorrhage, 3. Immobilization of the joint. Pain is best and quickest relieved by the administration of half a grain of morphia hypodermically. Any large bleeding points must be clamped and tied, and a dressing applied to the wound. Particulars should be noted on the tally. The limb should be now immobilized at the hip joint, and this is best accomplished by means of 2 rifles fastened together. The butt end of one rifle should occupy the axilla, and the butt end of the second rifle be fastened to the boot. This done, the 2 legs should be fastened together with puttees, the wounded man given a warm drink, and sent on with as little delay as possible to the casualty clearing station. B. At the casualty clearing station. When the patient is anesthetized, the temporary splint should be removed, together with all the clothing. The pubis, perineum, and anus should be shaved, and also the skin both in the neighborhood of the wound and at some distance from it. The skin around the wound is now thoroughly cleaned and disinfected, and finally painted over with iodine. The wound must next be cleanly excised and enlarged if necessary. After procuring absolute hemostasis, a Carroll-Dakin dressing is applied, and the limb put up in abduction with extension. The most suitable apparatus for this is a Jones abduction frame, and though transport with this is rather awkward, the difficulties are not insurmountable. The patient is transferred to the base as soon as he is fit to travel, which is usually on about the 3rd or 4th day. C. At the base hospital. The Carroll-Dakin treatment is continued until the dressing is changed, when smears are taken from every part of the wound and reported upon, the count of organisms per field being recorded on the temperature chart. It will be noticed that the joint cavity gradually shuts itself off from the exterior, the hole in the capsule becoming obliterated by plastic adhesions, which later are covered over with young granulation tissue. Provided the temperature keeps normal or is steadily falling, this event is one to be welcomed, for it is an indication that the joint cavity is sterile and shut off from the surrounding wound. When the bacterial count, as obtained by smears, shows 0.4 organism per field, 2 to 5 fields, with healthy leukocytes and macrophages present, secondary suture may be safely performed. The stitches should be removed at the end of the 10th day, and if the wound is soundly healed, the patient may get up on crutches. We have not always found it necessary to maintain abduction after the wound has soundly healed, as the patients can to some extent move the joint, and this should be encouraged. If, however, there has been fracture of the neck or great trochanter of the femur, or fracture of the acetabulum, especially of the upper lip, then extension and abduction must be maintained. For this reason, after the wound has soundly healed, the patient can be put up in plaster, with the limb abducted and slightly externally rotated at the hip joint. Should the sciatic nerve or branches of the anterior crural nerve be divided, they should be sutured prior to performing secondary suture of the wound, and all necessary steps be taken to guard against foot drop and trophic sores. Patients suffering from wounds of the hip joint often complain for the first few days of severe pain in the knee. This troublesome symptom is purely a referred pain and passes off as the wound about the hip becomes sterile. Aspirin, 10 grams, given 3 times a day is usually sufficient to give the patient complete relief. End of Chapter 17, Part 1. Recording by Jill Engle. Chapter 17, Part 2 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jill Engle. War Surgery, From Firing Line to Base, by Basil HUGHES and H. Stanley Banks. Chapter 17. Gunshot Injuries of Joints. Part 2. The knee joint. Anatomical considerations. Developmentally, the knee joint consists of 3 pouches, 1 superior and 2 lateral, the latter separated by the ligamentum mucosum. Accessory pouches later join the main cavity. Thus, the subcurial bursa becomes attached from the 3rd to the 5th year, and the posterior bursa joins up anywhere from the 10th to the 14th year. The posterior bursa is divided mesially by the posterior crucial ligament, and joining its internal division is the bursa beneath the semimembranosus tendon. A bursa beneath the ligamentum patelli sometimes communicates with the main cavity. The adult knee joint thus consists of a subcurial pouch, paired lateral suprapatellar pouches, paired lateral infrapatellar pouches, a posterior pouch completely divided in the middle line, the semimembranosus bursa, and sometimes the bursa beneath the ligamentum patelli, that is, 9 pouches in all. Anteriorly, the synovial membrane is pushed forwards by the infrapatellar pad of fat and forms the ligamentum mucosum. Inferiorly, the line of reflection is along the upper margin of the tibia, whilst superiorly it is at the apex of the subcurial pouch. Laterally, the line of reflection is about the same level as the anterior margins of the internal and external lateral ligaments, and posteriorly it is situated along the upper margin of the tibia below and above the femoral condyles above. The communication between the anterior and posterior pouches, so far as spread of infection is concerned, is around the lower aspect of the condyles of the femur, where a narrow channel exists which is formed by the reflection of the synovial membrane. The posterior pouch is easily and readily obliterated by slightly flexing the knee and applying very light pressure over the popliteal space, and the lateral communications between the anterior and posterior pouches are also easily obliterated by very slight pressure. The subcurial pouch is irregularly divided by a series of septa, whereas the reflection of the synovial membrane laterally presents a scalloped appearance. Running through the outer aspect of the posterior bursa is the popliteus tendon. Closely related to the joint posteriorly are the popliteal vessels and nerves, while a rich arterial anastomosis surrounds the joint and the patella. Frequency of occurrence. From nearly 2,000 consecutive cases of gunshot injuries treated at a base hospital, there have been 115 cases of knee joint injuries. This gives a percentage of 5.7. During active fighting, when advancing troops are going forward in the face of machine gun fire, the percentage is probably higher. Many men who are hit in the knee joint die from other injuries on the battlefield or at the clearing station, and for this reason, statistics of a clearing station are more reliable than those of a base hospital, though, of course, the most reliable statistics are regimental when taken from a number of regiments. During active fighting, from rough calculation, we would say that gunshot injuries of the knee joint form fully 8% of all wounds, probably more if many enemy machine guns are in action. Nature of the injury. Wounds of the knee joint may be A. Penetrating, B. Perforating, and they may or may not involve bone. Penetrating wounds of the knee joint may be caused by rifle bullets, shrapnel balls, or small pieces of high explosive. The foreign body may come to rest either in the joint cavity, the ligamentum patelli or periarticular structures, or in bone. From 115 cases of knee joint injuries seen and treated by us in the Balkans, we have not seen a single instance where the missile used has been a rifle bullet. All, without exception, were the result of shrapnel or high explosive. This is rather odd, because in France, a considerable proportion of the knee joint injuries that we treated were caused by rifle or machine gun bullets. Wounds of the knee joint caused by high explosive are undoubtedly the most dangerous of all. Shrapnel balls are less dangerous, and rifle and machine gun bullets are the least dangerous. The injury to bone involved in a penetrating wound may range from a perforation without extensive fracture to extensive comminution. Perforating wounds of the knee joint may involve soft structures only, or both soft structures and bone. The sites of the entry and exit wounds are of importance. The least dangerous seem to be wounds about the anterior aspect of the joint, involving only the anterior pouches, while wounds in the popliteal space are notoriously serious, as there is both the risk of infection of the posterior pouch and damage to the popliteal vessels and nerves. The damage to soft structures and bone may range from a simple perforation to laceration and comminution of an extensive kind. A knee joint may become involved as the result of a fissured fracture of the femur communicating with the joint cavity. In this case, a hemarthrosis results, which may or may not become infected. Gunshot wounds of the knee joint may damage the popliteal vessels or nerves, especially if the wound be situated in the popliteal space. It is interesting to note that in this connection the external popliteal nerve is by far the most frequently involved, and dropped foot results. Again, infection may travel from the joint cavity through the original perforation in the synovial membrane and give rise to periarticular separation, which is apt to result in secondary hemorrhage. Provided that intra-articular tension be kept low by aspiration, the synovial membrane can deal with a considerable degree of infection if the joint be kept absolutely at rest. The periarticular structures in the immediate neighborhood of the wound are contused and edematous. Consequently, any extension applied to such a wounded limb is painful and militates against complete rest of the wounded joint. Should fracture of bone have occurred, infection is very likely to follow, either of a limited or diffuse type. Bacteriology. In considering the question of infection in knee joints following gunshot wounds, it is desirable to discriminate between three main classes of injury. 1. Wounds in which a part of the joint is laid widely open. 2. Wounds in which the opening in the joint capsule is small. 3. Wounds in which the joint capsule is unbroken. 1. Wounds in which a part of the joint is laid widely open. Many of these wounds require amputation at the casualty clearing station, but a fair proportion are treated by conservative methods and reach the base hospital with the limb preserved. They are usually the result of wounding by high explosive or by explosive bullets, and are accompanied in most cases by considerable loss of bony substance. The cases which come under treatment at the base hospital are generally those in which a single joint pouch is widely opened up. In such cases, the remainder of the joint commonly becomes shut off, and from the point of view of infection, the wound does not differ materially from a compound fracture. The material secured for examination is simply the discharge from the depths of the granulating surface of the wound, unless the rest of the joint becomes filled with fluid, in which case a simple aspirated fluid may be obtained. Where there is much loss of substance, healing is a slow process, and unless the wound be sutured early, reinfection is prone to occur. It is often difficult to secure early sterilization in such cases, unless the technique throughout has been faultless. Where sterilization is delayed, when the Carroll-Dakin method has been used, the dominant organism is found to be a long-chain streptococcus. Autogenous vaccines in large doses are recommended for such cases. 2. Wounds in which the opening in the joint capsule is small. This class forms the large majority of gunshot wounds of the knee joint. The material obtained for bacteriological examination is the fluid aspirated from the joint at the commencement of the application of the dry treatment. Such aspirated fluid may be obtained either at the casualty clearing station or at the base hospital, or both. The fluid may come from a single shut-off pouch, the subcurial, or it may be a sample of the general synovial exudate of the joint. The object of the bacteriological examination is 1. To ascertain the presence or absence of established infection, 2. To ascertain the type of infection, 3. To prepare a vaccine, if necessary. Both 1 and 2 have a definite relation to prognosis and treatment, as will be seen later, and 3 is now recognized as a valuable subsidiary form of treatment in suitable cases. The examination of the knee joint fluid falls under 3 heads. 1. Physical. 2. Direct films. 3. Cultures. 1. Physical examination. The following types of fluid, classified according to their physical characters, may be seen. 1. A fluid containing non-hemolyzed blood mixed with synovia. In nearly all cases of penetrating gunshot wounds of joints, if the fluid be aspirated before actual separation occurs within the joint, the fluid is found to be blood-stained. Where the joint capsule has not been penetrated, a point which is at times difficult to determine, the joint fluid is not usually blood-stained. If the blood be not hemolyzed, it may, in a few cases, be derived from puncture of a vessel by the needle. This is likely to be the case where the blood coagulates in the tube. Apart from such accident, it may be stated that there are 2 distinct types of fluid containing non-hemolyzed blood. A. Non-infected fluids, as shown by microscopic and cultural tests. B. Infected fluids, as shown by the same tests. In a series of 42 aspirated knee joint fluids, type A was met with in 6, all of these being from joints in which the capsule had been penetrated by high explosive. The fluid, aspirated at least 3 days after the injury, contained simply uncoagulated blood mixed with synovia. Direct films showed no polynuclear leukocytosis in the fluid, and no tissue elements indicative of repair. Cultures were sterile. The examination of the fluid revealed no sign of gross inflammatory change within the joint. Since fragments of high explosive carry infection into the tissues in practically every case, it must be presumed that any infection which may have been introduced had been satisfactorily overcome by the vital activity of the synovial membrane. In other words, that the infection had not become established. All of these cases had been treated by the dry method, and immobilization had been thorough. In most of them, the technique of treatment described elsewhere in this chapter had been carried out, although in some it had been incompletely performed. The fact, however, that fluids of this type are met with in such a proportion of cases seems to point to high powers of vital resistance to infection on the part of the synovial membrane of the knee joint. Type B was obtained in 9 out of the 42 fluids. All of these were from penetrating wounds of the knee joint. In 3 cases, the evidence of infection was unequivocal, Staphylococcus aureus being grown from the fluid. In the other 6 cases, the fluid was sterile on culture, but there was seen in direct films a definite excess of polynuclear cells, as compared with normal blood. This leukocytosis of the joint, as we have called it, we have come to regard as sufficient evidence of infection, even in the absence of growth in cultures. The type of infection in these 9 fluids was thus one which was non-hemolytic to blood. Staphylococcus aureus, when present alone, has never been observed to hemolyze the blood. The Staphylococcus cases, as well as those in which cultures yielded no growth, apparently therefore constitute a non-hemolytic type of infection, which is relatively a mild one. In every case in this series, the dry treatment was sufficient to overcome the infection. The temperature remained elevated for a very few days, as a rule, and swelling and pain rapidly subsided. In not a single case did the infection go on to suppuration, and the cases were regularly dismissed to the convalescent depot with movable joints at the end of 6 weeks. Since we know from experience that Staphylococcus aureus is capable of producing acute suppuration in the knee joint under other less favorable methods of treatment, it seems probable that the dry method of treatment employed has some beneficial effect in aiding the synovial membrane to overcome this type of infection. 2. A fluid containing hemolyzed blood mixed with synovia. Hemolysis in these fluids varies considerably in degree. Its presence is determined by a permanent reddish tinge in the supernatant fluid obtained after centrifuging the specimen or allowing it to stand. All grades of color may be seen, from a slight tinging of the supernatant fluid to a deep red color. In 16 out of the 42 aspirated fluids examined by the authors, hemolysis was present, and in 11 of these, organisms were found in direct films or on culture. In the remaining 5 cases, no organisms were found, but a definite polynuclear leukocytosis of the joint was obtained in all. The infection in this series was generally much more serious than where the infection was non-hemolytic. The most common infecting organism found was Streptococcus pyogenes, and other varieties of Streptococci were also cultivated. We regard hemolysis as an important point to be observed in the aspirated fluids from wounded knee joints. Hemolysis always indicates infection, and the infection is often of a severe type. 3. A yellow fluid with a coagulum. This is the ordinary serofibrinous exudate of a serous membrane reacting to irritation, whether infective or mechanical. It is obtained in certain penetrating wounds of the joint in which no gross hemorrhage has occurred into the joint, for example, where foreign bodies are very small, and also in certain non-penetrating cases, where there is acute inflammation in the neighborhood of the joint. The depth of tint varies from a deep straw to a lemon-yellow color, and is probably due to the presence of blood pigment. This pigment is, in most cases, locally produced from slight extravasation of blood in the exudate, but it may be associated with a yellow color in the serum, generally resulting from hemolysis in the circulating blood. This is seen, for example, in cases where an effusion occurs into the knee joint during the course of severe gas gangrene toxemia. Fibrinogen is usually present in considerable amount in these yellow-colored fluids. Out of 6 fluids of this class in our series, 4 were from penetrating wounds and 2 from non-penetrating wounds of the joint. The 4 from the penetrating joints were all infected, the organisms grown being a short-chained Streptococcus, Staphylococcus aureus, and a diphtheroid bacillus. The remaining 2 fluids, one of which was straw-colored and the other lemon-yellow, yielded no evidence of septic infection, no leukocytosis of the joint, and no growth on culture was obtained. In both of these cases, the wound was a severely infected compound fracture of the lower third of the femur, just above the joint. The case from which the straw-colored fluid was obtained was a fatal gas gangrene wound. In the 5 of these cases which recovered, the infection within the joint, indubitably present in 4, was sufficiently mild to subside completely under the dry method of treatment properly carried out. Not one case progressed to suppuration. The conditions of infection appear, in these cases, to be similar to those obtained in a simple serofibrinous exudate of pleura, peritoneum, or pericardium, all of which, in general, subside completely when the parts are kept at rest. 4. A flaky coagulated non-pigmented fluid. This type is rare, only 2 cases out of a series of 42 having been seen by the authors. Both of these cases were from penetrating wounds of the joint, and both were infected. One of them yielded Streptococcus faecalis on culture. In both cases, the joint infection subsided under the dry method of treatment. This kind of fluid appears to be present in certain penetrating wounds of the knee joint where no hemorrhage has occurred into the joint. For example, in cases of penetration by multiple minute fragments of high explosive. It is associated with a type of infection mild enough to be overcome by the joint synovial membrane when the latter is put under the proper conditions. 5. A fluid containing pus. This type of fluid occurred in 9 out of our series of 42 early aspirated fluids. Almost all occurred among the first lot of knee joints treated, when the treatment at the casualty clearing stations as well as elsewhere was faulty. All of them were aspirated and found to contain pus within the first 3 or 4 days after the infliction of the wound. In all cases, the infecting organism was found to be a long-chain streptococcus, which was proved on several occasions to be Streptococcus pyogenes. The amount of pus varied much, and in some cases was sufficient to produce only a slight turbidity in the fluid. In every case, however, it was found necessary to treat the joint by the open wet method. The joint synovial membrane is apparently unable to subdue, unaided, a well-established infection with Streptococcus pyogenes. It was amongst the first 20 cases of this series of 42 that 8 of the 9 cases of purulent fluid occurred. In the last 22 cases, only 1 was found, and in this case the gross error of leaving the capsule of the joint unsutured had been committed at the casualty clearing station. The greatly diminished incidence of this severe form of infection in the later joints treated was ascribed entirely to improved technique of operation and subsequent treatment. The infection is one which would appear to be preventable by proper early application of the dry method of treatment described. When the infection is once established, the dry treatment is inadequate, and the joint must be opened and vigorous antiseptic irrigation treatment carried out. Odor. The discharge from infected knee joints has rarely any foul odor. The aspirated fluid, as well as the ordinary discharge from widely open joints, may contain gas-forming anaerobes, the former somewhat rarely, the latter commonly. Both B. perfringens and B. sporogenes have been frequently cultivated from knee joint fluid. It is rare, however, to detect a foul odor in the fluid, and actual gas formation within the joint is seldom, if ever, seen. The joint synovial membrane, like other serous membranes, such as the peritoneum, meninges, and pericardium, appear to have more active powers of dealing with anaerobic infection than has muscle or fascia. 2. Examination of direct films. Direct films are made from the fluid or from its centrifuge deposit, and stained by Keene's carbomethylene blue and by Graham's method. As a rule, it is sufficient to make the film from the fluid as received, but where the fluid is almost clear, the cellular elements being scanty, it is desirable to centrifuge 1 cc or more of the fluid in a narrow tube and make films from the deposit. Carbomethylene blue, as previously stated, is an excellent stain for the purpose and has the following advantages. A. Cells are well stained and differentiation between nucleus cytoplasm is marked. B. Organisms are stained intensely and sharply. C. Red blood corpuscles are stained green and can thus be distinguished at once from lymphocytes and tissue cells. D. Certain leukocytes are stained purplish, both polynuclears and mononuclears. These invariably show a widely meshed nuclear chromatin, and not uncommonly, organisms are seen in their cytoplasm. Their significance is unknown, but their appearance and incidence suggest that the purplish color denotes some degree of exhaustion or degeneracy, possibly associated with phagocytosis. The points of practical importance to be noted in the examination of direct films are 1. The types and relative numbers of cells present. 2. The presence or absence of organisms, and, if present, their nature. 1. As regards the cellular elements, the most important point is to determine whether there is a relative excess of polynuclear cells as compared with normal blood, when blood is present in the exudate. A glance at the film under microscope is usually sufficient to determine this, but occasionally a rough differential cell count is necessary. Where the excess of polynuclears is definite, a polynuclear leukocytosis of the joint is present, and this we regard as evidence of active infection, even when other tests are negative. When the fluid does not contain blood, the presence of even a few polynuclears is abnormal and indicative of some degree of septic infection. The large mononuclears, both large lymphocytes and endothelial cells, are commonly present in fair numbers, as in all serous exudates, and this point must be allowed for in estimating polynuclear leukocytosis of the joint. When tissue cells are present in quantity, they denote an ulcerative or granulating condition of the synovial membrane or other structure within the joint. The presence of organisms is usually clearly shown both in the blue-stained film and in the gram preparation. The presence of large, stout, gram-positive bacilli usually denotes gas-forming anaerobes. If present, they are to be regarded as a sign of danger, but their mere presence is no indication for special treatment, such as opening the joint, unless they are accompanied by long-chain streptococci. The organism which we have found to be of most serious import is Streptococcus pyogenes, which appears in direct films in long-chained form. Wherever a long-chained streptococcus is found in numbers in the exudate of wounds, whether open or closed, the sterilization of the wound is not proceeding satisfactorily, and in general, further or more efficient treatment is required. In every case in which we have found a long-chain streptococcus in direct films from joint fluid, the dry treatment alone has failed, owing to the severe toxemia or septicemia which has been produced. In all such cases, the joint has been opened and Carroll's procedure applied, and in some cases the limb has later been amputated. This bacteriological finding we regard as sufficient indication in itself for opening the joint. The infection, in our experience, is not always a virulent one. Clinically, the joint is acutely swollen and tender, and there are symptoms of severe toxemia. But even if symptoms be less acute, we regard the above finding as sufficient to indicate immediate treatment of the joint by the open-wet method. Coliform bacilli, etc., are usually seen in direct films only in the case of gross infection, in which case streptococci are not likely to be present in addition. If unaccompanied by a long-chain streptococcus, they denote active septic infection, but the joint must not necessarily be opened. 3. Cultural examination. Both aerobic and anaerobic cultures should be made, and in general the principles of cultivation of wound bacteria already mentioned should be followed. Cultures from knee joint exudates may be of practical importance in at least two ways. A. They determine definitely the type of infection present, a point which is of interest and may be of assistance to the surgeon in determining further treatment. And B. They may be required for the preparation of autogenous vaccines. Such vaccines should be employed, in particular, in all infections with Streptococcus pyogenes or other virulent streptococcus. Aerobic cultures should be made on an enriched protein medium, such as trip agar or brain agar. Primary anaerobic cultures should be made both in milk under paraffin to test for B. perfringens and also in broth, preferably of a kind containing particles in suspension, for example egg broth or brain broth. Subcultures may be made upon Dorset's egg medium for B. sporogenes and on glucose agar plates, incubated anaerobically by some method such as Henry's, in order to obtain pure cultures if such are desired. The following scheme is suggested for cultural examination. Incubation, aerobic, media for primary culture, trip agar or brain agar. Media for first subculture, brain agar, for vaccines. Media for subsequent subcultures, brain agar, for vaccines. Anaerobic incubation, media for primary culture, 1. Milk under paraffin, media for first subculture, milk after heating to 80 degrees Celsius for 20 minutes, alkaline meat. Media for subsequent subcultures, Dorset's egg medium, glucose agar plate. Or, medium for primary culture 2, broth or egg broth or brain broth. Media for first subculture, alkaline meat or glucose agar plate. Media for subsequent subcultures, glucose agar plate. Aerobic cultures. Any of the aerobes of wounds may be isolated. The most common are Staphylococcus, Streptococcus pyogenes, Streptococcus faecalis, or the Enterococcus, Micrococcus tetragonus, and coliform and diphtheroid bacilli. The Streptococcus pyogenes infections are the worst. They not uncommonly occur in joints which have been badly treated, for example, where a joint has been washed out with saline or where the capsule has not been closed. The presence of this organism forms the only absolute bacteriological indication for opening the joint and treating by the Carroll-Dakin method. Infection with any of the other aerobes can usually be subdued by the synovial membrane if the joint be treated from the outset, as described in the section on treatment. Anaerobic cultures. The most common organisms isolated are B. perfringens and B. sporogenes, the chief representatives of the saccharolytic and of the proteolytic groups of anaerobes, respectively. They are usually found in wounds in which the joint is widely open and there is free communication with the surface. They are sometimes cultivated, however, from the aspirated fluid from a closed joint. Although these anaerobes are cultivated from the joint with comparative frequency, actual gas formation within the joint is rarely, if ever, seen. This fact also lends support to the view that the knee joint synovial membrane, as regards resistance to infection, is no less active than other serous living membranes, for example, those of the peritoneal and pericardial cavities, in which gas formation is the greatest rarity. 3. Wounds in which the joint capsule is unbroken. Effusion may occur into the knee joint in case of certain non-penetrating wounds involving structures in the immediate neighborhood of the joint, for example, compound fractures of femur and tibia, or any gas gangrenous wound in the vicinity of the joint. On account of this, it is sometimes difficult to determine whether the capsule has been penetrated or not, and in such cases the method of injection of ether into the joint from the opposite side of the wound, as described on page 369, is of particular value in settling this point. In these non-penetrating wounds, the fluid aspirated from the joint is not usually blood-stained, and is generally either a yellow serofibrinous exudate or a frankly purulent fluid, depending on whether the extraarticular pus has invaded the joint capsule or not. The method of examination of the fluid and of treatment of the joint do not differ from those already described. Delayed infection of the knee joint comes under this heading. The term is applied to those somewhat rare cases of compound fracture of the femur or tibia in the neighborhood of the joint, which are followed by a sudden effusion into the joint at a period averaging some 2 to 3 weeks after the infliction of the wound. The path of the infection is usually a fissured fracture of the bone, although the fissure is not always demonstrable in a radiogram. The infecting organisms, which are usually virulent streptococci, travel along the fissure in the bone to the joint during the latent period. When the joint infection does occur, therefore, it is not uncommonly a virulent streptococcal one, and the condition generally is to be regarded as serious. The diagnosis of this type of infection and the treatment are on the lines already described. Spread of infection within the joint. The evidence afforded by the morbid anatomy of amputated specimens as to the routes of spread of infection within the knee joint has already been dealt with. Summary. 1. In certain penetrating wounds of the knee joint, the infection carried in by the missile fails to produce inflammatory changes under appropriate methods of treatment. The fluid aspirated from the joint in such cases is mixed blood and synovia only, without hemolysis. Direct films show no polynuclear leukocytosis, and cultures are sterile. 2. The following physical characteristics of aspirated fluids from the knee joint denote established active infection. A. Hemolyzed blood. B. Flakes. C. Pus. If non-hemolyzed blood be present, the fluid may yet be infected, but a non-hemolytic type of infection is generally less severe than a hemolytic type. 3. Direct films giving a polynuclear leukocytosis in the joint fluid indicate infection, even when cultures yield no growth. 4. Of all the organisms which may be cultivated from aspirated knee joint fluids, a long-chain streptococcus is the only one which consistently fails to be subdued by the vital resistance of the synovial membrane under appropriate dry methods of treatment. The presence of this organism in films or cultures is a direct indication to open the joint and apply wet methods of treatment. The joint fluid in such cases, if aspirated after the second or third day, is usually found to be purulent. 5. If the fluid aspirated after the third day be non-purulent, the joint inflammation should, in general, subside under the dry method of treatment. 6. The rarity of gas infection within the knee joint, in spite of the frequent presence of gas-producing anaerobes, supports the view, based on this and on the other facts noted above, that the knee joint synovial membrane has powers of vital resistance comparable to those possessed by the peritoneum and other serous membranes. 7. In certain non-penetrating wounds, effusion may occur into the knee joint. The aspirated fluid in such cases may or may not be infected, and the treatment depends on the bacteriological findings as indicated above. Where the effusion occurs in bone cases many days after the infliction of the wound, delayed infection, the fluid usually contains a virulent long-chain streptococcus and indicates a serious infection requiring wet methods of treatment. The appended table shows the bacteriological findings, the treatment and results of treatment in a consecutive series of gunshot wounds, high explosive, of the knee joint bacteriologically investigated. It will be observed that, generally speaking, the best results are found in the latter cases of the series, when technique had become more perfect. Treatment. A. On the battlefield. The wounded joint must be absolutely immobilized in a position of very slight flexion. A piece of ration box with a pad made from a putty placed beneath the popliteal space is all that is required. After application of the first field dressing, the wounded man should be carried with as little delay as possible to the advanced dressing station. A quarter of a grain of morphia may be given hypodermically to relieve the pain, and this must be noted on the regimental tally, with the date and hour of the wound. B. At the field ambulance. Should immobilization of the injured joint be complete and satisfactory, nothing further need be done at this unit beyond administering the usual dose of anti-tetanic serum. If, on the other hand, the splint applied on the battlefield is inadequate, then a back splint with footpiece, with a pad in the popliteal space, must be substituted, and the patient sent on to the casualty clearing station without delay. C. At the casualty clearing station. On arrival at this unit, the injured joint is usually acutely swollen, tender, and fluctuant. The advisability or not of performing a complete operation at this unit depends upon the presence or not of a reliable X-ray apparatus, and whether or not an undue rush of work is going on. Should the unit be not unduly pressed, and should it be in possession of a pathologist and a good X-ray apparatus, then operation may advisedly be undertaken. On the other hand, should the conditions be adverse, then simple aspiration only of the joint is advisable, for undue risk is taken in opening a knee joint in an operating theater where operations for other severely infected wounds are in progress. After aspiration of the joint contents and the consequent immediate relief of the intra-articular tension, the joint is immobilized by means of a back splint and footpiece, and 2 side splints, slight flexion being maintained and pressure exerted both posteriorly and laterally by means of suitable pads. Prior to aspiration, the limb in its entirety must be thoroughly washed and shaved, and the skin made as sterile as possible. We have, latterly in the East, also shaved the pubis, perineum, and anus in every case, as, under the circumstances, it is more cleanly and makes the nursing more simple. At a busy casualty clearing station in France, we practice simple aspiration of the joint in a large number of cases. After aspiration, the cases were immediately evacuated to the base, and subsequent information from the base hospitals proved the practice both sound and justifiable. Reports from the base hospitals seem to prove conclusively that better results followed simple aspiration at the casualty clearing station, whereas reports on joints that have been opened and washed out with saline, with or without removal of a foreign body, were unsatisfactory, and we can strongly corroborate this from our experience at a base hospital in the Balkans. For out of a series of 16 knee joint injuries, in which joint lavage had been practiced after excision of the wound, 12 progressed to a most virulent suppurative arthritis, whereas in a series of 31 cases, all the result of high explosive, that had been treated by simple aspiration at the casualty clearing station, only one case became infected. This is a striking difference. D. At the base hospital. At this unit, an X-ray should be taken in 2 directions as soon after arrival as possible, in order to determine any bony damage and the presence of a foreign body. If the joint is acutely distended, it should be aspirated at once, and the contents sent to the bacteriologist for investigation. A microscopical report aids greatly in prognosis and the subsequent treatment of the case. Favorable signs in the joint fluid are the presence of a leukocytosis, in which the leukocytes are healthy and stained well, absence of organisms in a smear preparation, and the presence of a few organisms either in smear or culture, provided the Streptococcus pyogenes is absent. A very unfavorable sign is the presence of a turbid fluid containing small flakes of lymph, and microscopically showing degenerate leukocytes, and the presence of Streptococcus pyogenes. If a foreign body be present in the joint, it is important to ascertain from the patient the posture he was in at the time of being wounded. For example, was he sitting, crouching, standing, etc., because the foreign body is invariably more easily extracted with the joint in the degree of flexion or extension that obtained when the wound was inflicted. Operation. The patient is fully anesthetized before the splint and dressings are removed, and throughout the operation the greatest care must be taken not to move the joint unless it is absolutely necessary, as by this means infection is only further disseminated. The limb should be again thoroughly cleaned with ether soap, followed by biniodide of mercury in spirit, dried, and the joint painted over with iodine. An aspirating needle is now inserted into the opposite side of the joint to that of the wound. The joint contents removed and sent in a sterile tube to the bacteriologist. The needle is left in the joint, and through it 5 cc of ether are injected into the joint cavity. The needle is then removed. The joint now becomes swollen and tympanitic, owing to the vaporization of the ether. The wound is then seared over, either with pure carbolic or the cautery, this precaution being taken to avoid any weeping from the septic wound surface onto the cleanly excised wound. If the cautery be used instead of pure carbolic, it should be before the injection of ether. The wound is finally excised en masse, including the perforation in the capsule. Prior to excision of the wound, a tourniquet is applied to the limb. The wound throughout the operation is swabbed with 1 in 1,000 saline solution of flavine or brilliant green, or with Usol. As soon as the ether is injected into the joint, it is seen to bubble out of the wound in the capsule. This is of advantage, as it shows exactly where the perforation in the capsule is situated and its extent, while at the same time the constant ebullition of ether from the hole in the joint prevents, to a large degree, the entrance of infection during the process of excising the wound. Moreover, on more than one occasion the missile has been forced out of the hole in the joint capsule by the force of the ether behind it. After the wound is excised, the surgeon changes his gloves and uses fresh instruments and towels. If necessary, the incision in the capsule is now enlarged in order to expedite the removal of the foreign body, though this is not often called for. The next step is closure of the hole in the synovial membrane and capsule with a continuous catgut stitch. The surgeon can be sure that the hole is satisfactorily closed when the ebullition of ether ceases. The joint is not washed out. Finally, the skin wound is closed with interrupted sutures of silkworm gut. Before tying the last skin suture, 1 or 2 drams of flavine or brilliant green, a 1 in 1,000 solution, are injected into the wound and included. A dressing and firm bandage are now applied. The tourniquet is removed, and the limb is put upon a back splint and foot piece with lateral splints. a pressure pad being placed in the popliteal space to obliterate the posterior pouch, and lateral pads to occlude the route from the anterior to the posterior pouches. The limb is then slung just free of the bed and is suspended from a Balkan support. After treatment, the joint at the end of 24 hours is distended, but not painfully so. At the end of 48 hours, the distension is less, and after 4 or 5 days, there is no fluid to be detected in the joint, and by this time, the temperature is usually normal. The joint is kept absolutely immobile for 3 weeks, the stitches being removed on the 8th day. The reactionary fluid in the joint following operation is no indication for further interference in the form of aspiration. As a rule, we do not disturb the dressing for 4 or 5 days, unless the temperature keeps unduly high. At the end of 3 weeks, gentle massage is commenced, and the patient is allowed up on crutches with the joint still immobilized. Gentle movements are commenced at the end of a month, and the patients are allowed to walk. At the end of the 5th or 6th week, full range of movement has returned, and the patients are discharged to a convalescent depot. Of 31 consecutive cases of knee joint injury treated by the method recommended above, in which the joint fluid without exception showed infection to be present, only 1 case progressed to separation. The remaining cases were up and about at the end of the 6th or 7th week, and there was no need for them to leave the country. The whole treatment aims at putting the joint under the best conditions to cope with what infection remains. This scheme of treatment is based upon the careful examination of early failures, for every joint was most carefully investigated after amputation in order to see where any mistake lay. It was found that infection of the posterior pouch was the invariable bugbear, and we now think that its prevention is possible if the wound does not originally involve the posterior aspect of the joint. By obliterating the posterior pouches and the route of infection from the anterior to the posterior pouches, and this we have after several experiments performed post-mortem, found both possible and simple, infection may be limited and arrested. To sum up, 1. Relieve intra-articular tension at the earliest possible moment. 2. Excise the wound en masse and remove the foreign body. 3. Close the perforation in the synovial membrane and capsule. 4. Close the wound in the skin, including an antiseptic. 5. Slightly flex and absolutely immobilize the joint. 6. Obliterate the posterior pouches by a pad placed in the popliteal space. 7. Obliterate the lateral communications between the anterior and posterior pouches by lateral pads. 8. Sling the limb on a Balkan support. 9. Don't be in a hurry to aspirate if the joint becomes distended after operation. Always be guided by the temperature and pulse. One need only have apprehensions if the bacteriologist reports the presence of Streptococcus pyogenes in the aspirated fluid. 10. Be scrupulously aseptic. When, once the knee joint has progressed to a suppurative arthritis, and especially if Streptococcus pyogenes be present, then it must be opened, and no small incision will suffice. Lateral incisions must be employed, which will enter the joint cavity at the level of the lateral reflections of the synovial membrane, and must extend from top to bottom of the synovial cavity. It is useless to make the incision farther forward, as by this means a sump is left in which pus stagnates. The posterior pouches must next be opened, and this is best accomplished by thrusting a large pair of Spencer Wells or sinus forceps backwards along the route of communication between the anterior and posterior pouches until their points can be felt beneath the skin, and then cutting down onto them. After washing out the entire joint, first with saline and then with Usol, Carroll's tubes are introduced, 4 anteriorly and 2 posteriorly, and the limb is put up on a Thompson's knee splint with extension. A dressing is then applied, and hourly installations of the hypochlorites are carried out. When, once the joint has progressed to this degree of infection, ankylosis is almost inevitable, hence a stiff joint must be aimed at. If, in spite of treatment, suppuration is still going on, or if suppuration has become extra or periarticular and secondary hemorrhage be likely, Or, if, as is usually the case when infection of the posterior pouches has occurred, septicemia be threatening, and especially if large serious wounds complicating exist, then amputation should be performed. If the missile be lodged in bone, in such a position that its extraction may add to the risk of causing a suppurative arthritis, it is best left alone, for it can always be extracted later, when the knee joint has recovered. We have adopted this practice in several cases, and seen no reason to regret it, as infection of the joint from the presence of a foreign body in the bone has not occurred, at any rate as late as the end of the 3rd month after injury. If, on the other hand, the foreign body is easily accessible and can be removed without risk, this should always be done. If bone is severely fractured, treatment will depend upon the conditions actually present. Should the patella be the bone involved, and should it be very comminuted, then it is best to remove it altogether. If the articular ends of the tibia and femur are comminuted, then the choice of operation lies between excision or amputation. We have performed excision in a small number of cases, but abandoned the practice, as our results did not justify the procedure. Amputation is indicated in the following conditions. 1. Excessive comminution of bone involving more than 3 inches of continuity. 2. Septic arthritis or periarthritis, which is threatening to progress to septicemia. 3. Wounds of a severely lacerated type in which the main artery and nerves have been irretrievably damaged. 4. Severe secondary hemorrhage, the result of periarticular sepsis. Out of a series of 115 cases of knee joint injury, all of which were, without exception, the result of high explosive and shrapnel, there were 18 deaths. This gives a mortality of 15.8%. 73 of the total had other wounds complicating, and 20 cases came to amputation. In other words, an amputation percentage of 17.9. 55 of the series were associated with damage to bone, the remainder being penetrating or perforating wounds of the soft structures. End of Chapter 17, Part 2. Recording by Jill Engle. Chapter 17, Part 3 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jill Engle. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 17, Gunshot Injuries of Joints. Part 3. Injuries of the ankle joint. Anatomical considerations. The ankle joint is a mortise or hinge joint containing one uncomplicated synovial membrane. Anteriorly and posteriorly, the synovial cavity presents an uncomplicated pouch which occupies a transverse position with regard to the foot. Externally, the inferior tibiofibular joint is provided with a synovial membrane, and this bursal sac is apt to become infected in gunshot injuries involving the external aspect of the ankle joint. In close proximity to the ankle joint are the astragalo-scaphoid and the astragalo-calcanean joints, while in close relation to the inner aspect of the joint are the posterior tibial artery, vein, and nerve. The ankle joint is surrounded by an arterial anastomosis. Frequency. Out of 2,000 consecutive cases seen at a base hospital, there were 40 cases of injury to the ankle joint. This gives a percentage of 2. Nature of injury. Wounds involving the ankle joint almost invariably involve fracture of bone. Thus, the internal malleolus or the external malleolus may be shot away, detached, or comminuted. Again, wounds involving the ankle joint may similarly involve the tarsal and metatarsal joints, and may be most extensive in nature. Frequently, tendons of the muscles in close relation to the inner and outer aspects of the joint are contused, torn, or completely divided. Infection. The ankle joint is probably less prone to infection than any other joint in the body, though when infected, the same organisms are met with. B. coli has been a very constant organism in association with wounds of the foot and ankle joint. Treatment. A. On the battlefield. The leg should be placed on a splint constructed in such a way as to keep the foot at a right angle. A modification of the old box splint made from 2 pieces of ration box and a sandbag will answer all requirements. The wound should be dressed with a first field or shell dressing and the foot fixed at a right angle by means of a putty. The patient may be given 1/4 grain of morphia hypodermically and then carried down to the advanced dressing station. B. At the casualty clearing station. Unless the wound is severe, the patient, after the wound has been inspected and dressed, may be sent direct to the base. If, however, the wound be extensive, it should be excised, a Carroll Dakin dressing applied, put up in a Robert Jones crab splint, and sent to the base. C. At the base hospital. Treatment will depend upon the position and nature of the wound and the degree of infection of the joint. If the internal malleolus be damaged and the joint definitely infected, it is best to remove the malleolus subperiosteally. If, on the other hand, the external malleolus is fractured, together with the lower end of the fibula, a not uncommon occurrence, then subperiosteal resection of the lowered, fractured end of the fibula is the operation of choice, for then the inferior tibiofibular articulation is exposed. When the infected joint cavity is by these means exposed, Carroll's tubes are put into the joint, one anteriorly and one posteriorly. An hourly installation of the hypochlorite solution is carried out. It frequently happens that wounds of the ankle joint which have been excised at the casualty clearing station, and in which the Carroll Dakin treatment has been started at once, do not give rise to infection of the synovial membrane. By continuing the Carroll Dakin treatment at the base hospital, the wound into the joint, even though it involves bone, becomes shut off from the exterior by adhesions which rapidly become covered with young granulation tissue. As soon as the external wound is surgically sterile, 2 organisms to 5 fields, secondary suture is performed, and the greater number of these sutures have healed per primum. Should the joint be wounded from behind and be infected, then division of the tendo Achillis gives an excellent approach to the joint cavity, and sterilization can be effected through the posterior wound. 5 such cases did excellently, for the joint and wound were sterile at the end of the 10th day. Secondary suture was performed, the wounds healed per primum, and the patients recovered perfect movement. Joints sterilized by subperiosteal resection of the internal or external malleoli have also done remarkably well, and the end results of 15 cases gave perfectly movable joints in 9, stiff joints with partial movement, which was improving in 3, while the other 3 cases are still under treatment. If, despite all efforts, the joint condition is unsatisfactory and slow of sterilization, and this obtains when the infection is streptococcic in origin, then astragalectomy gives the best results. Should the X-rays show fracture of the astragalus, then infection of the bone is almost certain to be present, and astragalectomy is the best practice. Astragalectomy, then, is called for in cases of virulent infection of the joint, where the joint is slow to sterilize and the cartilages are becoming involved, and also in cases of infected fracture of the astragalus. When the astragalus has been removed, the wound is left widely open and treated by Carroll's method until sterile, when it is sutured. During sterilization and after suture, these wounds are best nursed in a Jones crab splint, as the foot can always be kept at a right angle and inverted. Should the ankle joint be hopelessly disorganized and form but part of an extensive wound of the foot which is highly infected, then amputation in the lower third of the leg is the only treatment. During the period of sterilizing the wound, it is most important to see that the foot is kept at right angles, or in slight dorsiflexion, and inverted. As soon as the wounded man begins to walk or bear weight on the foot, the sole of the boot, and also the heel, must be raised on the inner side, and he must be made to walk with his toes turned inwards. This is a most important precaution, as neglect of this will lead to deformity and disability. Of 40 cases of gunshot injuries of the ankle joint, all of which were caused by high explosive, 3 necessitated amputation, 8%, 28 recovered with good movable joints, and the remaining 9, which show stiffness, are still under treatment. There was not a case of ankylosis. The tarsal and metatarsal joints. Wounds of the tarsal joints are amongst the most difficult of any to sterilize. The synovial membrane of the tarsal joints is a complicated sac, and when once infection has established itself, it is very difficult to eradicate. These wounds are most frequently associated with fracture of the tarsal and metatarsal bones, and are but part of one extensive wound. It is very rare to see one of these wounds in which infection is not firmly established by the time the base hospital is reached. Like wounds of the ankle joint, they rarely threaten life by general infection, but they lay the patient up for a considerable period and require much attention in order to get rid of the local infection. Treatment. A. On the battlefield. After application of the first field or shell dressing, the foot should be put up and immobilized in the same way as recommended for injury of the ankle joint. Morphia, a quarter grain, may be given to relieve pain. B. At the casualty clearing station. It is at this unit that early surgical treatment should be given. After thoroughly cleaning the skin, cutting and scrubbing the toenails, and cleaning in between the toes, turpentine cleans the feet probably better than anything else, and shaving the leg, the wound should be excised, and any fractured tarsal or metatarsal bones should be at once resected. After procuring hemostasis, a Carroll-Dakin dressing should be applied and the patient evacuated to the base. Cases in which this early treatment has been carried out have done well, sterilized quickly, and allowed of the wound being closed. The end results have been good, and the average time before weight can be borne on the damaged foot has been 7 to 8 weeks. Cases in which resection of damaged bone has not been carried out have hung on indefinitely. Sinuses have formed, and from time to time sequestra have come away. It is weeks before these patients can put their damaged feet to the ground, and the end results have been stiff, painful, and useless feet. C. At the base hospital. Sterilization of the wound is carried on at the base hospital, and secondary suture is performed where practicable. The foot is nursed on a Jones crab splint, and later, when the patient gets up onto crutches, a Sayers apparatus is substituted. The boot should be crooked in exactly the same way as recommended for injuries of the ankle joint before the patient starts to bear weight on the foot. And throughout the treatment, it is of the utmost importance to keep the foot at right angles and inverted. If the metatarsus and tarsus are hopelessly mutilated, with tendons, nerves, and arteries divided, so that the foot is one stinking mass, then amputation through the lower third of the leg is the only remedy. The shoulder joint. Anatomical considerations. The synovial cavity of the shoulder joint is a large bursal sac with one annex, the subscapularis bursa. The cavity is traversed by the tendon of the biceps brachialis muscle, and the tendon of the subscapularis muscle is plainly seen from within the joint cavity. In close relation to the shoulder joint are the acromioclavicular articulation, the subacromial bursa, and the main vessels and nerves of the upper extremity. The joint is extremely lax, and as soon as air is admitted to its interior, the head of the humerus tends to fall away from the glenoid cavity. This is an advantage from the point of view of sterilizing the joint when infected, as it will be seen from the accompanying figures that the synovial cavity under these conditions forms a sump. Frequency of occurrence. Out of 2,000 consecutive cases of wounds, there were 30 wounds of the shoulder joint. This gives a percentage of 1.5. Nature of wound. Wounds of the shoulder joint may be penetrating or perforating, complicated or uncomplicated. Penetrating wounds are the result of high explosive or shrapnel, rarely of rifle bullets. Soft parts or bone may be involved. In the case of bone, the injury may range from a clean perforation of the head of the humerus to comminution of varying degree. The glenoid cavity has been very rarely involved. Perforating wounds of the shoulder joint are interesting. Many cases are now on record, and are far from uncommon, in which the shoulder joint has been perforated antero-posteriorly by a small missile such as a rifle bullet or small piece of grenade. The head of the humerus, which seems to show what might be termed as immunity to comminution, is usually cleanly perforated, and but little disability results, the patient showing good movements at the end of 3 weeks. It is difficult to explain why it is that the head of the humerus is so seldom comminuted as the result of gunshot wounds, but it is a very noticeable fact, for we have seen it repeatedly perforated by such missiles as revolver bullets, pieces of grenade, and even pieces of shell and shrapnel balls, without any comminution taking place. Perforating wounds of the shoulder joint from side to side are more complicated, for the missile, after perforating the joint, may not emerge from the body, but come to rest in the thoracic cavity, the root of the neck, or even the face or head. Wounds of the shoulder joint may be complicated by damage of the acromioclavicular articulation, fracture of the acromion process, or fracture of the clavicle. More extensive wounds of the shoulder may result in laying the joint widely open and the carrying away of large pieces of tissue. Thus, the acromion process, the outer end of the clavicle, and part of the head of the humerus, together with the soft structures clothing them, may be carried away completely by a large piece of shell. In a number of instances, the upper extremity has been completely torn away from the trunk through the shoulder joint. This has occurred as a result of the burst of a Minenwerfer. The changes seen in the joint as the result of infection differ in no respect from those seen in other joints, and the organisms of infection are the same. Treatment. A. On the battlefield. The joint must be immobilized by fastening the arm to the side by means of a putty or triangular bandages and bandaging the forearm to the front of the chest. After a dressing has been applied, the wounded man can walk to the advanced dressing station. B. At the advanced dressing station or field ambulance. The dressing should be inspected, and also the condition of the circulation in the hand. If everything is satisfactory, the patient is sent on to the casualty clearing station. If, on the other hand, the limb is badly mangled and there is no circulation or feeling below the lesion, amputation should be performed without delay and a Carroll-Dakin dressing applied. We are absolutely convinced that the sooner amputation is performed in the case of hopelessly mangled limbs, the better. For cases we saw at a casualty clearing station during the Somme offensive in 1916, which had been so treated at the field ambulances, did far better than similar cases in which the mangled limb had been left on until the casualty clearing station was reached. C. At the casualty clearing station. Small penetrating wounds of the shoulder joint can be safely left until the base hospital is reached. The skin around the wound should be thoroughly cleaned and the axilla shaved. The arm is then bandaged to the side and the patient at once sent to the base. Should the missile have entered the root of the neck or chest, the shoulder wound need not be touched, as the majority of these cases, if the wound of entry be small, run an uncomplicated course so far as the shoulder joint is concerned. Under these conditions, the treatment should rather be directed to the chest lesion or to any damage that may have occurred in the neck, such as hemorrhage, etc. The missile should be carefully localized with the X-ray, and if feasible, it should be removed. If, however, the missile is lying in the joint cavity, it must be removed under the strictest aseptic precautions. Small penetrating wounds of the shoulder joint taking an antero-posterior course should be left alone. The skin around the wounds should be thoroughly cleaned and the arm bandaged to the side. Larger wounds of the shoulder, of the lacerated type involving bone, should be excised and a Carroll-Dakin dressing applied. If the head of the humerus be comminuted, the question of excision arises. We are of opinion that excision of the head of the humerus, however comminuted, is wrong practice. We have witnessed the end results of a number of these cases at a base hospital, where excision of the head of the humerus for comminution have been performed at a casualty clearing station, and in every case, without exception, the results, both immediate and remote, were most unsatisfactory. Some cases contracted osteomyelitis of the humerus. Others suppurated indefinitely, large sequester coming away, leaving the patient with a flailed joint, whilst others, through extensive formation of fibrous tissue, developed neuritis and trophic conditions in the limb. We never saw these complications occur when the head of the humerus, though comminuted, had been left alone. It is quite sufficient treatment to excise the wound thoroughly, leave the joint open, and into the depths of its cavity insert 1 Carroll's tube. A Carroll-Dakin dressing is then applied to the excised wound, and the patient is sent to the base with his arm bandaged securely to his side. If the acromion process is badly fractured, it is best to remove it, as this renders the sterilization of the joint all the easier. Should the damage about the shoulder joint be irretrievable, and the circulation and sensation of the limb absent, then disarticulation should be performed, and a Carroll-Dakin dressing applied to the open stump. D. At the base hospital. The day after arrival at the base hospital, the dressing is changed and the limb is put up on a Thomas's straight arm splint with extension. The Carroll-Dakin treatment is continued, and at the end of the 4th or 5th day, the joint cavity becomes shut off from the wound by adhesions, over which grows young granulation tissue. The wound becomes sterile at the end of the 10th to 14th day, when secondary suture is performed. We have not found it necessary in a single case to excise the head of the humerus, however comminuted. After suture of the wound, the arm is still kept abducted for another fortnight or 3 weeks. The stitches are removed at the end of the 10th day. Between the 4th and 5th week following injury, the splint is removed under an anesthetic, and the arm is brought down to the side. This necessitates the breaking of 1 or 2 friable adhesions. All movements of the shoulder joint are performed once the patient is under the anesthetic, and the arm is put in abduction for another week. At the end of this time, massage and passive movements are begun, and the results have been surprisingly satisfactory. The shoulder joint appears to be the easiest joint in the body to sterilize, probably on account of the simple nature of its synovial cavity, and this despite comminution of the head of the humerus. Wounds in this region, which certainly 18 months ago would have undergone disarticulation at the shoulder joint, have, when treated by the Carroll-Dakin system, given most astounding results, not only in rapidity of sterilization and secondary suture, but also as far as movement is concerned. The complications to be feared in extensive wounds of the shoulder joint are ankylosis and osteomyelitis. We have only seen osteomyelitis follow excision of the head of the humerus while the wound was septic, while ankylosis has not occurred in any of our cases. Should osteomyelitis supervene and threaten life, then amputation is the only treatment. The elbow joint. Anatomical considerations. The synovial cavity of the elbow joint is complex in variety, comprising 1 large bursal sac for the humeral ulnar and radiohumeral articulations, and an annex for the superior radioulnar articulation. The humeral ulnar and radiohumeral cavity is divided into spacious anterior and posterior compartments by the articular ends of the bones. The superior radioulnar articulation is surrounded by the orbicular ligament, which is in close apposition to the lateral articular surface of the bone. In close relation to the elbow joint are the brachial artery, the ulnar and median nerves, and the termination of the musculospiral trunk, and a rich arterial anastomosis surrounds it. Movements of flexion, extension, pronation, and supination are permitted at this joint. Frequency of occurrence. From 2,000 consecutive cases of wounds, there were 42 cases of injury to the elbow joint, giving a percentage of 2.1. Nature of injury. Wounds of the elbow joint are either lacerated, penetrating, or perforating, and practically always involve fracture of bone. Any of the bones entering into the formulation of the joint may be involved. Thus, one of the condyles of the humerus may be detached. The olecranon process may be fractured. The head of the radius may be comminuted, or the whole joint may be carried away. Dislocation of the elbow joint has not been uncommon. It may either be simple or compound, is usually caused by the falling in of a dugout or the parapet, and is usually associated with fracture of the coronoid process of the ulna. The ulnar or median, or the terminal divisions of the musculospiral nerve, may be contused, torn, or completely divided. giving rise to paralysis corresponding to the distribution of the injured nerve. In a few cases, the whole joint cavity with the soft structures surrounding it is so lacerated and disorganized that the whole of the forearm is one useless dead mass requiring amputation. Infection of the elbow joint differs in no way from that of other joints, for precisely the same organisms have been isolated. Complications. Immediate complications are 1. A spreading or localized periostitis about the lower end of the humerus and the upper end of the ulna. 2. Osteomyelitis and septicemia. 3. Paralyses. 4. Hemorrhage. Remote complications are 1. Stiffness and limited movement. 2. Ankylosis. 3. Deformity. 4. Wasting of muscles and trophic phenomena in the forearm and hand. Spreading or localized periostitis has occurred in 5 cases. The humerus is the bone usually involved, and the condition appears to be of a persistent kind. Osteomyelitis and septicemia are rare complications of wounds of the elbow joint, and we have not seen a case. This is probably explained by the comparatively simple nature of the synovial cavity of the joint, and the ease with which it can be sterilized. Paralyses have not been infrequent, and have been chiefly confined to the ulnar nerve and the divisions of the musculospiral. Hemorrhage has been a rare event since the adoption of the Carroll-Dakin process. Stiffness and limited movements are very apt to follow injuries of the elbow joint. Limitation of flexion and extension, and of the movements of the superior radio-ulnar articulation, especially inability to supinate the forearm fully, are the common sequelae. This may be due to either intra-articular or extra-articular causes, or both. If a wound has been open and granulating for some length of time, much fibrous tissue is formed around the joint, which will seriously limit movement. Again, if a fracture of the lower end of the humerus or the coronoid process of the ulna has occurred, then flexion may be impossible above a certain point. Ankylosis and deformity may occur owing to the joint having been fixed in a faulty position. This is, unfortunately, not a rare event. Wasting of muscles and trophic phenomena will follow when the large nerves of the forearm have been torn or completely divided. Treatment. A. On the battlefield. The arm, after a dressing has been applied, should be put up on an internal angular splint if this is available. 2 pieces of ration box will usually serve the purpose well, and the patient should be sent directly to the casualty clearing station. These patients can usually walk, hence there should be no delay in getting them out of the line. B. At the field ambulance. Nothing further need be done at this unit, unless the limb below the injury is dead and useless. If this be the case, immediate amputation should be performed before infection has time to spread. This procedure will also limit the shock occasioned by transport. C. At the casualty clearing station. An X-ray should be taken to ascertain the nature of the damage done and to show the presence and position of foreign bodies. This done, the patient should be anesthetized, the whole limb thoroughly cleaned and the axilla shaved. Further treatment will depend upon the position of the wound. If the wound be on the posterior aspect of the joint and involve fracture of the olecranon process, a not uncommon event, the wound should be carefully excised and sutured. The joint is now opened by an incision on its outer aspect. If the surgeon is satisfied that it is infected, the anterior and posterior sacs of the synovial cavity are opened, and 1 Carroll tube laid into each. The orbicular ligament is next divided, and a 3rd Carroll tube is inserted down to the superior radio-ulnar articulation. A dressing is now applied, and the limb is put up on a Thomas's straight-arm splint with extension. Should the wound be over the inner aspect of the joint, it should be excised, and if feasible, it should be sutured. The joint is opened from its outer aspect, and the rest of the treatment is as described above. If the wound is on the outer aspect of the joint, it should, after excision, be dealt with in the manner already recommended, the newly excised wound being left widely open. By this treatment, every part of the synovial cavity is open and readily permits of sterilization. It is impossible to sterilize an elbow joint through a posterior incision alone, as only the posterior sac of the synovial cavity is accessible. The whole joint must be sterilized, otherwise failure is bound to follow. The only possible approach to the whole of the synovial cavity is by means of an incision on its outer aspect. Extension keeps the articular surfaces of the bones apart, and by these means sterilization has proved both efficient and rapid. D. At the base hospital. The dressing is changed on the day following arrival, and the extension tightened up if necessary. Sterilization is carried on, and at the end of a week the joint cavity is shut off. At the end of 10 or 12 days, the wound is usually sterile, and secondary suture is performed. The stitches are removed at the end of the 10th day, and the forearm is put up in flexion to a right angle and in full supination. Should wrist drop be present, the hand is put on a dorsiflexion splint. At the end of another week or 10 days after the wound is soundly healed, the patient is given an anesthetic, preferably gas, and the elbow joint is moved once to its full extent in every direction. Thus, extension, flexion, pronation, and supination are all performed once, and the joint is finally left and secured in full flexion with the forearm fully supinated, which position is maintained for a fortnight. If wrist drop is present, the dorsiflexion splint is still kept on. At the end of a fortnight, massage is commenced and the patient is encouraged to use his arm. And if wrist drop does not complicate the injury, he is allowed to carry small weights. At this stage, the patient is sent to an orthopedic depot, where further massage and exercises are carried out. We have never practiced excision of the joint soon after injury, for we have never seen any reason to resort to this treatment. We have been concerned in the after-treatment of several cases in which excision of the joint had been performed soon after the injury at the casualty clearing station, and all cases but one were disappointing. We have, since adopting the practice recommended above, never seen a case of ankylosis result. Should such a complication be inevitable, the joint must be fixed in a position just over a right angle, with the forearm slightly more supinated than pronated. We are confident that the whole secret of success lies in an early sterilization and closure of the wound, with the minimum amount of scar tissue formation. The treatment of paralyses, deformity, ankylosis, etc., belongs to the domain of the orthopedic surgeon, but we would repeat that if early sterilization of these wounds were carried out in every case, there would be considerably less for the orthopedic surgeon to do. While in hospital, a paralyzed limb must be massaged, and a dropped wrist must be kept without intermission in the dorsiflex position by means of a splint, the patient wearing a sling. If nerves around the elbow joint are completely divided, they should be sutured at the first operation. End results. Out of 42 cases of wounds of the elbow joint seen from start to finish, 34 recovered with good movable joints. At the end of 8 weeks, flexion was good, and extension, though not complete, was improving. These men were all able to perform useful work. Of the remaining 8 cases, 3 had undergone excision of the elbow joint at the casualty clearing station, and these cases did badly. Of the remaining 5, 1 case required amputation for secondary hemorrhage, while the remaining 4 cases are still in hospital undergoing the routine treatment, 2 of them presenting considerable stiffness and limitation of movement. To sum up, the essentials in treatment are: 1. Excise the original wound as early as possible. 2. Open the joint cavity by an incision on its external aspect if infection is present. Divide the orbicular ligament and insert 3 Carroll's tubes. 3. Put up the limb in extension. 4. Suture when sterile. 5. Remove the stitches on the 10th day after suture. 6. A week later, put the arm in full flexion after performing every movement once. 7. At the end of another fortnight, start massage, passive movements, and exercises. 8. Should wrist drop be present, keep the hand uninterruptedly in dorsiflexion by means of a splint. 9. Massage and electrical treatment for paralyzed muscles. 10. Suture nerves if divided at the first operation. 11. Don't excise the elbow joint while the wound is septic. Carpal and metacarpal joints. The carpal and metacarpal joints possess a complex synovial cavity. The wrist joint, or the joint between the lower end of the radius and the first row of carpal bones, is a simple diarthroidal joint, and in immediate relation, though not always communicating, is the inferior radio-ulnar articulation. This articulation being separated from the wrist joint proper by a triangular fibrocartilage. The carpal joints are formed between the 8 carpal bones and possess a complex synovial cavity. In immediate relation to these joints are the radio and ulnar arteries, the ulnar and median nerves, and numerous muscle tendons. Wounds involving the wrist may be penetrating or perforating and practically always involve bone. Thus, the lower end of the radius or ulna may be fractured, the carpus itself may be fractured, and even some of the metacarpal bones. Perforating wounds of the carpal joints, the result of rifle bullets, have not been infrequent and often heal by themselves. Fracture of the scaphoid bone has also been fairly common in connection with wounds in this neighborhood. Larger lacerated wounds about the wrist may involve nerves, arteries, and tendons, together with bone, and injury to the deep palmar arch often gives rise to most troublesome hemorrhage. Larger wounds of the carpus, though highly infected, are much less difficult to sterilize than corresponding wounds of the tarsus. 20 cases of wrist joint injury occurred amongst a series of 2,000 wounds, giving a percentage of 1. Treatment. A. On the battlefield. The field or shell dressing should be applied and the forearm put up on a straight splint made from a piece of ration box, with a pad under the hand to dorsiflex the wrist. The arm is put in a sling and the wounded man can walk to the advanced dressing station. B. At the field ambulance. Nothing further need be done here unless the hand and wrist are irretrievably mangled, when immediate amputation is called for. The patient should be sent on with as little delay as possible to the casualty clearing station. C. At the casualty clearing station, an X-ray should be taken to ascertain the damage done to bone and to localize any foreign bodies. The hand should be thoroughly cleaned while the patient is under an anesthetic, and the fingernails cut short and scrubbed. Turpentine will be found useful in this connection. The wound should be excised and any detached pieces of bone removed. All bleeding points should be ligatured, a Carroll-Dakin dressing applied, and the wrist put up on a dorsiflexion splint. Any nerves that are divided should be sutured, but divided tendons should be left until the wound is sterile. Any foreign body should be removed. D. At the base hospital. Sterilization of the wound is carried on until a satisfactory bacteriological report is obtained, when secondary suture, if possible, is carried out. The wrist is kept in dorsiflexion throughout. If secondary suture is not possible, the wound edges are approximated by strapping to diminish the wound surface, and skin grafting is carried out later. After the wound is soundly healed, the patient is sent to an orthopedic depot, where massage and finger exercises are provided. Tendon or nerve transplantation can, if necessary, be carried out at a later date. Trophic changes in the skin as a result of divided or damaged nerves must be watched for, and the hand must be kept warm by the use of a woolen glove. End of Chapter 17, Part 3. Recording by Jill Engle.
Chapter 18 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Reading by Matt Perard. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 18. Gunshot Injuries of Bone. Bone injury resulting from gunshot wounds may range from contusion to simple or compound fracture. either of a limited or extensive degree. Simple fracture in this connection is comparatively rare, but compound fractures form a very large proportion of the wounds of the present war. Simple fractures result either from blows with spent pieces of shell or from the falling in of dugouts or pieces of the parapet. They differ from the simple fractures of civilian practice in that displacement of the fragments is greater and contusion of the soft parts is more marked. Compound fractures differ in many details from those observed in civilian practice, in that comminution and splintering of bone are often extreme. There may be considerable loss in bony continuity, large arteries and nerves may be implicated, and there is usually severe laceration of the muscles and of other soft structures. The types of compound fracture most commonly seen are 1. A gutter fracture of bone without destruction of continuity. Such a fracture is usually the result of a glancing blow, and the bone may or may not be fissured. 2. A clean perforation of bone without destruction of continuity, but practically always associated with fissure. 3. A fissured fracture of bone with little displacement. 4. Comminution of bone with or without destruction of continuity. The degree of damage sustained by a bone will depend upon the nature and velocity of the missile and the angle at which the bone is struck. If the bone be struck tangentially by a missile fired at close range, the blow will probably be glancing in nature, and little damage to bone will result, the missile passing on and emerging from the tissues. If, on the other hand, the blow be direct and the velocity high, then severe comminution or splintering of the bone will follow. A rifle bullet fired at close range and striking a bone tangentially may be turned in its course, and though the wound of entry may be small, the wound of exit is large and lacerated. Again, a rifle bullet fired at close range may strike the shaft of a long bone direct, causing severe comminution, and, continuing its course, emerge from the tissues, leaving a small wound of exit. This class of wound shows little tendency to become infected if the fracture is early immobilized. The most serious fractures are those caused by pieces of high explosive shell or bomb. The bone is comminuted, splintered, and in some cases pulverized. Small spicules of bone are scattered broadcast into the surrounding muscles, and on more than one occasion a bony spicule has been the cause of a secondary hemorrhage by eroding its way into a large vessel. The fractured ends of the bone are often displaced, and may be pressing upon the main vessels of the limb. Laceration of the soft structures is usually so extreme that they are scarcely recognizable, and important vessels and nerves may be displaced some distance from their normal position. Again, fracture of bone may involve a joint cavity, either directly or indirectly. Thus, the fracture may itself be part of an injury which involves the joint directly, or a long fissure may run from the site of fracture through the articular end of the bone. Practically all wounds involving compound fracture of bone and caused by high explosive are highly infected, and they are today the most difficult class of wound to deal with, for there is not only the bony injury to consider, but also the extensive destruction and infection of the soft parts. It is also very important to remember that bone as the result of injury has its vitality lowered just as much as, if not more than, the soft structures, and that it is therefore just as prone to infection. Bone, when once infected, is the most difficult tissue of all to sterilize. Complications. Immediate complications are 1. Osteomyelitis. 2. Secondary hemorrhage. Remote complications are 1. Stiffness and limited movement. 2. Deformity. 3. Paralysis. 4. Non-union. 5. Sinus. Osteomyelitis was at one time a frequent sequel of compound fracture of bone. Today, since the adoption of wound excision, perfect immobilization, and the process of continuous sterilization, it is rarely seen. Secondary hemorrhage may be either mechanical or septic in origin. It results either from an imperfect reduction of the fractured ends of the bone or from a detached bony spicule eroding its way into an artery, or it may be due to infection. Stiffness and limited movement are probably the most common sequelae of compound fracture. They are brought about by prolonged suppuration in wounds that have been allowed to remain open indefinitely, and in which, as a result, extensive fibrosis has taken place in the muscles of the wounded limb, with matting of nerves and other soft structures in fibrous tissue. Excessive and irregular formation of callus due to growth of bone from detached spicules which have been driven into the muscles adds to the infirmity. Deformity results from union of the fragments in malposition. Paralysis occur either from laceration or tearing of a nerve, or later result from the nerves being caught up in callus or scar tissue. Non-union may be brought about by prolonged suppuration and a consequent lowered vitality of the patient, by wide separation of the fractured ends of the bones, the result of imperfect reduction and fixation of the fracture, or by the inclusion of soft tissues between the fractured ends. Sinus. The presence of a sinus denotes either bony sequestration or a foreign body. Success in the treatment of compound fracture lies in early sterilization of the wound and secondary suture. By these means excessive formation of fibrous tissue is avoided. Massage and movements can be commenced at an early date. The patient can early be got onto crutches, which avoids prolonged confinement to bed, with the consequent body wasting and other evils. Stiffness and limitation of movement are reduced to a minimum. Union of the fractured bone is hastened, and as a result a number of cases can be returned to duty without leaving the country. The innominate bone. Fracture of the innominate bone may be associated with wounds of the buttock, the upper thigh, perineum, and penetrating wounds of the abdominal cavity. Large wounds of the buttock complicated by fracture of the os innominatum at one time formed one of the most serious and fatal types of wound with which the surgeon had to deal. They are exceedingly prone to gas gangrene infection and are associated with considerable shock. Wounds in the region of the perineum, which are complicated by fracture of the pubic or ischial bones, are apt to involve the external genitalia, the bladder, rectum, and urethra. Penetrating wounds of the abdominal cavity associated with fracture of the os innominatum are serious from the point of view of spicules of bone that are carried on by the missile and inflict severe damage on the viscera. Complications are: 1. Infection of both soft parts and bone. 2. Damage to the external genitalia. 3. Damage to the bladder, rectum, or other abdominal viscera. Owing to the proximity of the wound to the external organs of excretion, infection of a virulent type is almost universal. Gas gangrene infection of large buttock wounds was at one time as fatal a condition as any, while osteomyelitis of the innominate bone was by no means infrequent. Damage to the external genitalia may vary from evisceration of one or both testicles to destruction of the greater part of the organs. Portions of the penis may be carried away or partially detached, or the scrotum may be penetrated or perforated without damage to the testes. Should the wound be situated in the perineum, the urethra may be divided or the bladder penetrated. Wounds of the buttock or perineum may involve the terminal part of the rectum or the anal canal. Treatment. A. On the battlefield. After dressing the wounds, a binder made from puttees should be wrapped around the pelvis and the patient carefully carried on a stretcher to the advanced dressing station, and from this unit he should be sent as rapidly as possible to the casualty clearing station. A quarter of a grain of morphia should be given to relieve pain. Before leaving the advanced dressing station, both his legs should be fastened together and a Liston splint applied to one side. B. At the casualty clearing station, an anesthetic should be administered, and after shaving the pubes, perineum, and anus, the skin should be thoroughly disinfected. If abdominal or pelvic viscera are involved, treatment must be carried out along the lines recommended in the chapter dealing with abdominal injuries. Treatment of the wound. If the wound be situated in the buttock, it should be completely excised and a Carroll-Dakin dressing applied. All loose and dead pieces of bone should be removed, and absolute hemostasis secured before applying the dressing. If the wound involve the external genitalia, treatment will vary with the amount of damage done. Should one or both testicles be prolapsed and partially or wholly eviscerated, and be grossly infected and gangrenous, as is usually the case under these conditions, then single or double orchidectomy must be performed. If the testicle is only prolapsed and not eviscerated, it may be replaced, and after excision of the wound in the scrotum, 1 or 2 sutures may be inserted, a Carroll's tube being included in the scrotum cavity. Should the testes be only partially eviscerated, then the infected eviscerated portion should be removed and the remainder, if healthy, should be replaced. The scrotum can now be sutured and a Carroll's tube included in the scrotal sac. Should the body of the penis be damaged and the continuity of the urethra destroyed, an attempt should be made to suture the defect after excision of the wound if the surgeon is satisfied that the vitality of the distal parts of the organ warrants such a procedure. If the portion of the organ distal to the wound is dead, then it should be removed, and the proximal opening of the urethra should be sutured to the skin. If the wound is situated in the perineum, a catheter should first be passed to ascertain whether or not the urethra is intact. The wound should then be excised. If the urethra is torn, but its continuity not entirely destroyed, it is best to leave it and trust temporarily to a urinary fistula. A Carroll-Dakin dressing should be applied to the excised wound. Should the lower part of the rectum be wounded in association with a compound fracture of the innominate bone, then left inguinal colostomy is the operation of choice, in order to divert the fecal current and bring about sterilization of the wound. After colostomy has been performed, the wound should be completely excised and a Carroll-Dakin dressing applied. The lower limb of the gut can be washed through 6 hourly with half or 3/4 strength Usol. We have employed full strength Usol and seen no harm whatever result from its use. It is very important in the excision of these wounds to remove all loose pieces of bone, and also any portion of doubtful vitality. During the operation, 2 pints of saline solution with sodium bicarbonate and brandy should be administered subcutaneously. As soon as the patient is fit to travel, he should be evacuated to the base. C. At the base hospital. The wounds are dressed on the day after arrival and bacteriologically reported upon. An X-ray is also taken to show the extent of bony damage. As soon as the wounds are sterile, they are submitted to secondary suture. Large wounds of the buttock have given most gratifying results, and out of a series of 40 cases, 34 healed by primary union after secondary suture performed at the end of the 12th day, 12 of these being associated with fracture of the iliac bone. Of the remaining 6 cases, 2 completely gaped and 4 partially. They all eventually healed, and there were no deaths. Wounds about the perineum heal best by granulation, and have not been submitted to secondary suture. Cases in which colostomy has been performed are treated until the wound involving the lower rectum has healed, when a Dupuytren's clamp is applied and the fecal current again established. This done, an ordinary plastic operation is undertaken to close the colostomy wound. This operation was undertaken in 3 cases, all of which did extremely well. The patients have been allowed up on crutches at intervals varying from a month to 6 weeks from the time of receiving their injury. The femur. Compound fracture of the femur at one time formed the most fatal wound of the war. Of a series of 30 cases seen in the firing line in 1915, 18 died and 4 underwent amputation in the trenches, owing to extreme mutilation and the impossibility of immediate evacuation. The 4 cases recovered. Thus, out of the remaining 26 cases, there were 18 deaths, giving the appalling death rate of 70%. The femur may be fractured in any part of its length, and the fracture may involve either the hip joint or knee joint. There is no classical displacement of the fragments, for they may occupy any position, while small spicules of bone may be completely detached and distributed far and wide into the surrounding tissues. Compound fracture of the femur may be complicated by rupture of large arteries and nerves, and excessive disruption and infection of the soft parts is nearly always present. Complications most to be feared are osteomyelitis, septicemia, embolism, and secondary hemorrhage. Associated with compound fracture of the femur may be foot drop, owing to damage of the external popliteal nerve. This should always be suspected, and if present, steps should be taken from the commencement for its correction. Treatment. A. On the battlefield. After application of a field or shell dressing, the limb should be thoroughly immobilized in the position in which it is found. There should be no attempt at reduction. This can be accomplished by means of 2 rifles used as an outer splint, and by pieces of ration box used as posterior, interior, and anterior splints, and secured to the limb with puttees or 3-corner bandages. The damaged limb is now secured to its fellow, and after the administration of a 1/4 grain of morphia hypodermically, the patient is removed with all speed to the advanced dressing station, and thence, with as little delay as possible, to the casualty clearing station. If the limb is hopelessly mangled and attached to the body by a few damaged structures only, it should be severed forthwith and the main vessels tied. B. At the casualty clearing station. Compound fracture of the femur is always associated with severe reflex shock, and severe hemorrhage may have occurred in the line or during transit. The patient should be put to bed, made warm, and 2 pints of saline with brandy and sodium bicarbonate should be administered subcutaneously. When the pulse and general condition have improved, he is taken to the operating theatre, where an anesthetic, preferably open ether, is administered. Another pint of saline should be slowly administered subcutaneously during the operation. When the patient is anesthetized, the splint is removed, the pubes, perineum, anus, and limb are shaved, and the skin of the whole limb thoroughly cleaned. The wound must now be completely excised and thoroughly opened up. All obviously dead and detached pieces of bone, especially detached spicules, should be removed, and also the missile. This done, the wound is stitched widely open, see Figure 219, and propped further open, if necessary, by means of stout rubber tubes. Absolute hemostasis must be secured. Extension is next applied, and for this purpose we have used sterile gauze and Page's glue. The extension should come right up to the wound. See Figure 221. The splint is now applied, the best splint being a Thomas's knee splint or a Wallace-Maybury extension splint. We have usually employed the latter. See Figure 223. Should the wound involve the perineum or buttock, and so render a Thomas's knee splint impracticable, then the splint shown in Figure 225 can be used. Figure 226 shows the splint applied, with a back splint extending from the upper to the lower transverse bars. Extension is taken between the axilla and the stirrup at the foot of the splint. After applying the splint, extension is now made by means of the screw adjustment where such is fitted, and while this is going on the surgeon manipulates the fractured ends of the bones into position, taking care that they do not press upon a large vessel. He should also remove all loose spicules of bone that may be in contact with, or in the neighborhood of, any large vessel. When the fracture is adequately reduced and the reduction satisfactorily maintained, a Carroll-Dakin dressing is applied. See Figures 227, 228. A back splint is now affixed to steady all, and the patient is returned to bed. The patient is sent to the base hospital as soon as possible, with the limb slung from a stretcher bar. C. At the base hospital. The dressings are changed on the day after arrival, and the wound inspected. Before removing the dressing, it is advisable to slightly tighten up the extension, as there is always a certain amount of give in the material which forms it. The Carroll tubes should be changed, and the new ones should reach to every part of the wound, and especially down to and amongst the fragments of bone. A bacteriological examination as to the number of organisms per field should be made, and sterilization of the wound proceeded with. As soon as the wound is sterile, and this in the case of compound fracture of the femur has varied from the 6th to the 20th day following injury, the wound is sutured. At the end of a month, the Wallace-Maybury splint is removed, and a Thomas's knee splint, trench pattern, see Figure 230, is substituted. If foot drop be present, it must be corrected from the start, and the foot must be kept in inversion. If the peroneal muscles are not paralyzed, foot drop may be avoided by the use of a footpiece or apparatus, shown in Figures 231, 232, but its early correction is very important. During the period of sterilization of the wound and the remaining time spent in bed, the thigh will tend to sag, allowing the fractured ends of the bone to unite at an angle. This must be carefully watched for and avoided. It will never happen if the extension is adequately kept up and a back splint, preferably a ham splint, is used to support the limb from behind. See Figure 233. At the end of the 5th or 6th week, the patient is allowed up on crutches. The effect of this is to enhance union by the congestion it occasions in the dependent limb. At the end of the 7th week, massage is commenced, and the patient is sent to be fitted with a caliper walking splint, with which he can manage to get about with the aid of a stick. As union occurs, there is excessive formation of callus, due, no doubt, to the comminution and splintering of the bone. This in time is to some extent absorbed. At the end of 3 months, bony union is firm, and the patient is now allowed to bear weight on the limb. He is then transferred to an orthopedic depot for further massage and exercises. During the period of sterilization, small emboli may occasionally become detached and lodge in the lung. This may give rise to a slight irritating cough, which usually subsides and causes no further trouble. We have only seen this occur in connection with compound fracture of the femur. Secondary hemorrhage, septicemia, and osteomyelitis have occurred exceedingly rarely since the adoption of the Carroll-Dakin method. But should they occur, treatment recommended in other chapters dealing with these complications should be carried out. We have never found it necessary to resort to plating or bone grafting. Tibia and fibula. Compound fracture of the tibia may or may not involve the ankle or knee joints, and fracture of the tibia and fibula may exist separately or in combination. Fracture of the tibia may range from a perforation or fissure to extensive comminution, whereas fracture of the fibula often consists in a small breach of continuity, without excessive comminution. See figures 242, 243. Compound fracture of the lower end of the fibula usually shows a greater degree of comminution, and involves the ankle bone joint. Severe laceration of the soft structures may accompany compound fracture of the bones of the leg, and frequently the anterior tibial artery, second nerve, or the posterior tibial artery, but rarely the posterior tibial nerve, are lacerated and divided. Fractures of the lower third of the tibia are extremely difficult to keep satisfactorily immobilized and in position during sterilization. Treatment. A. On the battlefield. The fractured limb should be thoroughly immobilized by means of one posterior and two lateral splints made from pieces of a ration box. Under no circumstances whatever should any attempt be made to reduce the fracture, but after applying a shell dressing it should be splinted as it exists. The wounded man should be carried to the motor ambulance and transferred to the casualty clearing station with as little delay as possible. He may be given a quarter of a grain of morphia to relieve pain. If the limb is irretrievably damaged, amputation should be performed at either the advanced dressing station or the field ambulance. B. At the casualty clearing station. Shock occasioned by injuries of the leg is not usually severe. Consequently, the patient may be operated upon soon after his arrival at the casualty clearing station. After anesthesia is induced, the splints and dressing should be removed, the pubes and lower extremity shaved, and the skin thoroughly cleaned. Toenails should be cut short and the foot cleaned with turpentine. When this is complete, the surgeon should excise the wound, removing detached and useless pieces of infected bone. Hemostasis should be secured and any divided nerve sutured, if practicable. When this is complete, extension is affixed by means of sterile gauze and Page's glue. See Figure 251. Extension can be taken directly from the foot by means of a leather spat, but we have found this apparatus unsatisfactory. A Thomas's knee splint is now applied, and the extension is regulated by means of a screw adjustment affixed to the lower bar. The extension is tightened until the bones are in position, when a Carroll-Dakin dressing is put on. A ham split is combined with the Thomas's splint, and this steadies all. The patient is then transferred to the base hospital. C. At the base hospital. Continuous sterilization of the wound is carried on until the bacteriologist reports the wound sterile, which is usually from the 10th to the 17th day. At this stage, secondary suture is performed, and the limb is now put up on a back splint and footpiece with lateral splints. If the fracture be situated in the lower third of the tibia, union is usually delayed, and it is difficult to retain satisfactory apposition. Under these circumstances, if the wound is sterile, the fractures may be fixed either with plates or bone grafts. See Figures 252, 253. The cases in which we found it necessary to use plates did well, and no harm came of their use, as union and healing occurred. The stitches are removed on the 10th day, and the limb is kept on a back splint and footpiece for another fortnight. At the end of this period some union has usually taken place, and massage and movements are begun. the limb is put back on the splint with the foot at a right angle and inverted. The patient is allowed up on crutches with the injured limb kept off the ground by means of a strap placed round his neck, on the second or third day following the removal of the stitches. By this means a passive congestion is brought about in the wounded limb, which materially hastens the formation and consolidation of the callus. At the end of the 7th or 8th week following injury, the splint may be omitted, the patient still going about on crutches and putting no weight on the limb. Should foot drop be present, an apparatus for its correction must be worn. At the end of the 10th week, the patient is fitted with a boot, crooked along the inner side of the heel and sole, and is now allowed to put some weight on the limb. At this period he leaves for the orthopedic depot with full movements of the limb, and receives further massage and exercises. Tarsus and metatarsus. Fractures of the tarsal and metatarsal bones were at one time the most difficult of all to sterilize. This is explained by the complex nature of the synovial cavity surrounding them, and by the fact that in our earlier cases we were too conservative. Fractured bone, which later proved to be useless, was left in situ. Sterilization was exceedingly slow, owing to the difficulty experienced in getting the antiseptic to every part of the complex wound. Suppuration was prolonged, and excessive formation of fibrous tissue, with irremediable stiffness and incapacity, followed. Profiting by the experience and advice of the French and Italian surgeons, we adopted new methods, which gave striking results. Treatment. A. On the battlefield. The boot should be removed, and after application of the field or shell dressing, the foot should be fixed at a right angle by means of splints made from pieces of ration box. The patient should be carried to the advanced dressing station. If the foot is hopelessly crushed and its vitality destroyed, amputation should be performed without delay at the field ambulance. Morphia, a quarter gram, may be given before the patient is sent to the casualty clearing station. B. At the casualty clearing station, after anesthesia has been induced, the limb should be shaved and washed. The foot is now scrupulously cleaned, the toenails are cut short, and the sole of foot cleaned with turpentine. The nails are scrubbed with ether soap, and the space between the toes thoroughly washed, and finally cleaned with ether or biniodide of mercury and spirit, while the wound is protected with a swab wrung out of usol. The wound is now wholly excised. Damaged tarsal bones should be removed, and severely fractured metatarsal bones resected. The metatarsal bone of the great toe should, if possible, always be spared, owing to the important rôle that it plays in maintaining the arch of the foot. After procuring hemostasis, a Carroll-Dakin dressing is applied. The foot is put up at a right angle and kept inverted, and nursed on a Robert Jones crab splint. The patient is then sent to the base. C. At the base hospital. Sterilization of the wound is carried out until the bacteriologist reports it fit for secondary suture. If, during sterilization, further pieces of useless bone become obvious, they must be removed without delay. If stiffness and incapacity are to be avoided, sterilization must be rapid and secondary suture performed early, for the longer the wound remains open, the greater will be the incapacity. Since adopting the principle of free removal of damaged bone in the case of the foot, sterilization has been rapid and easy, and excellent function with the minimum of stiffness has resulted. After secondary suture has been performed, the foot must again be put up at right angles and inverted. The sutures are removed on the 10th day, and the patient is allowed up on crutches with his foot which is still kept inverted and at right angles slung off the ground. A fortnight later he is fitted with a boot crooked along the inner side of the sole and heel, and at the end of 6 weeks, that is 3 weeks after the removal of the stitches, he may be allowed to walk in his newly fitted boot, with the aid of a crutch or stick. The scapula. Fracture of the scapula has occurred with great frequency during the present war, and is often associated with penetrating or perforating wounds of the chest. The bone may be either cleanly perforated or comminuted. The body of the scapula is the part of the bone most frequently involved, and very rarely does a fracture of the scapula communicate with the shoulder joint. Treatment. A. On the battlefield. A dressing should be applied, and the arm bound securely to the side. If the chest is involved, the patient should be carried out of the line. If, however, the chest has escaped, he can walk. B. At the casualty clearing station. Treatment will depend upon the result of the X-ray and the nature of the wound of the soft parts. If the wound of entry be small and the chest be penetrated, it is best to adopt expectant treatment and to treat the chest condition. If, on the other hand, the wound in the back be lacerated, the chest often seems to escape penetration, and the missile will usually be found between the scapula and chest wall. In the latter case, operation is necessary. The wound must be excised. Broken pieces of the body of the scapula should be removed, and the foreign body extracted. A Carroll-Dakin dressing is applied and the patient evacuated to the base with the arm bandaged to the side. At the base hospital, when the wound is reported sterile, secondary suture should be performed. The stitches are removed at the end of the 10th day, and at the end of another week movements are commenced and the patient encouraged to move his arm. This class of case has given highly satisfactory results, the majority rapidly regaining full range of movement and being discharged to perform some duty on the lines of communication. It is very essential that wounds in this position should not be allowed to heal by granulation, for by this means a cicatrix results, which will in all probability prevent the soldier from carrying his equipment. The clavicle. Compound fracture of the clavicle may be associated with wounds about the root of the neck or penetrating wounds of the chest. A number of cases die on the battlefield as a result of injury of the large vessels which lie in near relation to this bone. The commonest site of fracture of the bone is the middle third. Displacement is often considerable, but extensive comminution is not common. Treatment. A. On the battlefield. The arm should be bandaged to the side and the shoulder elevated, either with a putty or a triangular bandage. A dressing should be applied and the wounded man sent to the advanced dressing station. B. At the casualty clearing station. The wound should be excised, the fractured ends of the bone manipulated into position, and a Carroll-Dakin dressing applied. Should the X-ray show the presence of a foreign body in the root of the neck, it should be removed. These wounds are sometimes associated with damage of the brachial plexus, but it is not wise at this stage to interfere with the nerve trunks. Should wrist drop be present, it must be corrected. The arm is now put up by Sayre's method, and the patient evacuated to the base. C. At the base hospital. As soon as the wound is sterile, it should be sutured. If the fragments of bone show a tendency to keep apart, it is quite justifiable, when the wound is sterile, to apply a plate before performing secondary suture. The stitches are removed at the end of the 10th day, but the arm is kept up in bandages or other suitable apparatus for another 3 weeks or a month. If at the end of this time the union has occurred, the plate may be removed, and after the wound has healed the patient may go about with his arm in a sling. As soon as union is firm, the sling can be discontinued and the patient may use his arm. The humerus. Compound fracture of the humerus has been of frequent occurrence during the present war, and the fracture in the majority of instances has been both extensive and comminuted. Either the shoulder or elbow joints may be involved, and injury of the musculospiral nerve with wrist drop has been a common complication. In several instances the brachial or superior profunda arteries have been torn and necessitated ligature, yet in this connection we have never seen gangrene of the arm result. The soft structures are commonly lacerated and highly infected. A rifle bullet traveling the limb may leave a small wound of entry and exit, and yet cause excessive comminution of the bone. Osteomyelitis, septicemia, and secondary hemorrhage have been extremely rare complications of injuries of this bone since the adoption of the Carroll-Dakin system of treatment, and the wounds as a whole sterilize easily. The remote complications are stiffness and limitation of movement, both at the shoulder and elbow joints. But since rapid sterilization and secondary suture have been carried out, with the consequent minimal amount of fibrous tissue formation and matting of the soft structures, stiffness and limited movement are becoming events of the past. A rare and later complication of compound fracture of the humerus has been reflex paralysis. The symptoms of this condition are an increased irritability of the intrinsic muscles of the hand, especially the interossei. These muscles, if tapped, contract. Further, the deep reflexes in the tendon surrounding the wrist are all increased. The skin of the hand is blue and the local temperature subnormal. If the hand is allowed to hang down, it becomes hyperemic, painful, and local perspiration follows. The condition is not understood, but it is apt to follow ligature of the brachial artery or damage to the large nerve trunks. The origin of the complaint is supposed by some to be central and confined to the sympathetic nerves, a condition of arteriospasm resulting. French surgeons have attempted a cure by exposing the main artery and stripping it to an extent of half an inch of its sympathetic coat. The artery, when found, is exceedingly small in caliber, and the operation is difficult to carry out satisfactorily. And up to the present, no results from such a procedure have been reported. In some respects the condition resembles erythromelalgia. Treatment. A. On the battlefield. After applying a dressing, the arm should be bandaged to the side and the forearm across the front of the chest. If hemorrhage be present, the bleeding vessel must be picked up and tied. Unless absolutely necessary, a tourniquet should not be employed. At the advanced dressing station, satisfactory hemostasis should be secured, and under no circumstances should the patient be sent onto the field ambulance with a tourniquet applied. Nothing further need be done at the field ambulance unless the limb is hopelessly mangled, when amputation should be performed prior to transit to the casualty clearing station. B. At the casualty clearing station. After thoroughly shaving and cleaning the limb and axilla, the wound should be completely excised and any detached and dead pieces and spicules of bone removed. The foreign body must be found and extracted. A previous X-ray will show its position and the nature of the damage done to bone. Divided nerve trunks, if present, should be sutured. Extension is now applied by means of sterile gauze and Page's glue. This may be applied to the limb and anteriorly and posteriorly or laterally, depending upon the position of the wound. A straight arm splint, Thomas's, is now applied, and extension brought about by means of a screw adjustment which is attached to the lower bar of the splint. Extension is now applied while the surgeon manipulates the fragments into position. As soon as reduction is effected, the surgeon should take care that the fractured ends of the bone are clear of the main vessels and nerve trunks, and that all detached spicules of bone are removed from their immediate neighborhood. This done, a Carroll Dakin dressing is applied, the tubes being inserted down to and amongst the fragments of bone. Under no circumstances should a Carroll's tube be allowed to rest against an artery or a nerve. A back splint is now applied, and the forearm maintained in a position of full supination. See Figure 263. C. At the base hospital. When the wound is reported bacteriologically sterile, it is submitted to secondary suture, and the stitches are removed on the 10th day. The arm is kept in extension for a month, at the end of which period the wound is healed and some union in the bone has taken place. The patient is allowed up while the wound is undergoing sterilization, that is, on about the 4th day after admission to the base hospital. Plate 8, though slightly inaccurate and exaggerated, will give some idea of the way in which these patients amuse themselves. They can either sit up in a chair with a splint suspended from some suitable contrivance, or they may walk about with a comrade supporting the splint at a right angle to the body. Fractures and wounds both heal and sterilize far more quickly when the patients are up. The patients both eat and sleep better, the nursing is made lighter, and the whole outlook is generally more cheerful for all concerned. At the end of a month, the straight arm splint and extension are removed under an anesthetic. Passive movements of the shoulder and elbow joints are performed once in order to be sure that there is no limitation of movement, and the arm is put up in another kind of splint. Should union still be insecure, the splint shown in Figure 264 may be employed, or the straight arm splint is still retained with extension applied laterally to the upper arm only. See Figure 265. By this means, movements at the elbow joint are permitted daily, while the extension on the upper arm remains undisturbed. See Figure 266. The splint shown in Figure 264 was devised by one of us for the treatment of all fractures involving the upper extremity. A padded crutch hinged at A occupies the axilla. At B is another joint permitting of horizontal movements. The distance from B to C is adjustable by means of a screw. D extension for the upper arm is taken between the padded crutch and the bar C. EF is a horizontal frame hinged at the points H. Extension in the case of a fractured forearm is taken between the points E and F, while the forearm is supported in full supination by metal troughs C. This splint then allows of abduction at the shoulder joint by means of the joint A, rotation of the shoulder joint at joint B, and flexion and extension of the forearm at the joint H. After removing the straight splint and extension and performing movements as described, the forearm is put up at a right angle to the upper arm and must still be maintained in full supination. If the latter precaution is not taken, much disability will result, because the forearm becomes fixed in pronation, and this is very difficult to overcome. Unfortunately, today we see many convalescent cases of fracture of the upper arm and forearm walking about with the forearm in full pronation, and in which any attempt at passive supination causes much pain. In fact, supination is almost impossible. This serious fault requires much time and patience for its correction, if indeed such is possible. The apparatus shown in Figure 267 is one of the best of its kind for correcting the condition. At the end of the 5th week, massage and passive movement at the shoulder and elbow joints can be commenced. The passive movements can all be carried out while the arm is in the splint shown in Figure 264. At the end of the 6th or 7th week, union is usually sound, and the splint may be omitted, the patient using a sling. At this stage the patient may use his arm to do small jobs about the ward, and at the end of the 8th week he leaves the hospital for a convalescent depot with good movements in the injured limb. Fractures of the humerus in the neighborhood of the elbow joint, after sterilization and suture, may be put up on a Robert Jones splint, devised for injury involving the elbow joint. See Figure 270. We prefer, however, to use the splint shown in Figure 264 for all cases. Should wrist drop be present, it must be corrected from the start by means of a splint which should maintain an uninterrupted dorsiflexion. See Plate 8, left-hand figure. The radius and ulna. Compound fracture of the bones of the forearm may occur separately or in combination. They may be associated with damage to nerves and arteries, and the wound of the soft structures may be small and penetrating, or perforating, or it may be lacerated. Wounds of the forearm involving bone may be associated with most troublesome hemorrhage from the interosseous arteries. Injury of the bones of the forearm has in the majority of instances been severe, comminution of a greater or lesser degree being present. The secret of success is, as before stated, rapid sterilization and secondary suture. For the longer these wounds are allowed to suppurate, the greater will be the amount of fibrosis and scar tissue, and consequently the greater the resulting stiffness and incapacity. A complication always to be avoided is cross-union of the fractured bones. Treatment. A. On the battlefield. After application of the dressing, the arm should be put up on a straight splint, and the patient sent at once out of the line. At the field ambulance, nothing further need be done, unless the forearm is hopelessly mutilated, in which case amputation should be immediately performed. B. At the casualty clearing station. After anesthesia has been induced, the splint should be removed and the arm and axilla shaved and washed. The fingernails should be cut short, and the hand and nails scrubbed clean. The wound, if lacerated, should now be excised, all detached and useless pieces of bone removed with the missile, hemostasis secured, and extension applied. We have always used a Thomas's straight arm splint for these fractures, applied in exactly the same way as for fracture of the humerus, the extension, of course, being taken from below the site of fracture. The surgeon should be satisfied that reduction is complete, and that all rough fragments of bone have been removed from the neighborhood of the blood vessels and nerves, before he applies the Carroll-Dakin dressing. Any divided nerve should, if practicable, be sutured. The forearm must occupy a position of complete supination. C. At the base hospital. Secondary suture is performed as soon as the wound is bacteriologically sterile, which is usually on about the 10th or 12th day following injury. The forearm is kept in extension and in full supination for a month. The patient may get up 3 or 4 days after arrival at the base hospital. At the end of a month, the straight arm splint is removed under an anesthetic, and the splint shown in Figure 264 is substituted. Extension is maintained if the fracture is not consolidated. At the end of 6 weeks, the extension is removed, massage is commenced, and the fracture is put up on anterior and posterior splints with the arm still in full supination. Movements at the wrist and elbow joint should be encouraged, and at the end of the 7th week, the patient may begin to use the arm. Should wrist drop be present, it should be corrected from the start, and this correction must be kept up uninterruptedly. The trouble in these cases seems to lie in a contracted condition of the pronator quadratus, but if the forearm is kept from beginning to end in full supination, this difficulty will be overcome. At the end of the 8th week, the patients leave hospital for the orthopedic depot. Carpus and metacarpus. Wounds of the carpus and metacarpus may range from a simple perforation involving one or more bones to large lacerated wounds complicated by fracture of several bones and damage of nerves and arteries. The nerves most frequently implicated are the median, or ulnar, and the arteries most likely to be divided are the radial and ulnar, if the wound be about the wrist, or the palmar arches if it involve the hand. Treatment. Treatment aims at rapid sterilization combined with conservatism. No more bone than is absolutely necessary should be removed, and in this respect treatment differs from that recommended for corresponding wounds of the tarsus and metatarsus. Fortunately, wounds about the hand, if early and thoroughly excised, sterilize quickly by the Carroll-Dakin system, and on the whole most gratifying results have been obtained. A convenient splint for wrist wounds is that shown in Figure 276, the wrist being kept throughout treatment and dorsiflexion. Fractured metacarpals or phalanges should have extension applied, the extension being taken and fastened over the end of the splint. Under no circumstances should a finger be amputated unless it is hopelessly destroyed. As soon as the wound is sterile, it is sutured, if this is possible. If impossible, the wound edges should be approximated in order to diminish the extent of exposed tissue, and what breach of the surface is left should be skin grafted. The finger should never be allowed to become contracted, and this can always be avoided by means of a suitable splint. Massage and exercises should be begun soon after the wound has healed, and the splint should be always replaced. Under no circumstances should the patient be allowed to sleep at night without his splint applied. Later operations will probably be required in the form of tendon or nerve transplantation, and to facilitate the success of these subsequent operations, it is of the highest importance to avoid fibrosis and matting of the tissues, which will always follow if sterilization is delayed. It is essential to hand these patients over to the orthopedic surgeon in the best possible condition for subsequent operation. That is, it must be seen that the wounded structures are not matted up in fibrous tissue. This can only be accomplished by rapid sterilization and suture, followed by massage and exercises. Gunshot wounds of superior and inferior maxillae. A series of 14 cases of gunshot wounds involving the maxillae contained 6 involving the mandible and 8 the superior maxilla. The wounds, on the whole, were of an extensive nature, and in this series there was 1 death. This class of wound may involve the soft tissues of the face, the tongue, the floor of the mouth, the pharynx, the hyoid bone, or the base of the skull. In 2 of the cases, tracheotomy was necessary, as edema of the glottis had occurred, owing to infection of the pharyngeal wall and base of the tongue. The immediate complications are: 1. Falling back of the tongue occurring in association with fracture of the mandible. The patient, on falling asleep, suddenly wakes up, cyanosed and terror-stricken. Consequently, his sleep is fitful and restless. 2. Inability to swallow any form of nourishment. It is alarming how rapidly these patients lose weight during the first 8 or 10 days in hospital. 3. Sepsis of a very offensive nature, and showing a tendency to spread with great rapidity into the submucous tissues. This complication in injuries of the upper jaw involving the pharynx has caused a rapidly spreading edema of the glottis, necessitating, as already stated, tracheotomy in 2 cases. 4. The presence of foreign bodies in the substance of the tongue, causing acute swelling and edema of this organ. We have, in 5 cases, extracted from the tongue pieces of the mandible and teeth. 5. Acute spreading erysipelas. which has been an ever-present danger in all wounds involving the face. 6. Septic pneumonia. A remote complication to guard against is a neurasthenic and despondent state, which is very apt to occur, and when once established is most difficult of treatment. These patients refuse to eat, will not speak unless spoken to, and rapidly go downhill. The danger is best overcome by nursing them in a convalescent ward with wounded men who are waiting to go to England, by encouraging them to roll bandages, or run errands, or to do anything which will keep them employed. These men should never be allowed the use of a looking glass. Treatment of the immediate complications. This in great part should be carried out as soon as the wounded man reaches the casualty clearing station. It consists in thoroughly cleaning the wound in the soft parts, excising as little as possible, carefully paring the skin edges, and suturing both mucous membrane and skin, the former with catgut, the latter with silkworm gut. Special attention should be paid to the corners of the mouth and the lip margins. These must be securely and accurately sutured first, and finally the soft parts forming the cheek, chin, and floor of the mouth should be dealt with, small tubes being left in the most dependent parts. Frequent mouth washes must be used, and a dressing of 10% ichthyol in glycerin may be used as a prophylactic against erysipelas. Should foreign bodies be present in the substance of the tongue, they must be extracted. If cases are left unsutured until they reach the base hospital, they are by this time so extremely offensive and septic that immediate operation is out of the question, and we have been compelled to wait 7 or 8 days before any plastic operation could be undertaken. During this time the patient has gone downhill, and is at this stage in a far worse condition to stand an operation which might have well been done at once at the casualty clearing station. We would, therefore, recommend immediate operation at the casualty clearing station, because the wounds heal in the great majority of cases, and much subsequent suffering is avoided. Treatment at the base hospital has for the first 7 or 8 days been directed to sterilizing the soft parts, and Carroll's method has given both rapid and excellent results. It is exceedingly difficult to feed these men, and in some cases rectal feeding must be resorted to. During the period of sterilization the mouth and tongue require constant attention, and for these a hydrogen peroxide mouthwash is recommended. Sleep has been a difficult problem during this period, as the patient constantly wakes with a start and finds he is choking. This has been in some extent overcome by threading a silkworm gut suture through the tongue and fastening a pair of Spencer Wells forceps on the end of the suture. Another difficulty is that the patient's tongue and pharynx get very dry, and dirty brown mucoid flakes become deposited there, needing constant removal. We have used borax and glycerin for cleaning and keeping these parts moist. When once the wound is reasonably clean, and one may allow some latitude in the case of the mouth, suture is performed. In every case, with one exception, the wounds healed well. Approximation and fixation of the fragments is an important point to consider at this juncture, and every operation has been carried out with the co-operation of the dental surgeon, who has at the time taken a cast and made a dental splint. If there has been no great breach of continuity in the body of the mandible, much can be done by the surgeon towards manipulating the fragments into position before suturing the soft parts. Providing the sutures hold, and in every case but one they have, then the surrounding soft parts form an excellent accessory splint for the broken mandible. A temporary external splint is fixed over all, and careful attention to the mouth and dressing twice daily of the wound with 10% ichthyol in glycerin form the immediate after treatment. The patients are allowed up the day after operation. The way in which they make good loss of weight and the ease with which they sleep after the suture has been performed is surprising. Some cases were able to eat eggs, fish, minced chicken, and bread and butter a fortnight after suture. It is important to see that there is no tension on the sutures approximating the soft parts. It is preferable to perform some flap operation rather than to trust to tension when approximating prepared surfaces. For sutured wounds of the face in which tension has been used will often break down. The patients will always try to talk or to convey their thoughts by expression, all of which will put further tension on the sutures. Lastly, the lips and structures forming the buccal orifice should always be dealt with first, as to ensure a buccal orifice which will neither break down nor contract. Consequently, in this region, mucous membrane must be accurately approximated to mucous membrane, and the line of the lip accurately maintained. If a portion of the lip be missing, then a plastic operation should be undertaken to replace it. Deficiencies in the teeth can be undertaken when the soft parts have become healed and consolidated, and the dental splint must be applied at the earliest possible moment. End of chapter 18.
Chapter 19, Part 1 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 19, Injuries of the Head, Part 1. Frequency of head wounds. Before the introduction of the steel helmet, gunshot injuries of the head were of frequent occurrence and formed a considerable percentage of any sum total of wounds. Human curiosity, which knows no limit, has, through a peep over the parapet, often cost a man his life. Nor is the trench periscope without dangers, for it has happened on several occasions that a bullet turned in its course by this instrument has entered a soldier's head and caused a fatal wound. Trenches are not necessarily safe cover from ricochet bullets, and these missiles have been the cause of fatal head wounds. Soldiers, while taking aim over the parapet or through holes in the parapet, are very apt to get hit in the head with a sniper's bullet. A common type of wound in this connection is that caused by a bullet, which, after striking the rifle barrel, passes on into the soldier's head. Frequently on a cold night, in order to prevent a water-cooled gun from freezing, both friend and foe would empty a portion of the belt of cartridges into their opponent's parapet. Head injuries at night from this cause alone were by no means infrequent. Shrapnel, or any other type of explosive, bursting overhead is probably the commonest cause of head injury, and troops moving through a shrapnel barrage prior to the days of steel helmets would show a high percentage of head wounds amongst their casualties. It is obvious, therefore, that in such circumstances the head is subject to injury almost more than any other part of the body. Anomalies of head wounds. Extensive head wounds involving brain and associated with immediate unconsciousness, if not at once fatal, are invariably so within an hour or two after infliction. Some may reach the casualty clearing station or a base hospital, but we can bear witness that these temporary survivors were but the few exceptions, for by far the majority die and are buried in the line. On the other hand, there are men suffering from penetrating head wounds who have walked a distance of a mile or more in order to reach an advanced dressing station. Some of these cases were heard of later in England doing well after operation at the clearing station or base hospital. Other cases, almost identical as far as the wound was concerned, immediately fell unconscious and either died or left the line in an unconscious condition. One case in particular that comes to mind is that of a sentry who was hit in the middle of the forehead, the bullet emerging in the middle of the vertex. One of us, who was in the next traverse when it happened, and 2 other men present in the same traverse as the injured man, only discovered what had taken place when we spoke to him and received no answer. Immediately after injury he was in the upright position, his head resting over his elbow on the parapet. Death in this case was instantaneous, and much blood was escaping from the superior longitudinal sinus. Instances have occurred of men who, after receiving a penetrating wound of the head, have found their way to the regimental aid post, and while awaiting evacuation have slowly become unconscious. Again, it has frequently happened that a man hit in the head may talk sensibly and recognize his comrades for so short an interval as 15 to 30 seconds before lapsing into unconsciousness. Some cases of perforating skull wounds, with brain and blood exuding from the wound of exit, have left the battlefield in a conscious state, whilst others have been profoundly unconscious from the start. This conscious state has been associated with certain definite planes of the head through which the missile has traveled, and these will be referred to later. Certain points in regard to extensive and fatal head wounds. It is difficult to explain the length of time, sometimes 2 or 3 hours, that some men, though quite unconscious, survive the infliction of the most ghastly head wounds. 2 cases are quoted to illustrate this. A. One man was hit in the head, while in trenches, by a bullet which had ricocheted off the sandbags. The ricochet bullet had carried away part of the calvarium and a very large part of the cerebral hemispheres. What brain remained appeared pulped and useless. Though quite unconscious, this man lived for an hour and 3/4, and during this period the breathing was regular, as also was the pulse, the rate being 100 per minute. A quarter of an hour before death, cyanosis appeared, with the familiar rattle in the throat. The pulse rate at this period became more rapid, and at the end the heart continued to beat for 3 minutes after respiration had ceased. The limbs were flaccid throughout, the knee jerks were present but not exaggerated, and the leg was moved when the skin on the inner side of the thigh was pinched. The plantar response was not tested. The pupils were equal, widely dilated, and inactive to light, but the corneal reflex was present. B. Another man hit in the head with a ricochet bullet, causing an almost similar wound, though with not quite so much loss of brain substance, lived for 2 hours and a half. His symptoms were almost identical with the above, the heart continuing to beat for 2.5 minutes after respiration had ceased. During the half hour preceding death, the breathing showed very irregular phases of apnea and dyspnea, though the respirations by no means conformed to the true Kind-Stokes type. The knee jerks were present but not exaggerated. There was no plantar response and no ankle clonus. The pupils were equal, widely dilated, and inactive to light, though the corneal reflex was present. The remaining cases differed but little from the above so far as could be ascertained from a rapid and somewhat rough examination. The following symptoms were more or less common to all. 1. Regular pulse rate varying from 100 to 120, accelerating before death. 2. Persistence of the heart's action after respiration had ceased. 3. Dilated or unequal pupils, inactive to light, corneal reflex present. 4. Conjugate deviation of the eyes in 3 cases. 5. Presence of knee jerks, which were not unduly brisk. 6. Absence of plantar response and ankle clonus in the cases tested. 7. Cutaneous reflex present in the thigh. 8. Absence of convulsions. 9. Absence of vomiting, but feces and urine were voided. An explanation of the persistence of vital functions in cases so appalling is perhaps to be found in an intact condition of the medulla, pons, and perhaps the subthalamic region, This is but a suggestion, but no postmortems were possible under existing circumstances. These gruesome cases are, nevertheless, interesting in that they furnish proof of respiration and heart's action continuing in man independently of the cerebral cortex, and they further go to prove not only the automatism of these two vital functions, but also that one can exist independently of the other. The condition of the reflexes is also of interest. Nature of head injuries. A wound of the head may involve 1. Scalp, 2. Skull, 3. Brain. 1. Scalp injuries. Scalp wounds are of the contused, incised, or lacerated variety. Contused wounds vary from a bruise of the scalp to the formation of a subepicranial hematoma, and may be associated with cerebral concussion or even cerebral laceration. On more than one occasion, a contused wound of the scalp has been complicated by a fracture of the bony cranium, especially the basis cranii. Unconsciousness may or may not be present, but it is this type of wound that not infrequently occasions hemorrhage from the middle meningeal artery, and this must always be borne in mind. Contused wounds of the scalp usually result from being buried in a dugout, by the parapet, or through being in the neighborhood of an exploding Minenwerfer. Incised wounds of the scalp are usually the result of missiles, blunt instruments such as the butt end of a rifle, bayonets, knives, or other weapons used in hand-to-hand fighting. These wounds vary both in length and depth, from little more than an abrasion to extensive incisions involving all structures down to bone. As a rule, they are of a fairly clean nature and heal rapidly after excision and suture. They may or may not be associated with cerebral concussion or cerebral hemorrhage, and not infrequently they are complicated by fracture of the skull. Lacerated wounds are the result of missiles or heavy hand weapons, such as a weighted entrenching tool handle or the butt end of a rifle. These wounds are most often extensive and dirty, and in some cases the scalp has in great part been torn back, remaining attached by a broad pedicle. Rarely is the vitality of such lacerated scalp destroyed, and excellent results have followed its cleansing, followed by immediate suture. We cannot recall a case in which we saw gangrene of the scalp. Lacerated scalp wounds may also be complicated by concussion, cerebral hemorrhage, or cerebral laceration, and not infrequently by fracture of the basis cranii. 2. Wounds of the skull. These are of almost every variety, but the following are the more common. 1. An intact outer table with a fracture of the inner table. 2. Fissured fractures. 3. Gutter fractures. 4. Depressed fractures. 5. Penetration of both inner and outer tables. 6. Complete removal of bone. A missile impinging on a spheroidal surface, unless it hits that surface perpendicularly, tends to glance off and take a tangential course. This is what happens in the case of the skull. When the blow is perpendicular to the surface at the point of impact, the outer table is first fractured, but before fracture results, the skull, by virtue of its elasticity, in younger people tends to give. In the case of the outer table, where the radius of curvature at the point struck is greater than that of the inner table, nothing further may happen as far as the outer table is concerned. This is not always the case for the concentrical inner table, whose radius of curvature at the point struck is less than that of the outer. Consequently, the inner table may give at a time when the outer table holds, and this is what actually happens in a number of cases. If, however, the outer table is fractured by a perpendicular hit, the inner table has now to bear the force of impact not only of the missile, but also of the fractured piece of the outer table that it carries in front of it. This results not in a simple perforation of the inner table, but in splintering, often of an excessive degree. Thus, in most cases of fractured wounds of the skull, the damage inflicted on the outer table is little indication of that sustained by the inner table, and this is a truth that should never be forgotten. Intact outer table with a fracture of the inner table. As mentioned above, this is not an uncommon occurrence, and the damage to the inner table is apt to be overlooked, as many of these cases are not associated with symptoms. One instance will suffice to show this. Sergeant Blank, hit in November 1915, sustained a scalp wound, which was of the furrowed variety and ran horizontally for a distance of 3½ inches above the right ear. The skull was exposed, and one of us who saw him directly after the injury was satisfied that there was no visible fracture of the skull. He was perfectly well, and after his wound was dressed, he walked to the advanced dressing station 1 mile distant. He was evacuated to England and returned to home duty 1 month later. In April 1916, he rejoined his unit in France, and on the night of his return he was seen by one of us in a typical Jacksonian fit. He was again evacuated to the base, where an operation was performed. An old fracture of the inner table was discovered with callus formation, and this was removed. The operation proved a complete cure up to the present, as we were able to ascertain his history a year later. This NCO never had a symptom, not even a headache, between November 1915 and April 1916. Fissured fractures are seen most frequently in the calvarium and the basis cranii. They may involve the outer table only, but more often both tables are damaged. They are the result of either a glancing blow by a missile or a blow on the head with a heavy instrument. The skull yields to a certain point only when struck with a heavy weapon, and when the bursting point is reached it gives, a fissured fracture resulting. Fissured fractures are not uncommonly associated with large lacerated scalp wounds. They may either be symptomless or, on the other hand, rapidly fatal. When a fissured fracture involves the calvarium, a degree of splintering of the inner table may be present. Gutter fractures. Gutter fractures are caused by pieces of high explosives, sabers, and sometimes rifle bullets. The outer table is depressed and the inner table extensively involved. This type of fracture is perhaps the least fatal of all. Men with gutter fractures, apparently situated over the Rolandic area, have walked from the line to the advanced dressing station and have shown no symptoms at all. One interesting case from a few similar may be quoted. Patient Blank sustained a gutter fracture just in front of his right parietal eminence in December 1915. He walked unaided to the regimental aid post and from there to the advanced dressing station. He had neither headache nor symptoms of concussion. When he reached the clearing station, he had complete loss of power in the right leg. He was trephined at this latter unit and was evacuated to the base 10 days later. The last we heard of him was that his leg had completely recovered soon after arrival at the base. The wound in the scalp had healed and he was marked to go to England. Depressed fractures are perhaps the commonest of skull injuries. They are the result of a hit with high explosive, shrapnel, or rifle bullets, although they may be produced by a blow over the head with a weighted stick or the butt end of a rifle. The amount of damage to bone is variable, but the inner table is, as a rule, severely comminuted. Depressed fractures are usually associated with varying degrees of concussion and frequently with focal symptoms. Penetration of outer and inner tables. This is a very common form of injury and the result of hits by small pieces of high explosive, shrapnel balls, or rifle bullets. Penetration or perforation of the bony cranium may occur, but the damage to bone is invariably the same. The outer table at the wound of entry usually presents a small hole, but the inner table is comminuted. After entering the skull, the missile may come to rest in the brain substance. If this does not happen, the missile continues its course and emerges from the skull, leaving a large comminuted wound of exit, from which blood and brain matter escape. If these latter in and out wounds be associated with immediate unconsciousness, they are invariably fatal. A number of unconscious men with brain protruding left the line, but in every case, and we kept careful notes, the regiment was within a very few days informed of their death, which had usually occurred at the casualty clearing station. It may be taken as a fairly sure guide that if one of these injuries be associated with unconsciousness and a pulse of over 100, then the case is hopeless. Some surgeons can doubtless report recoveries, but recovery is very much the exception. Perforating wounds of the skull may, on the other hand, be associated with consciousness, and though brain be protruding from the wound of exit, a number of such cases have recovered. Some of these men, though conscious at first, may during or after a motor journey to the clearing station become unconscious, yet after operation consciousness has returned and recovery has followed. Thus it is exceedingly important for the surgeon at the clearing station to know whether or not an interval of consciousness, however short, did exist after the injury, and a short note by the regimental medical officer to this effect on the tally is of the greatest possible assistance and importance. Complete removal of bone. Such an injury is almost invariably due to a glancing blow with a piece of shell, though more extensive damage of this kind has occurred as a result of the rending force produced by the explosion of a high explosive shell. The following are instances. Private Blank was struck on the head in April 1917 by a piece of high explosive in the region of the right parietal eminence. The missile turned down a flap of his scalp and carried away a piece of the skull about the size of a 5-shilling piece. The membranes were untouched. He suffered from headache and nightmare, both of which symptoms disappeared entirely after the flaps of scalp had been sutured back into position. Gunner Blank was sleeping in a ground bivouac one Sunday afternoon in May 1915. The enemy suddenly sent a few salvos of high explosive into the camp, one shell striking the ground and exploding 10 yards from his bivouac. He was seen 5 minutes after the shell had exploded by one of us. The top of his skull had been removed almost as cleanly as at a post-mortem, the membranes being quite intact. Though quite unconscious, he lived for 15 minutes. When pieces of the skull have been completely carried away by the missile, the meninges are generally involved. Quite a number of cases have occurred, however, in which the meninges have escaped, and two of the most constant symptoms of this latter condition, so long as the dura mater is left uncovered by the scalp, have been headache and nightmare. 3. Wounds of the meninges and brain. It is rare to find injury of the meninges existing apart from injury to the brain, but injury of the brain may exist apart from injury to the meninges. Wounds of the meninges and brain are the result of 1. An injury to the head not necessarily involving the skull, but contusing the scalp. 2. An injury which opens the scalp but causes no damage to the outer table of the skull. 3. An injury which fractures both tables of the skull. 4. Penetrating and perforating wounds of the skull. Condition 1 may be complicated by cerebral laceration, extradural or intradural hemorrhage, separately or in combination, or by severe cerebral concussion. Cerebral laceration may occur either in that part of the brain situated immediately below the point of impact on the skull, or at a point on the opposite side of the brain, the contre-coup effect. The extent of the laceration is variable, depending upon the force spent in producing it. Extradural and intradural hemorrhage are not at all uncommon accompaniments of head injuries which do not involve the scalp or skull. Extradural hemorrhage is most often the result of rupture of the middle meningeal artery or one of its branches, whereas intradural hemorrhage originates from ruptured vessels, usually veins, in the pia mater. The following case may be quoted as an instance of meningeal hemorrhage where both scalp and skull were intact. Corporal N, RFA, was on September 24, 1917, picked up unconscious. Examination showed that his tongue was not bitten. The next day 2 fits were reported. He regained consciousness but could remember nothing and could not read simple words. On September 29th, he was still dazed, his memory for past events was nil, his speech was slow, and he took a long time to answer questions. On the left parietal area was a painful swelling due to contusion of the scalp. Pupils equal but sluggish to light, especially on the right side. The tongue was protruded to the right, but the cranial nerves were otherwise normal. On October 1st, there was a contraction of the right visual field, the left being quite normal. Blunting to pinprick sense was present over the right side of the face. The deep reflexes were brisk, and the plantar response was flexor. Muscular power of the right side feebler than the left. Later in the day, complete anesthesia and analgesia were present over the right half of the body. This was associated with muscular twitchings in the right arm and complete loss of power on the right side. Finger-thumb reflex absent on the right side. Joint sense in right upper and lower limb were absent, and a stereognosis was well established. Lumbar puncture showed cerebrospinal fluid to be under increased tension, but examination of the fluid was negative. On October 2nd, an operation was performed, and the skull trephined just in front of the left parietal eminence. The hole in the skull was enlarged, and no pulsation of the dura was observed. On opening the dura, a large localized blood clot was evacuated from the precentral and postcentral areas, and a bleeding vessel in the pia underrun and ligatured. The patient made an uninterrupted recovery, and on October 12th sensation had returned, but paraphasia was present. He left for hospitalship a month later, able to walk and look after himself, and completely normal. Severe cerebral concussion, if present, differs in no way from that seen in civilian practice. Cases should be carefully watched, as this condition is not infrequently found to be complicated by hemorrhage. Condition 2, in which the scalp is laid open, but the outer table of the skull remains intact, is one of the most deceptive of head injuries. A case of this type may show either cerebral symptoms or no symptoms at all, and this despite the fact that the inner table has been fractured and the dura injured. Later, however, after intervals of 3 months or more, symptoms of cerebral irritation develop, and damage hitherto latent now becomes manifest. Thus callus formation may have occurred to a sufficient degree to cause pressure on the motor centers, and typical Jacksonian epilepsy results, as was shown in a case mentioned earlier in the chapter. If the meninges are involved, then adhesions may form between them and the cerebral cortex, and these, after organization, may be the cause of cerebral irritation. It may happen, however, that the inner table may escape injury altogether, but extradural or intradural hemorrhage may occur, as exhibited in the above case of Corporal N. Again, the damage to the inner table may be so extensive that not only are the meninges ruptured, but fragments of the inner table are driven into the brain substance. Where the force of the missile has been sufficient to fracture both the inner and the outer table, the damage sustained by the inner table is excessive, and the meninges are usually torn. Fragments of bone are driven into the cerebral cortex, which is lacerated to a degree comparable with the amount of bone carried in and the force of the blow. Symptoms will result compatible with the amount of damage done and the area of the brain involved. Cases do occur, however, in which the meninges are intact, but trephining shows blood beneath the dura mater and absence of cerebral pulsation. In other words, there is abnormal intradural tension, the result of hemorrhage and traumatic cerebral edema. Damaged brain, like other tissues, becomes temporarily edematous, the edema lasting from a week to a fortnight. Edema by itself will produce intracranial tension with either focal symptoms or symptoms of general compression. Penetrating wounds of the skull form a very common class of head injury, the missile most often being some type of high explosive. Rifle and machine gun bullets have not frequently been seen lodged in the brain, but shrapnel balls are not very uncommon, though far less frequent than pieces of high explosive. A missile penetrating the brain carries before it bone, rarely scalp, hair, and perhaps a piece of the soldier's cap, though the latter is not a common event since the introduction of the steel helmet. The track of the missile through the brain is ragged and usually filled with blood clot. There is a disruptive effect which results in a localized cerebral edema both around the track and around the missile. The perforation of the meninges varies in size according to the size of the missile and its velocity, the latter governing the nature and amount of bone damage. The cerebral edema and hemorrhage produced by the passage of the missile into the brain give rise to a varying degree of intracranial tension, from which either local or general symptoms result. If in its course the missile strikes and ruptures a large artery, fatal hemorrhage may result, the patient dying from a rapidly induced cerebral compression. The skull may be penetrated at any point. Thus, the missile may enter anywhere in the calvarium or may traverse the face. Cases are common in which the missile has entered the skull through the orbit, at the same time disorganizing the eye. Less frequently has it entered through the nares or mouth. The forehead is a common site of entry, and in this connection the frontal sinuses have often been involved. We have been concerned in a number of cases where both walls of the frontal sinus have been penetrated, the missile coming to rest in the corresponding or opposite cerebral hemisphere. 2 cases were admitted to hospital in which the missile had entered the external auditory meatus, coming to rest in the cerebral cortex of the opposite side. Perforating wounds of the skull are associated with a greater destruction to brain than are penetrating wounds. This is no doubt due to the greater velocity of the missile and the consequently more extensive damage to bone. The wound of entry may be at any point in the scalp or the upper face, the exit wound depending on the course taken by the missile. From the exit wound, blood and brain are usually exuding. In a number of cases, the missile has traversed the skull, but has not emerged from the scalp. It can readily be felt beneath the scalp, and with it is associated extensive comminution of both outer and inner tables. Perforating wounds may involve both cerebral hemispheres, but there are a considerable number which do not. The whole question depends on the direction of the missile in regard to the position of the soldier's head. Thus a man may be hit in the right forehead, and the missile emerge from his right parietal, temporal, or occipital areas, or from similar areas on the opposite side. Again, he may be hit in the temporal region, and the missile, after a very short intracranial course, emerge 2 or 3 inches farther back on the same side. This latter type of wound was of constant occurrence in the line. Consciousness may or may not be lost, but in the case of immediate unconsciousness caused by a perforating wound of the skull, we have never known a single recovery. We saw many of these cases in the line, and can bear witness that most of them died either instantaneously or before they could be evacuated, whilst in the case of the few who were evacuated, the regiment was informed, without exception, of their death. The cause of death in cases that fall unconscious is no doubt attributable to hemorrhage and excessive destruction of brain substance. Still, it is surprising that numbers do recover where a large amount of brain substance has been destroyed in certain regions, and this information alone is most valuable to the surgeon who undertakes cerebral work, either in civilian or military practice. Post-mortem findings. Post-mortem examinations on fatal cases of head injury have revealed much interesting and valuable information. Deaths have occurred in all grades of head injury, and in the slighter cases, the fatal issue has been the result of other serious wounds complicating. It will be convenient to consider first the post-mortem findings in cases of injury in which the skull is not fractured. The most constant findings are either hemorrhage or cerebral laceration. The dura is usually intact, and the hemorrhage is either extradural or intradural. If extradural, the damaged vessel is either the middle meningeal artery or one of its branches, whereas intradural hemorrhage has most often resulted from ruptured veins in the pia mater. Brain laceration in these slighter cases is small in amount, ranging from slight bruising and edema to an irregular tear of one or more convolutions. Cases have come to autopsy where, in addition to the cause of death, there has been present a scalp wound of small extent and not complained of during life. Removal of the skull cap has shown the presence of a very small hemorrhage beneath the dura, though the skull itself has not been fractured. Extradural hemorrhage is either limited or excessive, localized, or diffused. Thus in the case of a Greek who died half an hour after admission to hospital and 1 hour after injury, the greater part of one side of the dura was separated from the skull, and the space between dura and skull was occupied by an extensive blood clot. In this case, part of the posterior middle meningeal artery lay within a bony canal, and at its point of emergence it had been ruptured. Should the bleeding from the injured vessel be slow, and such may happen where a smaller meningeal branch is involved, then the hemorrhage is most likely to be limited and localized. When hemorrhage is subdural, it has invariably occurred from ruptured veins in the pia mater. Hemorrhage of this kind is either diffuse or localized. Some cases in which symptoms before death were those of general cerebral irritation have shown a thin, diffuse hemorrhage, almost completely covering the hemisphere, whereas others have shown a thin clot, the dimensions of which have been limited by the formation of subarachnoid adhesions, and the latter cases are those in which hemorrhage from the injured vessel has taken place slowly and gradually. When fracture of the skull has occurred, the dura has invariably been torn, except in cases of fracture of the basis cranii and some fissured fractures of the vault. The post-mortem appearances of a fractured basis cranii differ in no respect from those seen in civilian practice, and the fracture may traverse either the anterior, middle, or posterior fossa. In all cases of penetration and depressed fracture, the inner table is much more comminuted than the outer, and the ragged pieces of the former have invariably entered the cerebral cortex, causing variable degrees of cerebral laceration. Both extradural and intradural hemorrhage have usually occurred, the former being of limited and small extent. Cases in which the missile has lodged in the brain show fairly constant post-mortem findings. The tract of the missile in the brain is filled with blood clot containing one or more pieces of bone, usually derived from the inner table. At the end of the tract is the missile, with perhaps a piece of cloth and some hair, though since the steel helmet has been worn and the hair cut short, the latter accompaniments are rare. Around the missile is a cul-de-sac in the brain substance, which is also filled with blood clot. The walls of the tract are ragged, and into their substance small hemorrhages have occurred. The tract walls and the brain substance in their immediate neighborhood are soft and edematous. If the ventricles have been involved, their cavities have been found to be full of blood clot. If the missile has perforated the skull, then the damage to brain substance, though of the same quality as that seen in penetrating wounds, is, as already stated, more extensive. Should meningitis be the cause of death, the post-mortem appearances differ in no way from those of an ordinary acute meningitis seen in civilian practice. The subarachnoid space contains pus, scattered regularly or irregularly over the surface of the hemisphere or hemispheres. The vessels of the pia are congested, and the basal cisterns are full of a purulent or semi-purulent fluid. End of chapter 19, part 1. Chapter 19, part 2 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 19, Injuries of the Head, Part 2. Complications of head injuries. Infection. Speaking in a broad sense, every wound of the brain is infected, but this war has taught us the important truth that the brain and its meninges, if put under suitable conditions, are able to withstand and successfully combat infections of the most virulent kind. Wounds of the brain form ideal conditions for anaerobic infection, for there is a blood clot within a space that soon becomes shut off from the exterior. The subarachnoid space, being nothing more than a large bursal sac, probably possesses powers of resisting infection similar to those of the peritoneum. As soon as the subarachnoid space has been traversed, the perforation helps to form part of the septic tract of the missile. Adhesions, however, are soon thrown out, which glue the wounded edges of the arachnoid, pia, and dura together, so that the subarachnoid space becomes early shut off. The clot filling up the tract in the brain is, however, a dangerously close neighbor to the septic wound in the scalp and skull, and at the bottom of the tract, embedded in clot, is the missile, unless the wound be perforating. The organisms entering the brain are those met with in other wounds and described in previous chapters. Gas formation in the clot has been present in several instances, and the Bacillus perfringens has been isolated. Gas exuding from the brain has a peculiarly offensive and pungent odor, and differs from the smell of gas in other wounds of the body. Patients have been admitted to hospital with this condition who were perfectly conscious, and have shown no other symptoms except perhaps a monoplegia or slight headache. We are quite at a loss to explain why it is that patients suffering from gas infection are for as long as 4 days after injury and before operation apparently well. They eat, sleep, read, and smoke. They do not often suffer from headache, and the most constant symptoms they have shown have been purely focal in type. There is no doubt whatever that the cortex possesses very high powers of immunity, never known to us before this war, against infection of the most virulent type. Cases of acute encephalitis have occurred, but in our experience, out of a large number of cases of penetrating head injury seen from start to finish, they are the rare exceptions. The whole danger seems to lie in infection of the meninges, and if while operating the newly formed subarachnoid adhesions are inadvertently broken down, then a serious risk of meningitis follows. Spreading infection in the damaged skull bones or scalp is a phenomenon practically unknown to us. Cerebral venous sinuses. Infection may spread to the large cerebral venous sinuses, and the thrombosis of these vessels is the result. It is rare to find infection of the sinuses following injury of brain substance. It usually follows an infected wound of the sinus itself. Such a complication is extremely grave, and we have seen no patients recover. One case of thrombosis of the superior longitudinal sinus resulting from a wound examined post-mortem by us showed a partially disintegrated clot which contained gas and had spread backwards into one of the lateral sinuses and reached the jugular vein on the same side. A large abscess was found in the right lung and several small abscesses in the left lung. Another case of thrombosis of the cavernous sinuses showed bilateral exophthalmos before death. Post-mortem examination showed a localized abscess in the right pleura and multiple abscesses in both lungs. The patient died of septic pneumonia. It would seem that infection of the sinuses by organisms associated with war wounds gives rise to a thrombus, which readily breaks down and becomes disseminated as emboli. One case of thrombosis of the lateral sinus before death showed an acute arthritis, probably embolic, of the right knee joint. This case died before the knee joint condition matured. Hernia cerebri is undoubtedly associated with a subacute type of infection. From the wound in the dura, a mass of brain herniates, which slowly gets bigger and is often associated with a large discharge of cerebrospinal fluid. Earlier in the war, this unfortunate complication was common, but today, thanks to a more perfect technique and thorough understanding of cerebral injuries, so admirably brought forward by Colonel Percy Sargent and Colonel Cuthbert Wallace, this complication is a rare event. Intracranial aneurysm. This is a rare complication, and we have been concerned in the treatment of only 2 cases. Both were associated with complete blindness, and in both, the aneurysm occurred between the intracranial portion of the internal carotid artery and the cavernous sinus. Both cases also showed a bilateral pulsating exophthalmos, which underwent spontaneous cure without operation. Symptoms. Immediate symptoms vary from unconsciousness to no symptoms at all. If a man falls unconscious after receiving his wound, he may either show a slow pulse, slow, shallow, and sighing respirations, with pupils semi-dilated, and inactive or sluggish to light, and it may be possible to rouse him to some extent by shouting in his ear; or, on the other hand, he may be profoundly unconscious, with unequal and inactive pupils, and breathing stertorous. The pulse rate in the latter case may be either slow or as high as 110 or 120 beats per minute. Reflexes will vary in these unconscious men. Seen soon after injury, the deep reflexes have been most variable and the plantar response indefinite. It seems that the reflexes do not immediately after injury conform to what is commonly taught, but some time must elapse before they can be looked upon as reliable guides. Flaccidity of the limbs is present in all men who fall unconscious and persists for a few hours. Hence in very early cases, that is to say, in men seen immediately after they fall, the respiration, pulse, and pupils are the important points to note. Should hemorrhage from the nose, mouth, or ears be present, with stertorous breathing and unconsciousness, the symptoms are clearly those of a fractured basis cranii. Aphasia and loss of memory are not uncommon symptoms of head injury, and may be the result of either concussion, shell shock, or more definite organic damage to the cortex, in the region of Broca's area, or the frontal lobes. Hemianopsia, contraction of the fields of vision, or paracentral scotoma, are associated with injury of the occipital lobes. Loss of joint sense and the presence of a stereognosis point to lesions in the post-Rolandic area. Lesions of the precentral or postcentral gyri are associated with motor or sensory changes, and most common, if not the most interesting, are the monoplegias. Associated with the Rolandic lesions is the loss of the finger-thumb reflex. This reflex is obtained by flexing the little and ring fingers acutely on the palm at the metacarpophalangeal joint. In a normal individual, when this is done, the thumb becomes hyperextended and adducted. Should a lesion of the Rolandic area be present, this reflex will often fail. Lesions of the Rolandic area may give rise to symptoms of monoplegia or hemiplegia, or these same symptoms may be caused by a localized hemorrhage of the cerebral cortex. Twitchings or fits are indications of cerebral irritation, and are often more attributable to hemorrhage than to actual damage to brain substance. Wounds of the brain that are from the start symptomless are associated with damage of the silent areas. Later, that is to say, 4 or 5 hours after injury, the altered reflexes become established. In true organic lesions of the motor cortex or the coronal radiata, the deep reflexes are increased, and with this there is often spasticity of the affected limbs. The knee jerks, Achilles jerks, and supinator jerks become exaggerated, especially on the opposite side, and there may be ankle clonus with a one-sided extensor plantar response. Motor power in the muscles of the affected limb, as shown by the grips and movement, may be either very diminished or completely absent. Sensory changes may or may not be present, depending upon whether the postcentral gyrus or its tracts have or have not been injured. Interference with speech and articulation, inequality of the pupils, and loss of memory may all point to intracranial pressure or injury to Broca's area. Protrusion of the tongue to one side, paralysis of the muscles of the eyeball, ptosis, complete facial palsy, deafness, and blindness are important points to note in connection with injury of the cranial nerves. Incontinence has very rarely been an early symptom of cerebral injury, unless unconsciousness be present. Later symptoms are those due to infection, organized injury of the meninges or brain, or callus formation from an unrecognized fracture of the inner table. The earliest symptoms of infection of the brain are headache and vomiting, and an early examination of the fundus oculi may show swelling of the disc with engorgement of the retinal veins. These symptoms are quickly followed by rigidity of the muscles of the back of the neck, the presence of Kernig's sign, squint, and unconsciousness, with incontinence of urine and feces. Infection may follow and take the form of a localized, encapsulated abscess around a missile that has been left in the brain. This abscess may lie latent for as long as 2 years or more without giving rise to symptoms. A few such cases have been reported during the present war. An old injury of the membranes which has become organized and bound to the cortex by adhesions may, if the injury be in the neighborhood of the Rolandic area, give rise to Jacksonian epilepsy, as may also an excess of callus which has formed around the site of a fracture of the inner table. The symptoms of sinus thrombosis are headache, vomiting, and rigors, followed by the dissemination of emboli. Thrombosis of the superior longitudinal sinus may spread backwards to the lateral sinus of one side and thence to the internal jugular vein. Later symptoms are those of pyemia, metastases appearing first in the lungs. In one case of thrombosis of the cavernous sinuses, there was bilateral exophthalmos. Examination of a case of head injury. The regimental medical officer is the first man who can give important information in a case of head injury, and what he must note is whether or not the patient was conscious for any interval, however short, after being hit. He should also note the pulse, the respiration, the condition of the pupils, and the presence of hemiplegia or paraplegia. These few points only take but a minute or so to ascertain, and this small amount of information is invaluable to the surgeon who first deals with the case. On admission to the casualty clearing station or base hospital, the first point to strike the surgeon is the presence or not of unconsciousness, and whether or not the patient can be roused by shouting into his ear. The respiration should be noted as to whether it is stertorous or not, and the pulse rate recorded, whether slow or rapid. Any twitchings in the fingers or toes, or any convulsions should be carefully observed, special note being made as to where the twitching commenced. The wound is next examined, and its character, whether penetrating or perforating, ascertained. The presence of any brain exuding from the wound of exit should be looked for. If the surgeon has the information from the regimental medical officer that a man was conscious after receiving his wound, though he may now be profoundly unconscious, with a rapid pulse, should not deter him from operating. If the patient is conscious, his speech and articulation are noted, and also the condition of the pupils, whether equal, dilated, contracted, or active to light. The fields of vision should at the same time be roughly tested, and any gross contraction looked for. The condition of the remaining cranial nerves is rapidly ascertained by asking the patient to protrude his tongue, show his teeth, move his eyes, close his eyes, and by testing his hearing. Monoplegia, hemiplegia, or anesthesia are next looked for and noted, and the reflexes tested. Spasticity may be present. The reflexes to note are the knee jerk, the Achilles jerk, the supinator jerk, the abdominal reflex, the finger-thumb reflex, and the plantar response. The presence or absence of ankle clonus is important. Hemorrhage from the nose or ears should always be looked for. Finally, the presence or absence of a stereognosis and joint sense is ascertained. When the above examination is complete, and it takes but a short time, the fissures of Sylvius and Rolando are marked out as follows. Take a point 35 mm back along the zygoma from a frontomalar suture, and from there take a point 12 mm perpendicularly upwards from the upper border of the zygoma. This will give the Sylvanian point. Next take a point just in front of and below the parietal eminence. A line joining these 2 points will give, with tolerable accuracy, the marking of the Sylvanian fissure. By the ordinary formula mark out the fissure of Rolando. Having got the surface markings of both these fissures, lay a thin wire along each, fastening it in place with sticking plaster. An X-ray can now be taken laterally and antero-posteriorly. By this means the foreign body can be localized and its position determined, both in relation to the hole in the skull and to the Sylvanian and Rolandic fissures. Diagnosis. A soldier who has sustained a head injury is either conscious, subconscious, or unconscious. If there be no wound of the scalp and no fracture of the skull, an unconscious state is the result of 1. Cerebral concussion. 2. Intracranial hemorrhage, either extradural or intradural. 3. Cerebral laceration. 1 and 3 frequently coexist. The important points to observe in making a differential diagnosis are the condition of the pupils, the nature of the breathing, and the pulse. A slow, shallow, and sighing type of respiration, with equal pupils, not unduly dilated or contracted, and a normal or slightly heightened or lowered pulse rate, point strongly to a state of cerebral concussion. Both light and corneal reflex are usually present, but diminished if the case be one of cerebral concussion. Should cerebral laceration complicate a state of concussion, the symptoms of concussion may be modified, for in addition there may be symptoms of a subdural hemorrhage, varying in amount according to the extent of brain damage. Thus, superadded to symptoms of concussion, there may be signs of cerebral irritation, shown by twitchings or even convulsions. For instance, in one case operated upon for twitchings of the right hand and forearm, the injury being on the right side, it was found that a subdural hemorrhage had occurred as the result of a cerebral laceration on the left side, contre coup, and this is usually what occurs. Cerebral concussion associated with twitchings or other symptoms on the same side of the body as the injury point strongly to cerebral laceration being present. Cerebral laceration may be present in the absence of severe concussion and may involve the brain on the same side as the injury, or the effect may be contre coup. Severe headache, loss of memory, dizziness, drowsiness, restriction of the fields of vision, or motor and sensory symptoms are all strong evidence of laceration with a degree of subdural hemorrhage. Intracranial hemorrhage may or may not accompany cerebral laceration and may be extradural, intradural, or both. Unconsciousness is by no means an immediate sequel of the injury in these cases, and if the medical officer who first saw the case can certify that the wounded man was conscious for any interval of time, this is most valuable information. A state of unconsciousness with inequality of the pupils and stertorous breathing following an injury is almost pathognomic of extradural hemorrhage, the source most often being an injured middle meningeal artery or of its branches. If the bleeding is slow, then the appearance of unconsciousness is delayed. If rapid, then symptoms of compression come on almost immediately. The limb on the opposite side of the body to the hemorrhage may either be flaccid or spastic, and experience goes to prove that the early reflexes are of little value. One case particularly interesting is that of patient blank, hit by a glancing blow over his right temporal region in October 1915. He walked to the regimental aid post and for 5 minutes talked sensibly. At the end of this time he slowly lost consciousness, the pupils became unequal, the right being greater than the left, and his breathing became stertorous. Unfortunately, it was broad daylight, and he could not be moved. As unconsciousness became deeper and signs of compression more pronounced, one of us trephined him in a dugout in the line. An extensive hemorrhage had occurred. The clot was turned out and the bleeding vessel, a branch of the middle meningeal artery, was tied. He was kept in the line for 24 hours and was later evacuated from a field ambulance, having recovered consciousness and done well up to then. Subdural hemorrhage is usually associated with symptoms of cerebral irritability, and the conscious state being frequently present, more rarely unconsciousness. Muscular twitchings, headache, convulsions, violent acts, contraction of the fields of vision, and loss of memory are symptoms associated with subdural hemorrhage. Cases of subdural hemorrhage associated with transient monoplesias or hemiplesias are not uncommon, for with the hemorrhage is present a degree of cerebral edema, the result of the injury. Subdural hemorrhage has rarely been associated with symptoms of cerebral compression unless an extradural hemorrhage coexisted. Unconsciousness with an open wound of the scalp and a fractured skull. If there be an open wound of the scalp with fracture of the skull not associated with penetration, then an unconscious condition may be the result of either concussion or compression, or both. The above remarks as to the differential diagnosis apply equally here. When penetration of the skull has taken place and unconsciousness exists, the X-ray is of great value in determining what damage is likely to have occurred. An almost invariable rule in these cases is, and we have time after time confirmed it both at operation and at autopsy, that if after being hit an interval of consciousness exists, however short, the case is one of hemorrhage. If on the other hand the soldier is unconscious from the start with stertorous breathing and rapid pulse, then extensive damage to brain has occurred. When the missile has penetrated or perforated the skull, an X-ray taken in two directions, with wires laid over the fissures of Rolando and Sylvius, will give with tolerable accuracy the direction of the path of the missile and its depth in the brain, and from these data considerable information is afforded of the damage done. Perforating wounds of the skull with brain protruding from the wound of exit and associated with immediate unconsciousness and rapid pulse denote extensive damage to brain substance and are invariably fatal. The following table may be of some help in the diagnosis of head injuries complicated by unconsciousness. Unconsciousness with a head injury without breach in scalp or skull. Concussion, pupils equal, slow, shallow respirations, pulse slightly slowed or quickened. Cerebral laceration. In addition to concussion, there may be homolateral irritability. Intracranial hemorrhage. Extradural. Unequal pupils, stertorous breathing, slow pulse. Initial interval of consciousness, flaccidity or spasticity of limbs of opposite side. Intradural. Symptoms of concussion, coupled with those of cerebral irritation, such as twitchings, convulsions, etc. Unconsciousness. Head injury with breach of scalp and skull without penetration of skull by missile. Concussion. Fractured bases cranii. Hemorrhage from nose, throat, or ears. Hematoma of upper eyelids and often stertorous breathing with unequal pupils. Hemorrhage with brain laceration and edema immediately below injury. Here focal symptoms or symptoms of cerebral irritability, if such exist, are heterolateral. Head injury with penetration or perforation of skull by missile, an X-ray in two directions, with wires laid on the Rolandic and Sylvian fissures, surface markings, will show the breach in the bone, the position of the missile, and subsequently its path, and from this the damaged tract of brain can with tolerable accuracy be estimated. Subconsciousness is the result of concussion, hemorrhage, or brain injury. It is frequently associated with subdural hemorrhage, but in this case there are present, in addition, symptoms of cerebral irritation. If the condition be due to a slowly progressive compression, then subconsciousness slowly progresses to unconsciousness, and further symptoms of compression slowly follow. If due to concussion only, then consciousness soon returns. Consciousness. Penetrating or perforating wounds of the skull associated with consciousness form one of the most interesting types of war wound. They are often associated with monoplegia, rarely hemiplegia, but they are frequently symptomless. When the patient is conscious, the diagnosis is easier. The first important question that arises is the lesion post or pre-central? If the wound is of the perforating variety, its direction will furnish some idea as to what part of the brain has suffered. If the wound is of the penetrating variety, there is often little indication of the path the missile has taken. The two tests in determining whether the damage done is in front of or behind the Rolandic fissure are the presence or absence of joint sense and of stereognostic sense. If both these senses are normal, then the lesion is pre-Rolandic, but if there be loss of joint sense and astereognosis be present, then the lesion is post-Rolandic. Should the lesion be post-Rolandic, sensory changes and the fields of vision should be investigated. Changes, if present, will point to damage of the post-central gyrus or occipital lobes. Monoplegia of the arm, leg, or face, if the lesion be precentral, will denote injury to the precentral gyrus, while aphasia and loss of speech will point to injury of Broca's area. Loss of memory, mental disturbances, and less frequently headache indicate injury of the frontal lobes. Injury of the optic chiasma invariably causes complete blindness. Hemiplegia may result from injury of the precentral gyrus or the coronal radiata. Injuries involving the internal capsule have invariably been fatal. Injury to the venous sinuses of the brain are either fatal on the battlefield from hemorrhage or are only manifest at operation, though their presence may be suspected from the position of the wound. Depressed fractures of the skull over these sinuses usually prevent hemorrhage, and it is when the fracture is elevated or the broken piece of bone removed that an alarming hemorrhage results. Injuries of the precentral gyrus are frequently associated with absence of the finger-thumb reflex. In all conscious cases, an X-ray should, as above stated, be taken with wires laid on the surface markings of the Rolandic and Sylvian fissures. Complications of head injuries: headache, vomiting, rigidity of the neck muscles, and the presence of Koenig's sign with drowsiness. The temperature rises to 103 degrees or more, a squint may develop, and incontinence may follow. There is one other condition which can simulate these symptoms, and that is cerebral malaria, which is in the East very prone to complicate head injuries. We have in 6 instances been perplexed, for the symptoms appeared so rapidly in patients who were progressing well. In malaria, the onset of symptoms in cases of head wounds has been remarkably sudden, and the temperature much higher than that seen in meningitis, for in 2 cases it reached 107 degrees, and in the remaining cases 105 degrees. Not always the case in uncomplicated cerebral malaria. The patients are either noisy or deeply comatose. Meningitis and encephalitis are of more gradual onset, the temperature is lower, and there is not the tachycardia, cachexia, and cyanosis that one sees associated with cerebral malaria. In the case of meningitis, lumbar puncture, which should always be performed, often clears the diagnosis and benefits the patient, whereas in cerebral malaria, lumbar puncture does not influence, or has not, in a large number of cases treated in this hospital, influenced the condition one way or the other. On the other hand, large doses of quinine given intravenously and intramuscularly, 100 grams in 24 hours, has brought about a magical improvement in desperate cases of cerebral malaria, whereas this drug has no effect on the course of an infective meningoencephalitis. Hernia cerebri is readily diagnosed by a pulsing, protruding mass of brain substance, which continues to increase in size. Infection and thrombosis of the venous sinuses are diagnosed by the presence of rigors, the presence of thrombosis of the internal jugular vein, if the lateral or petrosal sinuses are involved, and the presence of exophthalmos if the cavernous sinuses be affected. An occasional sequel to wounds about the optic chiasma is the formation of an aneurysm between the internal carotid artery in its intracranial part and the cavernous sinus. As stated before, we have been concerned in 2 cases, both being associated with complete blindness and a lateral pulsating exophthalmos. End of chapter 19, part 2. Chapter 19, Part 3 of War Surgery from Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. War Surgery from Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 19, Injuries of the Head, Part 3. Prognosis. The immediate prognosis of head injuries depends almost entirely upon the immediate symptoms and the time that elapses before treatment is undertaken. If after receiving the wound, consciousness be present for any interval, however short, or should a period of consciousness, brief or long, follow immediate unconsciousness, the result of a stun, then the lesion is almost certain to be one of hemorrhage, and if early surgical measures be undertaken, the prognosis is favorable. The wounds of the head not involving a breach in the scalp or skull and associated with unconsciousness following an interval of consciousness are invariably cases of extradural hemorrhage, and if early surgical treatment is forthcoming, the outlook is good. Should symptoms of cerebral irritation complicate a head wound in which neither scalp nor skull are opened, the prognosis is favorable if early surgical treatment is available. When scalp and skull are involved, the immediate prognosis is favorable if the case is seen and treated early. Symptoms may be similar, that is to say, unconsciousness may be present following an interval of consciousness. The longer surgical treatment is delayed, the worse becomes the prognosis in view of septic complications. Should unconsciousness supervene immediately and be associated with stertorous breathing and a rapid pulse, then the prognosis is invariably fatal. Penetrating wounds of the skull associated with consciousness and focal symptoms, such as monoplegia, aphasia, loss of memory, and the like, are of favorable prognosis if early surgical treatment be carried out. We would again call attention to the amount of damage and infection the brain can withstand, and yet in great part recover itself if treated early. Monoplesias, hemiplesias, contraction of the fields of vision, aphasia, and the like, are, in the case of gunshot injury of the head, on the whole of good prognosis. It is not so often the actual damage wrought by the missile that is productive of these symptoms, but the localized cerebral edema that has resulted from the injury. If the intracranial tension be early relieved by trephining and the wound put under the best surgical conditions, the above symptoms subside from the 8th to the 20th day. We have now treated many such cases, and the average time for subsidence of focal symptoms after operation has worked out at 10 days. Fractures of the base of the skull, where early or immediate unconsciousness follows, are of bad prognosis, although we have had recovery in 2 cases as the result of early trephining, but in both of these cases an interval of consciousness had existed. When sepsis is established, the prognosis varies with the portion of the brain infected. If infection has spread to and involved the meninges, the outlook is extremely grave, and but few cases recover. If, on the other hand, the cortex is infected, the infection has shown a tendency to become localized, and on more than one occasion gas has issued from the brain of men who have made complete recoveries, and have shown no untoward symptoms as late as the end of the 3rd month after operation. 2 cases have been heard of 9 months later who have not yet suffered any incapacity. Localized encephalitis, therefore, shows a great tendency to clear up after trephining and evacuation of the blood clot and foreign body from the substance of the cerebral cortex. Spreading encephalitis, though more the exception than the rule, is of grave significance and invariably ends fatally. Thrombosis and infection of the venous sinuses form a very fatal complication, and we have not seen recovery in any case resulting from a gunshot wound. Hernia cerebri, though much less rare than formerly, is a serious complication, but active and efficient early treatment has given such good results that this complication is not today the dreaded sequel of brain injury that it used to be. Silent cerebral planes. Cranial injuries are from many points of view perplexing. While in the line, we saw many cases of perforating head injuries, some remaining conscious after injury, though by far the majority were immediately unconscious and dead before they could be evacuated. Some conscious cases resembled in almost every detail many of the unconscious, so far as the wound was concerned, and this led one of us to make some observations. These observations, gathered from a large number of head injuries seen on the battlefield and taken under the difficult conditions that exist there, must be taken for what they are worth. For there was neither time, nor in many instances was it either safe or advisable to make more refined and accurate measurements. The surface markings that were taken were the nasion, the occipital protuberance, the parietal eminences, the zygomatic process, the external angular process of the frontal bone, and the mastoid processes. From what we were able to observe over a large number of cases, the findings were more than tolerably constant. The planes through which a missile might pass and emerge, although there was evidently extensive laceration of brain substance, with a quantity protruding from the exit wound, are represented in the accompanying figures. A point of entry half an inch above and 1½ to 2 inches outside the nasion, with a point of exit 1 inch above and 1 to 2 inches outside the occipital protuberance, either on the same or the opposite side, form 2 of the silent tracts. The distance of the point of entry and exit varies within limits of 3/4 of an inch. These, then, are 2 silent planes. A point of entry in the same position and within the same limitations in either frontal bone, with a point of exit 2 to 2½ inches behind the external angular process of the frontal bone, 1 inch to 1¼ inches above the zygoma, form 2 more silent planes. A point of entry 1 inch to 1¼ inches below the parietal eminence, with a point of exit corresponding to the tracts CC and DD, is another silent plane. We are able to discover no silent planes for which the mastoid process was any guide. These planes are of great interest, for in several cases the damage to brain, especially in the frontal region, must have been extensive, judging by the nature of the wound and the amount of brain that was protruding. Similar severe laceration was seen in the planes AA and BB, yet these patients were not only conscious but able to walk. The same phenomena were observed in cases where the tract EE was present, and this was all the more puzzling, as it was very difficult to see how the motor and sensory areas could have escaped. Yet these men walked, and they were by no means isolated cases. Other cases in which rough measurements showed the plane to have deviated by 1/4 to 1/2 inch were profoundly unconscious and died on the battlefield. We have recorded these observations, rough as they may seem, for these planes seem so definite and constant as to justify what appear to be crude and unscientifically conducted observations. But many such observations were made under difficult circumstances and enemy fire. Consequently, speed was a necessity and some inaccuracy inevitable. Treatment. Prophylaxis. Treatment begins on the battlefield and falls to the lot of the regimental medical officer. An ounce of prevention in these cases is better than many pounds of cure. Hence all prophylactic precautions should be taken. The inventor of the steel helmet has indeed proved a savior of mankind in the present war, and it is little less than marvelous that the incidence of head injuries should have fallen to the degree it has at the time of writing. It should be thoroughly impressed on the soldier that the wearing of his steel helmet is as important to him as carrying his rifle or grenade, and it is the duty of his company officer and platoon commander to make this clear. The importance of keeping the hair as short as possible cannot be too strongly emphasized, and whenever the soldier gets the opportunity of a wash he should thoroughly soap and wash his head. It is in this connection that, Apart from the general health, the mouth should be kept as clean as possible. Running ears should be seen too, and any suppuration above the nose should have attention. Treatment on the battlefield. The first field dressing should be applied at once, and the wounded man removed as quickly as possible to the advanced dressing station of the field ambulance. It is very important to record on the tally whether consciousness existed for any time after the man was wounded, for by the time he reaches the clearing station he may be unconscious. Treatment at the advanced dressing station. If there is any delay at this point, the dressing should be removed and the scalp shaved to the distance of 2 or 3 inches from the wound. A U-Sol dressing should be applied and the wounded man placed on a stretcher. If time permits, short notes as to his state of consciousness, pupils, breathing, and pulse should be recorded. Stimulants must be avoided. Treatment at the casualty clearing station. It is undoubtedly at this unit that head injuries should receive surgical attention. In a rush this is often impossible, and a number of cases requiring operation pass through to the base hospitals. Unconscious patients in whom no open injury to scalp or skull exists, especially if information is forthcoming that at one time after injury they were conscious, should be operated upon without delay. Such cases usually show unequal pupils, stertorous breathing, and a slow pulse. Flaccidity of muscles on the opposite side of the lesion, with alteration in the reflexes, may be present, but their early absence in these cases has proved no guide. All cases of open injury to the scalp should be operated upon. Penetrating wounds of the skull may or may not present focal symptoms. All such cases should be x-rayed on admission, 2 pieces of wire being placed, one on the fissure of Rolando and the other over the fissure of Sylvius. An x-ray taken in 2 directions will thus give the position of the foreign body in relation to the injury in the skull, and also in relation to the fissures of Sylvius and Rolando. Operation. The scalp must be cleanly shaved all over, all hair being removed from the neck. This done, the scalp and face are thoroughly cleaned, the former with a scrubbing brush and spirit soap, the wound being protected the while with an antiseptic pad. The cleaning of the scalp has been usually carried out when the patient is under anesthetic, preferably chloroform. When the scalp has been thoroughly washed, it is dried with ether and again rubbed over with beniodide and spirit. The scalp must be cleaned right up to the wound edge. The surgeon now changes his gloves and sterile towels are placed over the patient, one being carefully placed over his face and one over the anesthetist's arms. A pad of sterile wool is placed below the towels to absorb any blood. We have not used a head rest, but have always found a sterilized pillow satisfactory. The wound. The surgeon now proceeds to deal with the wound in the scalp. This should be first sponged out with pure carbolic, or preferably treated with the cautery. This is an important preliminary because during excision, reinfection can easily occur from the weeping of the damaged infected surface over the newly incised surface. Excision of the wound should now be carried out. The scalpel must incise all tissue down to bone, going through tissues 1/4 of an inch outside the damaged edge. The wound must be excised en masse. This done, the surgeon takes freshly sterilized instruments, discarding those he has been using. He now proceeds to examine the skull. If the wound be severe and the patient concussed, but the outer table appear intact as far as fracture is concerned, and provided there be no definite focal symptoms, we are content to go no farther. It is a debated point whether or not all these cases should be trephined, and the French surgeons have advised it. We have not taken this view for the following reasons. 1. So many of these cases completely recover without trephining, and to our knowledge have returned to duty showing no untoward symptoms. 2. Although the wound may have been carefully excised and every antiseptic precaution taken, yet the wound was originally septic, and there is always a risk, slight though it be, of infecting the meninges. 3. Should damage have occurred to the inner table and symptoms develop later, then operation can always be undertaken under ideal conditions, for by this time the wound has healed. Focal symptoms in cases of head injury with an undamaged outer table are rare unless there be extradural hemorrhage. If this be present, then the skull must be opened. If there is no indication for trephining, the scalp after excision of the wound is sutured with interrupted stitches of silkworm gut without the incision of a small tube. Before suture, we have swabbed the fresh wound with either flavine, bright green, or Usol. Almost without exception, these wounds have healed by primary union. If the wound be extensive, making it impossible to approximate the scalp edges, then the device recommended by Cuthbert Wallace and shown in the illustration on page 497 should be practiced, and it has given excellent results. Trephining. If there be immediate indications for performing a trephine operation on a case in which the outer table is not fractured, the skull must be well exposed. Two methods of accomplishing this are open to the surgeon, for he may either use an omega flap, including the wound of excision, or he may enlarge the wound of excision. We have tried both methods extensively and prefer the latter. When once the skull is exposed, the trephine is applied and a circular piece of bone removed. It may then be found that the inner table is fractured. The hole in the skull is enlarged with Hoffman's or Horsley's forceps, and all fragments of the inner table removed. Any bleeding meningeal branch must be ligatured. In these cases, it will often be observed that the dura does not pulsate. This is due to cerebral edema occasioned by the injury, and under no consideration should the dura be opened unless there be previous signs of cerebral irritation. The dura may perhaps be damaged, and from the rent some blood clot is exuded, followed by visible pulsation in the exposed part of the cerebral cortex. Should this latter condition be present, the dura should be left alone, as probably by this time subarachnoid adhesions have formed. When all loose bone and blood clot have been removed, the scalp is approximated by means of silkworm gut sutures, and primary union invariably results. Before suture, the wound has been washed out with flavine or brilliant green, saline being employed during the operation. Some surgeons before returning the patient to bed have advocated lumbar puncture, but we have seen no reason to do this. If no open injury to the scalp has taken place, it is preferable to trephine just as one would do in civilian practice, turning down the usual omega flap. The operation in this case is from first to last aseptic, as there is no open infected scalp wound to deal with. Fracture of the outer and inner tables. The first stage of the operation is the same as that in which no fracture exists. The wound of the scalp after cauterization should be completely excised. This done, the trephine is applied and a piece of bone, including a portion of the fracture, is removed, after enlarging the wound of excision or turning down a flap which includes it. The fractured portions of both inner and outer tables are removed. We have not practiced elevation because the fractured bone is infected. If the missile has not penetrated the dura, nothing further is done. The wound is now washed out with brilliant green, flavine or Usol, and the scalp is stitched over a very small rubber tube, with its ends protruding from the most dependent corners of the wound. The wound is dressed daily, and Usol is syringed through the tube. At the end of the 48th hour, the tube is omitted, and the wound invariably heals per primum. Penetrating wounds of the brain. With the X-ray plate before him, the surgeon proceeds first to excise the scalp wound. By means of incisions, prolonged from the wound of excision, the hole in the bone is fully exposed and enlarged with trephine or bone forceps. Enough bone must be removed to show 1/8 to 1/6 of an inch of undamaged dura all around the opening of the skull. At this stage it will be noticed that the dura does not pulsate, and that the breach in its surface is plugged with blood clot. Often lying in the breach is a detached piece of bone. When this is removed, the brain vomits blood clot, often accompanied by other pieces of bone from the tract. In some instances, we have seen it expel the missile. When once the blood clot is ejected, the brain starts to pulsate and may be protruded through the hole in the dura. After carefully measuring the depth of the missile in the brain substance and its direction, a finger is carefully inserted into the tract. The trained finger finds its way along the track of the missile until it comes to a cul-de-sac. Here, lying quite loosely, for we have never found it embedded, is the missile. A scoop is now gently inserted along the finger which is touching the missile, and between the finger and scoop the missile is carefully withdrawn. We have performed several of these operations and have seen no harm follow the insertion of the finger, provided it be done carefully. Neither have we restricted ourselves to the depth to which the finger has been inserted, and in not one case has harm resulted. The walls of the tract made by the missile are edematous, very soft, and, so to speak, give way before the finger. The whole process must be carried out most carefully and gently, and on no account should a surgeon insert his finger and feel round. This is quite unnecessary, for in a large number of cases we have found that track leads the finger direct to the missile. Success depends entirely on the sense of touch, and much irretrievable damage may be brought about through the formation of a false track by an inexperienced finger. Great care must be taken in inserting the finger lest subarachnoid adhesions be broken, for if this happens, then meningitis may easily follow. After the missile has been removed, the wound is washed out with flavine or brilliant green, and the scalp sutured over a small tube, the ends of which occupy the most dependent parts. In no case have we employed brain drainage, and we have never regretted it. There is not the slightest doubt that the damaged brain, if left alone after operation, provided it has not been unduly stirred up by digital manipulation, and put under the best conditions, can successfully deal with what infection is present, and this our results have proved. Drainage contrivances inserted into brain substance through a wound that was once septic are always paths along which further infection can travel, and we have found them wholly unnecessary. When all necessary manipulations of the brain are finished, the defect in the scalp must at all costs be closed. It is very bad practice to leave a breach in the scalp with the underlying dura and brain uncovered. In this war, as at other times in the history of surgery, the pendulum has first swung one way and then another. At one time, surgeons advocated the practice of leaving head wounds open after operation. There was a reason for this, because at this particular time neither the nature of head injuries nor the type of infection was understood. Bad results followed, for both infection of the exposed dura and brain and hernia cerebri too often occurred. Today it is the practice to close all head injuries after excision has been performed. The procedure has proved both safe and satisfactory when the proper technique has been followed. We still, however, see cases arriving at the base hospital where excision of the scalp wound and trephining has been undertaken at the casualty clearing station, yet the surgeon has stayed his hand at completely closing the scalp wound. This is a grievous mistake, for where such a breach in the scalp is allowed to exist for a period of 10 days or more, a degree of hernia cerebri, if not infection, is bound to follow. If proper excision of the scalp wound has been performed, it is perfectly safe and correct practice to close the scalp defect completely, and so afford protection to exposed dura and brain. Neglect to do this will lead to serious complications. Closure of the wound. It is in the vast majority of cases possible to close the wound in the scalp by interrupted sutures of silkworm gut. If there is liable to be much tension, the scalp should be undermined on either side of the wound. This is best done by inserting the closed blades of a blunt-ended pair of scissors beneath the scalp tissues, and then opening them. If this maneuver is insufficient to allow of the edges of the wound being approximated, then plastic measures must be resorted to. One of the best is the S incision recommended by Cuthbert Wallace and shown in the illustration. Another method is that of making an oblique incision into the scalp on either side of the wound, not involving the pericranium, and sliding the two flaps so formed together over the breach in the skull. If the condition is one of fungus cerebri, the wound is sterilized by the Carrel-Dakin method until the count shows 2 organisms to 5 fields or lower. When this is the case, the patient is taken to the theater. The edges of the scalp wound are carefully excised and peeled off the protruding part of the brain. This done, the fungus cerebri is removed with a snare of silkworm gut. There is rarely any bleeding. The edges of the scalp wound are now loosened and sutured over the freshly left brain surface, a small perforated tube being left in the flap, into which U-Sol is instilled twice daily. 10 of these cases were operated upon and were detained 3 months after operation. Every case healed by primary union. There was not any untoward symptom, and every man left for hospitalship able to walk and look after himself, having been up and about for 6 weeks. At the end of the operation, for suture and removal of the fungus cerebri, lumbar puncture was performed in each case, and its repetition was not called for. These 10 cases are of special interest, for before operation they all seemed well, but complained of disturbed and irregular sleep. And while they slept, they suffered from nightmare. After operation, these 2 constant symptoms disappeared. When a hernia cerebri is large and is tending to become larger, the treatment par excellence is lumbar puncture. This measure should be carried out daily, the wound being kept clean with a Carrel-Dakin dressing. The bowels should be kept moving, preferably with hydragogue purgatives. And we have always nursed these patients as far as possible in the sitting position, as no doubt gravity plays an important part in reducing the hernia cerebri. The sitting position is easily maintained by means of the folding bed, and the patients on the whole prefer it. Every possible precaution must be taken to avoid infection, and in this connection the Carrel-Dakin dressing has proved admirably satisfactory. Under this treatment, the hernia cerebri gradually subsides and eventually becomes a fungus cerebri. When this has happened and the wound is sterile, the operation for fungus cerebri described above can be safely carried out. On no account should any undue external pressure be brought to bear upon the hernia, and this has never been found necessary. Cases are described in which, despite treatment, the hernia tends to get larger or remain stationary. Such a case has never come under our care. Some surgeons have in this connection recommended a subtemporal compression operation on the contralateral side, and this is what would seem the most feasible procedure in the circumstances. Meningitis and encephalitis. Should symptoms of infection of the meninges or cortex supervene, then the best treatment is repeated lumbar puncture. The cerebrospinal fluid should be examined and cultured, and if possible, an autogenous vaccine prepared. These complications, though of necessity grave, are not necessarily fatal. They are frequently due to the presence of an unapproachable foreign body, or they may follow the clumsy removal of a foreign body, or a clumsily performed trephine operation. We have seen recoveries take place in what appear to be hopeless cases, and the surgeon should never despair. In all cases of head injury, eutropine 15 grains must be given 3 times daily, or in serious cases 4 hourly. Calomel 5 grains should be administered to all cases of head injury, and magnesium sulfate 3I 2 or 3 times a day ensures the presence of a liquid stool. If the patient is noisy or sleepless, potassium bromide 60 grains and chloral hydrate 15 grains may be given in the evening. Stimulants must be carefully avoided. Easily digestible diet only should be taken for the first few days following operation, and as a routine these men are kept in bed for 6 weeks. As far as possible, head injuries should be nursed in a quiet ward set apart for them, and if possible, the medical officer in charge of the ward and the sister should not be changed, as these patients require special care and treatment, which can only be given by those having considerable experience. The ward should not be too light, it should be clean, and no other septic gunshot wounds admitted, as the very strictest antiseptic precautions are required in the after treatment of these cases. Addenda. Excisions of head wounds en masse has been recommended by Cushing. In common with other surgeons, he recommends the use of local anesthesia and extraction of the foreign body, with the contents of the tract made by it in the brain substance, by means of suction. The method and technique are described in the British Journal of Surgery, April 1918. End of chapter 19, part 3.
Chapter 20, Part 1 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by MaryAnn Spiegel. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 20, Gunshot Injuries of the Thorax, Part 1. Gunshot injuries of the chest, though extremely rare in civilian practice, have assumed a position of importance and frequency in the present war. Knowing how vital the part of our anatomy is, which is formed by the thorax and its enclosed viscera, it seems strange that continuance of function in these parts still persists, despite gross damage inflicted upon them by the modern missile. Thoracic wounds are an object lesson of the way in which nature makes good temporary damage inflicted on important and vital viscera. It is almost incredible how a missile can penetrate or perforate the thoracic cavity in places or along paths which anatomically would seem fatal, and yet the victim of these wounds can walk down unconcerned to the regimental aid post or the advanced dressing station. One of us witnessed instances of 2 men hit in the chest who, despite a hemiothorax, nevertheless continued to hold a sap for 2 hours, throwing bombs all the while. Many victims of penetrating chest wounds die where they fall, the lesion undoubtedly being one of the heart or great vessels. A number of these cases were the result of snipers' bullets, and most of them presented a very small wound of entry. During an attack in early 1915, several men were hit in the chest, both by rifle and machine gun bullets, while going over the parapet. Some were killed outright, but the majority, who at this stage seemed to suffer but little, were immediately sent to the advanced dressing station. It is difficult to estimate the gross percentage mortality in the case of chest wounds. All the statistics we have are concerned with those who survive long enough to reach the casualty clearing stations and base hospitals, and these form but a fraction of the total. Judging from experience in the line, it would seem that, of the battlefield statistics, the recoveries appear to be greater than the deaths. If, then, a man sustain a wound of his heart or great vessels, no treatment that can be given him on the battlefield can possibly save him. In fact, his luck is out. If, on the other hand, these essentially vital structures escape, he stands a chance, and from observations made both at the clearing station and the base, the chance on the whole is in his favor. Anatomy of the thorax in relation to wounds. The anatomy of the thorax is such that wounds involving the thoracic contents may easily be complicated by damage to other important structures. The thorax is a bony cage, formed by the ribs, vertebral column, and sternum. The floor is formed by the dome of the diaphragm, with its right and left cupollae, and the roof, formed by Simpson's fascia, projects from 1 1/2 to 2 inches into the root of the neck. The diaphragm is a fibromuscular sheet perforated in several places for the transmission of such important structures as the aorta, inferior venal cava, esophagus, thoracic duct, and the splanchnic nerves. It is lined for the greater part of its extent superiorly by the diaphragmatic pleura and inferiorly by the peritoneum. On its convex surface rest the base of both lungs and the heart, while its concave surface accommodates the right and left lobes of the liver, the spleen, and a small portion of the anterior wall of the stomach. The dome-like structure of the diaphragm leaves a recess between the lower chest wall and the superior or diaphragmatic surface, the costophrenic recess. The recessus phrenicocostalis is bounded externally by the lower thoracic parietes lined by the parietal pleura, internally by the diaphragm clothed with its diaphragmatic pleura, and superiorly by the base of the lung clothed with visceral pleura. The roof of the pleural cavities, also dome-shaped on either side, is in close relation to important structures at the root of the neck, such as the innominate artery and vein, the subclavian and carotid arteries, and the large nerve trunks of the bronchial plexus. In immediate relation to the posterior wall of the thorax are the two scapulae. The thoracic cavity and its contents never rest. Respiration and cardiac action, in order to maintain the life of the individual, must never cease from birth to death. Normally, in the pleural cavities, a negative pressure obtains. If there is a breach of continuity in the thoracic parietes, involving their entire thickness, the interpleural and intrapulmonary pressures become equalized, and pneumothorax results. For the well-being of the individual, it is essential that respiration and cardiac action should continue unimpeded. It is well known to what extent pulmonary or cardiac disease can mitigate against the general health and resistance of any person so afflicted. In exactly the same manner, a severe injury of the lung militates against the satisfactory progress of wounds present elsewhere in the same individual. Thus we have constantly noticed that large flesh wounds or compound fractures complicating a chest wound in the same individual take infinitely longer to sterilize and heal than similar wounds in other individuals where no chest injury exists. This is an important point, as wounds in other parts of the body complicating a chest wound should receive more active and energetic treatment. Wounds of the thorax may be A. contused, B. non-penetrating, C. penetrating, D. perforating. A. Contused wounds of the chest are usually the result of a direct hit by a spent piece of shell or being buried. The damage done varies from slight or severe bruising of the chest wall up to a simple or compound fracture of bone with bruising or tearing of the thoracic viscera. If the blow be sufficient to fracture bone, the fracture may involve the parietal pleura only, subpleural hematoma, or it may involve the pleural cavity, causing a degree of hemothorax, simple fracture. If, on the other hand, the fractured bone involves the lung, compound fracture, then hemoptysis and hemothorax result. Contused wounds of the thoracic parietes are not infrequently followed by a clear effusion into the pleural cavities or by pneumonia. A contused wound in the chest wall in the region of the spine may cause damage varying from a slight or severe degree of spinal concussion to a fracture of the vertebral column with complete paralysis. B. Non-penetrating wounds of the chest vary in degree from simple abrasions to severe lacerations both of soft parts and bone. If the wound be oblique and tangential, a number of ribs may be involved. Fracture of the ribs in this connection can either be direct, indirect, or both. If a rib is fractured indirectly, it usually gives at the place of greatest fixation, that is, at or near the angle. If, on the other hand, it is fractured at the site of impact, the blow being tangential, there is not much displacement, but the parietal pleura lining to the injured rib is torn. Ribs that are fractured tangentially are very apt to become splintered and to penetrate the parietal pleura, the result being a penetrating wound. Non-penetrating wounds of the thoracic cavity may involve the vertebral column or even the spinal cord, and give rise to either severe spinal concussion or a complete paralysis below the site of lesion. Non-penetrating injuries of the chest wall may, through fracture of the ribs, be the cause of a hemothorax or hemopneumothorax. C. Penetrating wounds of the chest vary from a small wound of entry to a severe laceration of the chest wall. Thus, in one case of a soldier killed on patrol duty by the explosion of an enemy bomb, It was only after a diligent search that a very small wound of entry was found in the posterior thoracic parietes. In contrast to this may be quoted the case of Lieutenant Corporal Blank, who in October 1915 was hit with a piece of high explosive. The left wall of the chest was in great part carried away, leaving the left lung still covered with visceral pleura and part of the pericardium exposed. This man lived for 5 hours in the line, but all this time was cyanosed and showed a rapid intermittent pulse. Penetrating wounds of the chest may or may not involve the thoracic viscera. If the heart or great vessels are wounded, death usually is immediate and painless. If, on the other hand, the lungs only are involved, the patient is more often able to help himself and is early evacuated to the forward units. Again, a penetrating wound of the thorax may involve the spine or the abdominal viscera, especially those lying in immediate relation to the diaphragmatic cupollae, viz., the liver, stomach, and spleen. Most cases of penetrating chest wounds, though not all, are associated with hemothorax. A penetrating wound of the chest low down may miss the lung, but by transversing the recessus pharyngico-costalis may damage the liver, stomach, or spleen. Again, a missile may come to rest in either the anterior or posterior mediastinum without inflicting damage on the viscera. We have seen this latter occurrence in quite a number of cases. It is most frequently associated with fracture of the sternum, the piece of missile being wedged in this bone or having just penetrated it. By far the majority of cases of penetrating wounds of the chest are associated with fracture of the bony structures forming the thoracic wall. D. Perforating wounds of the thorax may show a small wound of entrance and a larger wound of exit. The wound of exit depends upon the amount of damage done to bone, and may vary in size from quite a small opening to a wound of terrific extent which almost passes description. One case will suffice to illustrate this. Private Blank, while on sentry go, was hit with a piece of shell in the back of the left chest, below the inferior angle of the scapula. The missile emerged on the right side, and when one of us saw this man a few minutes after injury, he was lying in the trench bottom. The greater part of his right thoracic parietes had been carried away. The exposed lung was flapping about and was soiled with trench mud. He was quickly removed to the regimental aid post a few yards away, where the lung was washed, replaced, and maintained in place with a boiled towel. He reached the casualty clearing station and lived for 3 days. A number of similar wounds never left the line. In all these cases, the exposed lung without exception was dark-colored and engorged. These wounds, apart from their ghastly nature, presented an interesting side in that the lung does not appear to collapse wholly or cease to function. Indeed, the reverse occurs, for these exposed lungs were inflated to a very considerable degree at each inspiration. Without wishing to dwell on wounds so fatal and gruesome, it is of interest and practical importance to record what actually happened in one special case which survived for 3½ hours in the line. This particular man had a large piece of his left thoracic wall and part of his sternum carried away as the result of the bursting of a trench mortar. The pericardium and lung were exposed, and the main feature in his case was cardiac embarrassment. He was given an anesthetic prior to dressing the wound, and there was severe hemorrhage from the internal mammary artery. It was then ascertained that although the lung was exposed, yet it was inflated at each inspiration, and the immediate trouble was due, not to the pulmonary condition, but to cardiac displacement. The displacement was of a rotary character, the apex of the heart having moved to the right and forwards. This was quite sufficient to bring about an amount of obvious kinking in the pulmonary veins, with consequent engorgement of the afflicted lung. This engorgement is exactly what occurred not only in those cases who died in the line, but also in the very few that survived long enough to reach the casualty clearing station. It was not until opportunity had presented itself of seeing this one particular case in detail and under an anesthetic that an explanation of the engorged condition of these prolapsed lungs could be found. Perforating wounds of the thorax may or may not be associated with damage through the thoracic or abdominal viscera, and the bony frame of the thorax rarely escapes injury. Penetrating or perforating wounds may involve the ribs, sternum, or spine. When the ribs are involved, there is usually much splintering of the bone, with a carrying forward of some splinters by the missile into the substance of the thoracic contents. On rare occasions, a rib may be cleanly perforated without any splintering, the result of a perpendicular hit with an undeviated rifle bullet, or a notch may be cleanly cut in its superior or inferior aspect. In a number of instances, though these are the exception, the bullet or missile may enter the chest through an intercostal space and so miss bone altogether. Perforating wounds, however, are different, as the exit wound is larger and more ragged, owing to the missile already distorted, hitting the rib on its concave aspect, and now traveling from within outwards. Immediate complications of chest wounds. These are A. Hemothorax, B. Pneumothorax, C. Chylothorax, D. Paraplegia, E. Damage to abdominal viscera. A. Hemothorax. This is a very constant complication of almost all penetrating and perforating chest wounds, though it should be borne in mind that in very few instances hemothorax, of sufficient degree to give rise to no physical signs, occurs. The extravasated blood may originate either from a damaged viscus, most often the lung, or from arteries in the chest wall, the intercostal arteries, and internal mammary. The commonest source of hemorrhage is the lung, though we have operated upon a number of cases where the bleeding has been taking place from the chest wall. Bleeding from the chest wall into the pleural cavity is seen most frequently in penetrating shell wounds, where one or more ribs have been driven in, but in the case of perforating shell or bullet wounds, the bleeding from this source is extreme and visible in the wound of exit. The course of hemothorax depends a good deal on what happens to the wounded man in the few hours after he is hit. If he is a stretcher case from the moment he is wounded, the pool of extravasated blood will in 9 cases out of 10 assume and keep a definite position in the pleural cavity. If, however, he is able to walk and move about for some time after being hit, the position of the extravasated blood will vary accordingly. As soon as the blood is shed into the pleural cavity, a process of clotting takes place, but it does so in a manner quite different from that which occurs in vitro. The constant movement that is going on in the chest keeps the extravasated blood moving, and consequently the clotting process is almost identical with that seen in whipped blood. Fibrin is thrown out and deposited upon the movable structures, viz., the lung, diaphragm, and chest wall. This clot has been called by Elliot and Henry the primary clot. Later, according to these observers, a further inflammatory effusion takes place into the pleural cavity, which already contains blood devoid of fibrinogen, and which therefore does not clot in vitro. The latter effusion contains fibrinogen in varying quantity and gives rise to further clotting in the already existing defibrinated blood. The latter clotting process they have termed the secondary clot. If a patient suffering from hemothorax be kept quiet, the hemothorax becomes shut off by adhesions formed between the damaged lung and the parietal pleura. The part of the lung beneath the effused blood collapses and ceases to function, whereas the portion unsubmerged shows a compensatory emphysema, which may extend across the midline of the chest. Thus, the physical signs of the affected side will be dullness to percussion over the localized or non-localized area of effusion, and scodaic resonance almost equal to that of a pneumothorax over the area of compensatory emphysema. Over the area of dullness there are diminished voice and breath sounds and diminished fremitus, whereas over the area of scodaic resonance the breath sounds are extremely harsh and expiration is unduly prolonged, thus distinguishing the condition from one of pneumothorax, for which on percussion alone it might well be mistaken. The collapsed portion of the lung shows fibrin deposited upon its surface, and if left long enough the fibrin organizes and forms a barrier against subsequent expansion. Elliot and Henry, in the RAMC Journal of November 1916, have pointed out that the portion of the lung collapsed is rarely, if ever, the seat of infection, and that by submersion in the pool of blood, the power of expansion is not permanently impaired. Wounds about the apices of the lungs are generally associated with an extensive hemothorax, for the effusion of blood into the pleural cavity tends to continue until the whole lung up to the level of the wound in its substance has become submerged. When this is accomplished, further hemorrhage from the lung ceases. Such then is the simple history of a hemothorax. From it we can gather some idea of nature's method of providing rest for the wounded lung, of arresting hemorrhage, and at the same time of compensating for the lost function of the submerged portion of the lung by the production of compensatory emphysema in the unsubmerged portion. Where old adhesions exist in the pleural cavity, the result of previous disease or a previous wound, the condition of the hemothorax becomes modified. We may in these circumstances get irregular loculi in the pleural cavity filled with blood, or if the damaged part of the lung be already firmly adherent to the chest wall, then hemorrhage may occur between the chest wall and the parietal pleura. This, however, is rare. The presence of old adhesions will in the case of hemothorax prevent collapse of the affected lung. B. Pneumothorax. This condition rarely exists as an entity in gunshot wounds. It is invariably associated with a varying degree of hemothorax, hence, more correctly, the condition should be called hemopneumothorax. Pneumothorax may be either traumatic or infective. Traumatic pneumothorax may result either from injury to the chest wall or lung, much more commonly to the former. The breach in the chest wall may be open, as in a thoracostomy wound, or it may be valve-like. It is not at all an uncommon type of chest wound, and, since the prognosis is good, few cases come to autopsy. Pneumothorax, the result of injury to the lung, is very rare, hemothorax being by far the most common sequel of the condition. Infective pneumothorax is, unfortunately, in this war a common complication of hemothorax. It is produced by the presence of gas-forming sporogenous anaerobes in the effused blood. When once these organisms have established themselves in the extravasated blood, gas formation proceeds at a great pace, and a typical pneumothorax results. We have now investigated a number of these cases, and have isolated B. perfringens from all of them. It is a noteworthy fact that an infective pneumothorax has never been seen by us in any case where a traumatic pneumothorax existed previously. The explanation of this would appear to lie in free access of air in the latter condition, and the consequent lack of anaerobic facilities for the development of P. perfringens. A traumatic pneumothorax soon becomes absorbed when once the hole in the chest wall has been closed, and the symptoms are nothing more than those produced by a thoracostomy performed for conditions like empyema. Infective pneumothorax is associated with symptoms of grave toxemia and calls for immediate thoracostomy and the evacuation of the septic and disintegrated blood clot. C. Chylothorax. This is a rare complication and due to injury to the thoracic duct. In no case have we found this condition at autopsy, but in 2 cases out of 150 we inferred that this condition occurred owing to the clinical signs present. Both of these men had small penetrating wounds of the thorax with no symptoms other than wasting and some intermittent vomiting and diarrhea which lasted about 12 days. Physical signs showed some dullness at the bases. Aspiration was not performed. After 5 weeks' interval, both men commenced to improve and to put on weight, and left in good health for hospitalship 8 weeks after their injury. D. Paraplegia. This very grave, if not fatal, complication may be associated with damage to the lung, and is due to the missile in its course striking the spinal column. Not uncommonly have we seen paresis and paresthesia associated with damage to the thoracic cavity, especially where the missile has entered the cavity from behind in the region of the spinal column without hitting the spine itself. It often happens that a missile entering the thorax from behind and striking the spinal column carries into the lung broken spicules of blood, and so renders the damage to the lung all the more serious. Such cases are invariably fatal, and if they survive long enough, further complications, such as bed sores, cystitis, and the like, seem to come on with greater rapidity than is the case if an uncomplicated wound of the spine exists. E. Damage to the abdominal viscera. This is by no means an uncommon complication of chest wounds, and usually happens, though not always so, in connection with penetrating wounds of the lower thoracic region. The liver, stomach, and spleen are the abdominal viscera most often involved, although we have operated upon cases where both small and large intestine have been perforated, and 2 of these by wounds situated higher up in the chest wall. The usual course of the missile in this class of case, however, is across the pharyngeal-costal recess, missing the lung, entering the dome of the diaphragm, and wounding one of the 3 abdominal viscera mentioned. We might add that among many cases of chest injury seen by us, both in France and in the East, we have never seen a case of injury to the esophagus. This may be explained by the fact that the esophagus is so close a relation of the aortal and pericardium that wounds involving it are almost immediately fatal. We saw 2 cases of injury to the interthoracic portion of the trachea, and though tracheotomy was performed by means of a rubber tube, both cases proved rapidly fatal. One case suffered a fatal hemorrhage from the left innominate vein, and the second showed a virulent infection of the mediastinum with gas formation, which was also present in the pericardium 6 hours after the infliction of the wound. We saw at a field ambulance a true case of Spanning's pneumothorax, and confirmed this when the patient was on the operating table, whilst we were endeavoring to relieve a condition that was rapidly proving fatal. The patient was a German, and the wound proved to be of the right bronchus, valve-like in nature and communicating with the right pleural cavity. The features about this particular case were the extent of the pneumothorax and the extensive amount of cardiac displacement. The patient took the anesthetic badly, and after thoracostomy had been performed, the rush of air through the valve-like opening in the bronchus could be heard as the patient sputtered in expiration. Further turning back of the chest wall revealed the condition, and during this latter part of the operation the patient died. Owing to the rush of work at the time, further notes or examination could not be made. Hemoptysis of varying degree accompanies wounds of the lung. This is usually so slight and transient that we have not included it as an immediate complication. Cases, however, occurred in the line in which a rapidly fatal hemoptysis followed certain penetrating wounds of the chest. It is probable that here both a large artery and a bronchus or the trachea had been wounded simultaneously, but the conditions did not permit of further examination. We can call to mind only 4 such cases, and in all death followed almost immediately. Subsequent history of penetrating chest wounds associated with uncomplicated hemothorax. Before proceeding to discuss the remote complications of chest wounds, it is interesting to follow the history of an uncomplicated hemothorax. It has been pointed out in preceding pages that the submerged portion of the lung becomes coated on its surface with fibrin from the extravasated blood. Further, if this fibrin be left long enough, it gets tougher and tends to organize. If this condition persisted, it would seem that the constricting influence of this organized fibrin would prevent subsequent expansion of the lung, but clinically this is not the case. It would seem that both extravasated blood and fibrin are to a great extent absorbed, but the latter not wholly so. An autopsy performed on a case of death due to septicemia from a knee joint injury showed the condition persisting in the chest from a gunshot wound 2 years previously. The wound in the chest was a perforating one, the entrance being over the superior angle of the right scapula, and the exit in the third right intercostal space in front. The following observations were made at autopsy. There is no evidence of collapse of the right lung. The lower lobe shows old irregular adhesions to the chest wall and the diaphragm. The surface of the lower lobe of the lung shows a patchy scarring of the visceral pleura. Congestion of both bases present. Another case more convincing is that of a man whom one of us saw who was hit in the chest early in 1915. He was returned to duty in the line 9 months later. After being in the line 1 month, he received a fatal wound in the head. An autopsy revealed adhesions between the lung and chest wall, with the same patchy scarring of the lung. The lung was not collapsed, although after his first injury he had suffered from an uncomplicated hemothorax. There is, then, strong evidence to show that the extravasated blood is in time absorbed. the fibrinous envelope of the submerged portion of the lung is fissured, allowing this part of the lung to expand, the final result being scattered and tough adhesions between the submerged portion of the lung and the chest wall. Out of 150 cases of penetrating and perforating gunshot wounds of the thorax treated by us from start to finish, there have been quite a number of cases of uncomplicated hemothorax. The history of one such case, watched over a period of 2.5 months, will suffice to show the clinical picture, for such cases differ but little clinically. Private Blank was wounded on April 24, 1917, by a piece of high explosive which perforated his left chest. The entrance wound was in the back, traversing the supraspinatus fossa and emerging on the third intercostal space, just 3.5 inches from the middle line. On admission, 4 days after the injury, he was dyspnoic and kainosed. Dullness was present up to a level of 1 inch above both entrance and exit wounds in front and behind, and over this area of dullness tactile fremitus and breath sounds were absent, and voice sounds were distant. The cardiac dullness was present to an extent of 2.5 inches to the right of the sternum. The apex beat was not felt, and the heart sounds were distant and better heard on the right side. Above the area of dullness, scodaic resonance was very marked and extended across the middle line, and over this area the breath sounds were very harsh and expiration most prolonged. True agophony was not present. The evening temperature reached 102 degrees, returning to 99 degrees in the morning. At the end of a week, dyspnoea and kyanosis had disappeared, but there were no changes in the physical signs. At the end of a fortnight, the evening temperature reached to just above 100 degrees, returning to nearly normal in the morning. Auscultation now revealed tubular breathing about the upper part of the dull area. 4 days later, crepitus redux was present in the same area. During the next fortnight, redux, crepitations, and bronchial breathing were present, and scattered over the greater part of the dull area in front. In 6 weeks after the injury, the temperature had returned to normal, and both distant breath sounds and voice sounds could be heard. On leaving hospital a month later, the temperature was normal, voice and breath sounds were present, though slightly distant as compared with the sound side, but there was a very distinct comparative dullness. The physical signs at this stage were, then, those which are associated with a thickened pleura, but slightly modified. From this case, which differed but little from others of similar nature, we may infer that an uncomplicated hemothorax of considerable extent becomes absorbed in from 10 to 12 weeks after injury. Remote complications of gunshot injuries of the chest. It may happen, as we have seen in more than one occasion, that a soldier wounded in the chest may be the subject of old pulmonary tuberculosis. If this be the case, an injury may be sufficient to light up the trouble, though this, so far as we have been able to find out, has been rather the exception than the rule. It may happen that a soldier wounded in the chest has at some time suffered from a previous pneumonia with pleurisy and emphysema, leaving him with old fibrous adhesions between the lung and chest wall, and this has not infrequently been the case. Or, again, he may have suffered from a previous wound of the chest, leaving him with a condition described in a preceding paragraph. Previous adhesions profoundly modify a chest wound, in that hemothorax tends to become irregular and loculated. Remote complications of chest wounds, with the exception of surgical emphysema, are concerned with sepsis and are as follows: A. Surgical emphysema. B. Pyothorax. C. Pyohemothorax. D. Pneumoniahemothorax. E. Septic pneumonia. F. Hemoptysis. G. Abscess of the lung. H. Gangrene of the lung. I. Mediastinitis and pericarditis. A. Surgical emphysema. This may be either localized or of a most extensive kind. Thus instances have occurred where the whole of the face was swollen to such an extent that the eyes could not be opened, and the patient was quite unrecognizable. The neck, chest, thorax, abdomen, scrotum, and thighs have all been involved, and on palpation the subcutaneous tissues are both crepitant and resonant. The condition, though very distressing to the patient, does not necessarily threaten life. The cause is generally a valve-like opening into the chest wall which admits air during inspiration but does not allow of its exit in expiration. The smallest of valve-like openings into the chest can give rise to a most extensive type of surgical emphysema. Many such cases have occurred, but we have never seen death result from this cause alone. B. Pyothorax results from the infection of an extravasation into the pleural cavity, which is not necessarily blood. In these cases, the lung has not always been damaged, but the condition is the result of infection of an inflammatory or traumatic exudate from the pleura. Such a collection of pus may form either in the pleural cavity or between the lobes of the lung, and may be localized or general. Presence of old adhesions in the pleural cavity tends to an irregular form of loculation. C. Pyohemothorax. This condition results from the infection of a hemothorax. Its appearance is delayed after the occurrence of the original hemothorax, appearing in R series in from the 12th to the 17th day. The source of infection is either the missile itself, the lung, or the infected wound in the chest wall, the last especially if bone be involved. The onset of the infection of the hemothorax is evident from the temperature chart, for the temperature at this juncture begins to swing between a higher and lower level and becomes irregular, a condition not obtaining in the case of an uncomplicated hemothorax. The patient becomes sallow and ill and rapidly loses weight. D. Pyopneumohemothorax. This results from infection of the hemothorax with sporogenous gas-forming organisms. The condition appears from the 5th to the 14th day after injury. The patients are profoundly ill and anemic. The hemothorax temperature chart alters to that resembling a pyohemothorax, but is even more irregular. Classical signs of a pneumothorax appear in that there is scodaic resonance, transmission of sound, produced by means of coins, across the thoracic cavity, diminished breath and voice sounds, and cardiac displacement. These patients may vomit. The peculiar cyanotic color, so typical of gas infection, may be present on the lips. The skin may be sallow or pale, wasting is very rapid, and the condition, unless energetically treated, is very fatal. Infection of the hemothorax is the result of either the missile itself or more commonly the wound in the thoracic wall. E. Septic pneumonia. This is not at all an uncommon complication of chest wounds, especially when the missile has lodged in the lung and there is no existing hemothorax. It probably results from infection of the portion of damaged lung around the missile, and from this focus infection spreads. Spread of infection is rendered the more easy owing to the absence of hemothorax, for the damaged lung is not at rest. This patchy and septic pneumonia does not limit itself to the damaged lung, but it may spread to the sound lung. The condition, when once established, is very fatal. F. Hemoptysis. This fatal complication usually occurs from the 8th to the 12th day after injury and is nothing more than a secondary hemorrhage from the damaged lung. The missile, lodged in the lung, causes infection of the damaged lung tissue which surrounds it. Should an artery of any size be included within the damaged area, secondary hemorrhage results, and the blood is coughed up just as in a hemoptysis due to pulmonary tubercle. We have witnessed 4 cases in which this hemoptysis was brisk and profuse. 3 of the cases died and 1 recovered. Death was not immediate, but followed a few hours later. G. Abscess of the lung. Localized abscess of the lung around the missile is not uncommon, and is usually associated with injuries in which hemothorax has not occurred. The abscess contents, usually of an extremely offensive nature, are coughed up, and a spontaneous cure may result. Usually associated with the expectorated abscess contents is some small amount of blood, but this has never been excessive. The condition, though extremely serious, is not necessarily fatal, the chief danger being a septic spreading pneumonia or gangrene of the lung. H. Gangrene of the lung. This is a rare complication of gunshot wounds and does not occur where hemothorax is present. In 2 cases an abscess first formed and was coughed up with a small amount of blood. Following this, gangrene of the lung supervened, and the characteristic pungent breath, of both these patients pervaded the ward, necessitating their removal. In one case, emboli were disseminated before death. One embolus lodged in the penis, giving rise to a constant painful erection, until the organ became one gangrenous mass. One man died 5 days after the onset of the condition, while the other lingered still longer. It may be mentioned in this connection that gangrene of the lung, to the naked eye similar to these two cases, has occurred from embolism due to gangrene of Vincent's type present in other parts of the body. We can record 3 such cases, 2 of which died and 1 recovered. I. Mediastinitis and pericarditis. Mediastinitis is usually brought about by the lodgment of the missile, with its concomitant piece of clothing, in the mediastinum. It is common in connection with fracture of the sternum, where the missile has been a piece of high explosive. In 3 cases, gas formation was well advanced, and death from toxemia rapidly followed. 2 cases recovered, but in both these the missile was removed early and easily. Pericarditis is not an uncommon complication of septic wounds of the lung, especially where streptococcus is present. Infection in this case probably spreads by the lymphatics from the site of injury. This complication is by no means fatal, and a number of cases recover. It has occurred in combination with an infected hemothorax, but has rapidly subsided when the septic contents of the pleural cavity have been evacuated. Thus it would seem that the pericardium, like other bursal cavities, possesses high resisting powers against infection. End of chapter 20, part 1. Chapter 20, Part 2 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by MaryAnn. War Surgery, From Firing Line to Base by Basil HUGHES and H. Stanley Banks. Chapter 20, Gunshot Injuries of the Thorax, Part 2. Bacteriology of chest wounds. Wounds involving the chest wall only, without penetrating the thoracic cavity, do not differ bacteriologically from wounds of the body generally. Those involving the heart and great vessels are usually rapidly fatal in the line. Other wounds involving the mediastinum do not usually present any special features of bacteriological interest. From the bacteriological point of view, therefore, it is only necessary to consider here the special problems with those penetrating and perforating wounds of the chest cavity which involve the lungs themselves. Infection. The infecting organisms in these wounds are derived from 3 sources. 1. From without. These are carried in with the missile and its concomitant piece of cloth. They present a large variety, being derived largely from fecal sources. This is the source of the most dangerous organisms, anaerobic gas bacilli, streptococci, etc. 2. From the skin. These are sucked in during inspiration in certain wounds in which the opening in the thoracic parietes is not valve-like, but freely open. These organisms consist of the usual skin cocci, etc., and also other organisms of fecal or other origin, e.g. Pyocaneus, which happen to contaminate the skin at the time. 3. From within. These are the habitual organisms of mouth, pharynx, trachea, and bronchi, as well as others, which may chance to be present in these situations at the time of wounding. They include M. tetragenus, M. carteralis, pneumococcus, pneumobacillus, diphtheriord bacilli, and the like. A large variety of organisms may therefore be present. Indeed, any of those which have been considered in detail in the chapter on the bacteria of wounds may be found in such wounds, and in the hemorrhagic fluid present in the pleural cavity, gas-producing bacilli, especially B. perforinges, give rise to the greatest amount of trouble. The hemothorax which invariably accompanies these wounds of the lung remains clinically sterile in the majority of cases which are left alone. Clinical sterility implies that, even though a few organisms or spores may have gained access to the fluid, No sufficient growth or development of them has occurred to give rise to the least clinical sign of infection. Such cases may well be left alone, and if they remain clinically sterile, absorption of the fluid takes place gradually without any trouble. When, however, the smallest sign or symptom of infection occurs, and the 12th to the 17th day from the date of wound is the critical time, exploratory puncture should at once be performed. Clinical signs of infection supervened only in 28% of a series of about 150 cases treated by us at base hospital. Aerobic infection. The infection of the fluid is in some cases a purely aerobic one. This is the type of infection which always occurs, for example, in traumatic pneumohemothorax cases. In such cases, the effused blood becomes altered in color and may be hemolyzed or may contain pus. The infection in these cases usually becomes localized, and the condition resolves itself into an emphysema with its accompanying toxemia. Exceptionally, however, spread of the infection may occur throughout the whole pleural sac, or in the opposite pleural sac, or in the pericardium. The issue in such cases is complicated. The cases which we have seen of pure aerobic infection have all done well after thoracostomy. In cases of such infection, gas is never formed within the pleura or the pericardial cavities, even although certain gas-producing organisms of the coli type be present. Anaerobic infection. A purely anaerobic infection has been described, but such cases must be rare. We have not personally seen one. In these cases, gas is said to be produced in the pleural cavity, and there is liability to anaerobic toxemia and even septicemia, with other well-known clinical features of sallowness, jaundice, vomiting, quick feeble pulse, and tendency to rapidly fatal issue. Mixed anaerobic and aerobic infection. This is, unfortunately, the most common and the most serious type of infected hemothorax. The anaerobes lying in the effused blood are unable for some time to establish their growth, probably owing to their feeble powers of growing in fresh or unaltered blood or serum. The associated aerobes, however, are able to grow in some cases, and they produce exactly that devitalized or antithriptic condition of the hemothorax fluid which is essential for the development of the anaerobes. Gas is then produced within the clot and may remain as a localized collection for some time, while at the same time toxic products become absorbed by the tissues around the septic and gaseous area. A febrile reaction develops and anaerobic toxemia occurs. The gas, at first localized, may burst through the clot, becoming generalized throughout the pleural cavity, and may spread to neighboring structures, such as the opposite pleura and the pericardium. Such a condition is of the utmost gravity, calling for immediate thoracostomy. Exploratory puncture should be performed as soon as the least clinical sign of infection occurs. It is not possible to be sure that the infection has not occurred without a bacteriological examination of the fluids. If no fluid is withdrawn, or if the fluid be sterile and show no excess of polynuclear cells, the examination should be repeated after a few days, should suspicious physical signs continue. Sometimes the exploring needle fails to enter the infected area, or it may enter into a localized volume of gas, localized blood clot, or, if old adhesions be present binding lungs to pleura at certain points, the needle may pass through these adhesions directly into the lung. In these later cases, no fluid may be withdrawn into the syringe. If sterile clotted blood be drawn off, the needle has most probably entered a vein, for hemothorax fluid is always uncoagulated, except in some cases where the soft secondary clot has formed. This latter can, however, be readily recognized. Examination of hemothorax fluid. The physical characters of the fluid should be noted, and a direct microscopic examination made, followed by a cultural examination if necessary. Physical characters. 4 types of samples of hemothorax fluid infected with anaerobes are described by Elliott and Henry. 1. Blood, with an offensive odor and an intense purple color, which is darker and more transparent than that of venous blood. This fluid contains dissolved hemoglobin from hemolysis of the red corpuscles, and consequently it will show up a crimson froth in the barrel of the syringe. The crimson purple color is in itself almost characteristic of an abundantly growing infection by anaerobic bacilli. But the foul smell is the chief criterion, and it may be accepted as sufficient proof of infection. From such a sample, on standing, a large, flocculent deposit of reddish-brown pus may fall down, but the eye cannot recognize the presence of this pus in the freshly drawn sample. In some of these cases, the needle may find at first only offensive gas under pressure and fail to withdraw any fluid. 2. A fluid that is obviously loaded with pus, reddish pink or deep buff in color, and either slightly or not at all offensive. 3. A red fluid like that of an ordinary sterile hemothorax and inoffensive. Microscopic examination of this fluid in films shows a moderate increase in the number of polymorphonuclear cells, and bacilli appear on culture. 4. A yellow serous fluid with the usual fine gelatinous secondary clot on standing and the same findings under the microscope as in 3. From our own experience, we would say that in a series of cases in which samples are drawn off when there are suspicious clinical signs of infection, the physical characters of the fluid are briefly as follows. The fluid may stink, may contain pus, may contain hemolyzed blood, as shown by the permanently crimson froth or crimson supernatant fluid after centrifugalizing, or may appear to be simple dark, odorless, coagulated blood. The foul odor, of course, denotes anaerobic infection in every case, and we agree that this is the only criterion of infection that can be accepted at once without further study. Many fluids, however, which are quite odorless, contain not only aerobes but anaerobes, and in the absence of odor, no matter what other physical characters may be, further examination is indicated. In a few cases, yellow serous fluid may be withdrawn, and extremely rarely, chyle may appear and bear a superficial resemblance to pus. Direct microscopic examination. This is a very valuable and rapid means of determining whether a given fluid is infected or not. Elliott and Henry found that in 90% of cases which were subsequently proved by culture to be infected, organisms were found in these direct films. In our own series of cases we obtained a precisely similar result, and found, moreover, that in most of the odd 10% or so, most of the fluids, although showing no organisms, yet contained a distinct polynuclear leukocytosis, which we came to regard as definite evidence of infection. Thus, by this simple method, which need not take more than a few minutes to carry out, a reliable preliminary report can be given in some 90 to 95% of the cases. The technique, which we prefer, is as follows. A smear is made from the fluid, or, if necessary, from its centrifuge deposit, upon each of 2 slides, dried in the air and fixed by heat. The first is stained by Kuhl's carbomethylene blue for 3 minutes, and the second by Graham's method. The carbomethylene blue stain has already been described, but it may here be repeated that it gives a beautiful picture by which cells and organisms which are stained deep blue stand out prominently from the mass of red blood corpuscles, which are stained green. The leukocytes and other cells can be picked out at once in the field. The nuclei, much more deeply blue than the cytoplasm, and the organisms, which are also deeply stained, can be very rapidly picked out, especially if intercellular, when they show up well against the light blue background of the cytoplasm. If no organisms be seen, a rapid differential leukocyte count can be performed, and the point determined whether any considerable excess of polynuclears exists. Graham's method of staining, with carbofuscin 1 in 20 for the counterstain, moreover, gives a fair idea of the type of organism present. It is particularly useful for staining the anaerobic bacilli, which stand out as large, stout, gram-positive, non-sporing, capsulated rods, single or paired, e.g., B. perfringens, or large sporing bacilli, e.g., B. sporogenes. The presence of such organisms in direct films is for practical purposes, in routine work, sufficient for a preliminary diagnosis of anaerobes. It must be remembered, however, that sporing aerobes of the subtilis menstruicus type do occasionally occur in hemothorax fluids. These latter organisms are usually freely sporing, occur in long chains, and have filamentous forms. But these features may also in places be displayed by anaerobes, and these sporing aerobes cannot really be distinguished from the anaerobes by any morphological features in direct films. We have not, however, encountered a single case in which these aerobes were unaccompanied by anaerobes in hemothorax fluids, and if they do occur separately, it must be a rare occurrence, and the chance of confusing the two groups by the appearance of films is therefore very small. Certain other organisms can be picked out readily in these direct films. Where organisms are numerous, Streptococcus in long or short chains, Staphylococcus, Sarcinae, M. terrigenus, B. influenzae, the groups of diphthorioid bacilli, gram-positive, and of coliform bacilli, gram-negative, and sometimes pneumococcus, gram-positive, and large gram-negative diplococcus of the M. cartahalis type can be distinguished. Where organisms are scanty, the cocci, especially Streptococcus, generally occur in diplococcal form and are usually all intracellular. Among these, the Streptococcus, which is the most important aerobe, can usually be picked out by the relatively large oval shape, by the arrangement, and by the gram-positive staining of the cocci. Such are the features commonly found in these direct films, and it can be seen that if there be any need for an immediate report, a very valuable preliminary one can be given almost at once, and, indeed, no further examination may be required in a large number of cases. It is obvious, however, that no definite identification of these organisms can be made without cultures, and that cultures are especially required, 1. Where no organisms are found in direct films, and for exact work; 2. Where stout gram-positive bacilli are found, for the certain differential diagnosis between relatively harmless aerobes and the gas-producing anaerobes. Cultural examination. The following cultures should be put up. 1. Agar tubes or plate containing several cc's of the hemothorax fluid. The latter fluid is rich in protein, and when it is mixed with agar, a culture medium adapted for the needs of the most delicate organisms is obtained. 2. Litmus milk, made anaerobic by running sterile paraffin oil on the top. 3. Broth tube, made anaerobic by any convenient method, page 78. From the agar tubes or plate, the various colonies of aerobic organisms can be picked off and identified either by microscopic examination or by further subcultural methods. The litmus milk is a most useful medium for the determination of the presence of anaerobes. The most usual reaction where anaerobes are present is the production of the Purfingens reaction, or some modification of it, e.g., that which involves as an additional feature the digestion of the casein clot. The latter is a sign of the presence of other organisms. If the Purfingens reaction be not obtained in typical form, 1 or 2 subcultures in milk will often produce the desired effect, and no doubt can then be entertained of the presence of B. perfringens. This organism does not spore in milk, and hence it can be killed off by heating the milk culture to 80 degrees Celsius for half an hour. The latter will then still contain the sporing organisms, which can be recovered by pursuing the investigation in various ways. A convenient method is to subculture into another milk tube made anaerobic, and to examine for the reaction produced by B. sporogenes, which is the next most common anaerobe. B. sporogenes produces a certain amount of gas and clot in milk, but with a slow digestion and deposit of the clot, leaving pink, translucent, supernatant fluid after several days. Films made from this culture contain the typical sporing bacilli. These 2 organisms can be further identified by the cultural tests given on pages 68 to 71, and if pure cultures are desired, it is better to subculture once or twice in an alkaline glucose meat-containing broth before plating out anaerobically upon agar. By the above milk method, the Purfingens group can usually be identified within 24 hours, and the sporogenes group within a day or 2 longer. The anaerobic broth culture supplements the milk method, for the latter may fail to yield all anaerobic organisms present, owing to the excessive acidity which is produced in the milk tube. From the broth culture, anaerobic tube or plate cultures should be made at intervals of a few days up to a fortnight. The saccharolytic anaerobes develop most quickly in the broth culture, and they can be obtained almost pure during the first 2 or 3 days. After this, the protolytic group develops more strongly, and within a few days more, they come to replace almost completely the heteroglyptic organisms. B. tetani is difficult to obtain in pure culture, but it may sometimes be obtained by plating out from the broth after about a fortnight's incubation. Thus, if anaerobic tube or plate cultures be made from the broth on the 3rd, 7th, and 15th days of incubation, colonies of most of the anaerobes present can be obtained. Their further identification depends upon subcultural tests, especially with regard to the sugar reactions. Summary. 1. In routine work, the whole of the scheme detailed above need not be followed. 2. Practical question 1 is the fluid infected? The criteria of infection are briefly as follows. A. Physical characters, the presence of odor. B. Microscopical examination, the presence of organisms or the presence of a definite excess of polynuclears. C. Cultural examination, a growth of any organism. Practical question 1 can in 90% or more of the cases be settled in a few minutes by the findings under A and B. In the odd 10% or so, it can be settled within 24 hours by the findings under C. 3. A report on the question whether or not a fluid is infected should be written within 24 hours in order that, in the former case, thoracostomy can be performed forthwith. 4. If the fluid be sterile, the puncture should be repeated in all cases where suspicious clinical signs continue, as the exploring needle may at times fail to withdraw infected fluid, even though the latter be present in the chest. 5. Practical question 2 is, what is the nature of the infection? This may be important from the point of view of prognosis and treatment. A purely aerobic infection is usually the least dangerous. A purely anaerobic one is immediate, and a mixed infection, especially if gross, is the most dangerous, provided that in all cases thoracostomy be performed. The special dangers associated with anaerobic infection are spreading gas gangrene production and anaerobic or ptomaine toxemia. 7. To decide the nature of the infection, the methods of examination A, B, and C should be followed out, but in the case of C, only so far as may be necessary in each particular example. The aerobic culture should be made in every case, and for anaerobes, the milk method should be used at least so far as to determine the presence or absence of the perfringens and sporogenes group. These are the most important representatives of the two groups of anaerobes. The report on such a modified investigation can be given within 2 or 3 days. Symptoms. The earliest symptom of a penetrating wound of the chest, as seen on the battlefield, is hemoptysis. It is immediate and variable in amount, but as a rule the degree is small. The onset of other symptoms varies. In a large percentage of cases, these men fall when hit, and at first there is no feeling of terror. The faces betoken this, though as a rule these wounded men are quiet and talk little. This early anxious facial expression is a most constant accompaniment to chest wounds. There are, however, on the other hand, the few whom a perforating wound of the chest will not stop, and we have instanced 2 cases in a preceding paragraph on page 502. Symptoms of hemothorax. These will entirely depend upon the amount of extravasated blood. If the amount be considerable, respiratory distress with a degree of cyanosis will be present. If the amount be excessive, the lips are of a pale cyanosed hue. Dyspnea with air hunger is present, the apex beat and cardiac dullness are displaced, and with this is superadded cardiac embarrassment. Physical signs are those of fluid in the pleural cavity with certain differences, for a hemothorax, unlike a serious effusion, soon becomes shut off by a zone of fibrous adhesions formed between the chest wall and lung. Further, the portion of lung which is not in contact with the effused blood rapidly shows a large degree of emphysema. This rapid appearance of a well-marked emphysema is almost pathognomonic of hemothorax clinically, and this condition has been emphasized by Elliott and Henry from their findings in such cases at autopsy. There is dullness to percussion, with loss of voice and breath sounds, and loss of tactile fermentus over the submerged portion of the lung, while over the emphysematous area there is a scodaic resonance, which would lead one to suspect pneumothorax. Over this latter area, the breath sounds are almost similar to what one hears on putting the stethoscope over the trachea, and expiration is unduly prolonged. This compensatory emphysema often extends across the middle line, and post-mortem findings have shown that the emphysematous portion of the lung is pushed up against the chest wall, leaving the markings of the ribs upon its surface. The cardiac dullness in extreme cases may be displaced as much as 3 to 3.5 inches to the right or left, depending on which of the two lungs is damaged. The evening temperature of a simple hemothorax may reach as high as 102 degrees, returning in the morning to between 99 and 100 degrees, or, on the other hand, the oscillations may not be quite so great. Where the effusion is small in amount, there may be no symptoms beyond dullness rising to a certain level, with a slight rise in the evening temperature. There is no distress, and these patients are comfortable and happy while sitting in a chair. Symptoms of pneumothorax. If the pneumothorax be traumatic, the lung is in part collapsed, and with this there may be cardiac displacement, increase in the respiration rate, dyspnea, and cyanosis. To percussion there is scodiac resonance, and to auscultation there are distinct or vanished voice and breath sounds. There is also present the brut d'aérienne, or clang, heard through the thoracic cavity on the affected side, when coins are clinked together on the chest wall. Should the pneumothorax be of the infective type, then, in addition to the above symptoms, there are those of a grave toxemia. The patient looks sallow, the tongue is dirty, there is loss of appetite, and the temperature is swinging, reaching 103 degrees, rarely higher, in the evening, returning to 99 degrees in the morning. Accompanying these symptoms are evening sweats, and the patient wastes with alarming rapidity. Chylothorax. This is a difficult condition to diagnose, as it is invariably associated with hemothorax. The only actual proof of the condition existing would rest on examination of some of the aspirated thoracic contents. We inferred that this condition existed in 2 of our cases of uncomplicated hemothorax, though we had no direct proof. But these patients wasted to a remarkable degree, although the chest contents were proven culturally to be sterile. It did not strike us at this particular time to look for fat globules, or make any further examination for the presence of chyle in the aspirated contents. Both patients recovered, having begun to put on weight in the 4th week after injury. The symptoms of this condition would, then, appear to be rapid wasting and the presence of chyle in the aspirated chest contents. Pyothorax. In addition to all the physical signs of fluid, there are superadded symptoms of toxemia. The temperature is swinging, reaching as high as 103 degrees in the evening, returning to normal or below normal in the morning. The patient is sallow and toxic, his tongue is dirty, his appetite is poor, he sweats at night, and rapidly wastes. Pyohemothorax. The symptoms are identical with those mentioned for pyothorax, except that the evening temperature is not so high and toxic symptoms not so severe. The steady temperature of a hemothorax after the latter has become infected assumes a swinging character and may rise a little each evening, coming down lower in the morning. Pneumohemothorax. Here the symptoms are those of a combined pneumothorax and hemothorax, with an infection of a severe type superadded if the pyothorax be infective in origin, but less severe toxic symptoms if the pyothorax be due to traumatism. Surgical emphysema. The symptoms here are those of an inflation of the subcutaneous tissues with air. The inflated tissues are both crepitant and tympanitic. Septic bronchopneumonia. Symptoms of this condition differ in no way from those described in textbooks on medicine and need no further comment here. Should the patient survive long enough, an emphymia is very likely to develop, and this should always be borne in mind. Mediastinitis. With this condition, there are associated pleural friction sounds with pleural pericardial rubs. The pleural friction sounds usually occur along the anterior margin of the lung. There is often present a frequent, painful, irritating cough, besides considerable intrathoracic pain. Almost invariably complicating this condition is pericarditis and pleurisy, due to direct spread of the infection to the pericardium and the pleura. Mediastinitis is associated with a temperature rising in the evening to 103 degrees, returning to just above normal in the morning. Pericarditis. Symptoms differ in no way from those described in textbooks on medicine and call for no further comment here. Abscess of the lung. A patient may be progressing well up to the 5th or 6th day after injury, when he suddenly becomes seized with dyspnea and cough. The expectoration, which is fairly profuse, may consist of odorless or foul-smelling pus, which may or may not be blood-stained. Auscultation will reveal scattered rhonchi and crepitations over an area, the extent of which increases daily, involving further dyspnea and distress. At this stage the patient may die, or he may survive long enough to show the further complications of this condition. Thus, a day or two later, there may be a profuse hemotypsis, from which death results, or gangrene of the lung, with its unmistakable characteristic odor, may supervene and end the case. Amphoric breathing in the case of lung abscess following gunshot wounds has invariably been absent, its place being taken by signs of consolidation and scattered crepitations. The crepitations are not confined to the damaged lung, but are present in the contralateral organ. In fact, associated with the abscess is almost invariably a septic bronchial pneumonia of both lungs. Diagnosis. In the diagnosis of gunshot wounds of the chest, great assistance can be obtained from the temperature chart and the general appearance of the patient. The fact that a patient has a penetrating wound of his chest and has coughed up some blood-stained sputum is sufficient to determine that the lung has been damaged. Cyanosis, dyspnea, cardiac displacement with signs of fluid or air in the pleural cavity of the affected side following soon after the injury will denote the presence of a hemothorax or of a pneumothorax. If, after the 10th day, the temperature becomes irregular, the patient looks ill and begins to lose weight, it is almost certain that the infection of the hemothorax or hemopneumothorax has occurred. Should, however, an uncomplicated hemothorax after the 10th day show symptoms of a pneumohemothorax, then the presence of gas-forming anaerobes should be suspected. At this stage, a needle should be inserted and some of the pleural fluid withdrawn. This fluid may either be pus, in the case of a pure pyrothorax, or chocolate-covered, with or without an offensive odor, in the case of an infected hemothorax. Should an evil-smelling, chocolate-covered fluid be aspirated in the case of an uncomplicated hemothorax, which has developed into a case of pneumothorax, then infection by gas-forming anaerobes is present beyond all doubt. In all cases, the aspirated fluid should be sent to the bacteriologist for examination and the nature of the infection ascertained. An X-ray will show the position of the missile in the chest and whether or not it is embedded in the lung tissue, the mediastinum, or the chest wall. A foul expectoration following on the 4th day after injury, while the missile is still in the lung, associated with an area of consolidation, with scattered rhonchi and crepitations in one or both lungs, is strong evidence of lung abscess. Gangrene of the lung is unmistakable by the pungent characteristic odor of the breath which accompanies it. An uncomplicated wound of the chest, or wound associated with an uncomplicated hemothorax, if there be marked wasting with it, a rare event, should arouse suspicion of injury to the thoracic duct. Aspiration should be performed with the object of detecting the presence of chyle in the thoracic contents. Mediastinitis is readily recognized by the pain it occasions, by the cracking crepitations along the anterior borders of the lungs, by the presence of temperature and pleural pericardial rubs, and frequently by an accompanying pericarditis. The position of the missile as shown by X-ray may be of help in the diagnosis. Wounds of the chest associated with paraplegia and paresis denote spinal involvement. Some cases, on the other hand, are complicated by severe spinal concussion, where the spine itself shows no gross lesion. If this be the case, then the missile may have injured structures adjacent to the spine, e.g. a rib, the concussion occasioned being sufficient to give rise to symptoms of paresis. A lumbar puncture should always be performed in case of doubt and the presence or not of blood in the cerebrospinal fluid ascertained. Wounds of the chest may or may not involve the abdominal viscera. Many thoracic wounds, in which the diaphragm has escaped, give rise to abdominal symptoms. Thus, there is rigidity of the abdominal wall on the side corresponding to the lesion, with apparent pain and tenderness of a general kind on palpation, this being due to an attempt to splint the injured side of the chest. Vomiting is almost always absent in these cases, and the patient can pass both urine and flatus. Further, in a few hours the abdominal rigidity and pain pass off. Many wounds of the thorax do, however, traverse the diaphragm and involve the abdominal viscera. The viscera most commonly involved are the liver, spleen, and stomach, though the large and small intestine are not exempt. persistent vomiting, abdominal rigidity with retraction, and inability to pass flatus and urine are the most constant and reliable symptoms of abdominal injury. Prognosis. Uncomplicated cases of hemothorax invariably do well. The temperature usually settles in from a fortnight to 6 weeks, depending upon the amount of extravasated blood. Uncomplicated cases of traumatic pneumohemothorax also do well. The pneumothorax is soon absorbed, and the progress of these patients differs in no way from that of hemothorax. Pyothorax, pyohemothorax, and pneumopyohemothorax are serious conditions, especially the last. Yet if early exit be given to the infected chest contents, the outlook is good. Out of 30 such cases, we had 5 deaths, and of these 5 deaths, 3 were severely complicated by other wounds. This gives a mortality of 16%. Septic bronchopneumonia and lung abscess, secondary hemorrhage, hemoptysis, gangrene, mediastinitis with pericarditis are all very fatal conditions, and unfortunately but few recover. Surgical emphysema, though of the most extensive kind, vanishes very quickly when once the rent in the chest wall has been closed, and the prognosis is good. Treatment. Treatment will depend upon the presence or absence of infection. Infection in chest wounds, as in every type of wound in this war, is the main problem that the surgeon has to face. Many chest wounds, as seen at the base hospital, do not go on to infection, for out of a special series of 150 consecutive cases, infection occurred in 42, that is, in 28%. Treatment in the line will depend upon whether the wound in the chest wall is patent, that is to say, whether there is open communication between the pleural cavity and the atmosphere. If such communication exists, the wound should be immediately plugged with gauze, and a first field dressing or shell dressing firmly applied over this. The wounded man should then be removed to the advanced dressing station as quickly and as quietly as circumstances permit. A quarter of a grain of morphia can be given at once hypodermically, and this should be noted on the tally. A penetrating wound not involving a direct communication between the lung and the exterior should be dressed, and the wounded man carried back. In a number of instances during an action, this type of wound has not debarred a man from walking to the advanced dressing station, and apparently no harm has come of it. During such strenuous times this may be encouraged, for by this means evacuation of the wounded is hastened at a time when stretcher-bearers are busy with the more helpless cases. All cases of chest wounds, as far as it is possible, should be sent direct from the line to the nearest casualty clearing station. Treatment at the casualty clearing station. On arrival at this unit, all chest injuries are put to bed with as little delay as possible and are nursed in the upright or semi-recumbent posture. The only conditions calling for immediate interference are 1. Severe dyspnea with excessive cardiac displacement, 2. Hemorrhage associated with a large open rent in the chest wall, 3. Chest wounds complicated with injury of the abdominal viscera, and 4. Extensive surgical emphysema. 1. Severe dyspnea with excessive cardiac displacement may be due to one of 2 conditions. 1. A traumatic pneumothorax of an extensive kind due to injury of the chest wall. 2. An extensive hemothorax. Where a pneumothorax exists owing to either an extensive or small wound of the chest wall, the hole in the parietes must, if possible, be closed. If this be impossible, or if it involve an operation which the patient at this stage could not stand, then the hole must be plugged with sterile gauze after excision of the wound. If the wound in the parietes is large, a Carroll-Dakin dressing should be applied after the breach in the wall has been plugged. Where cardiac displacement and dyspnea are present, the pneumothorax must be decreased, and this can best be done by fitting a Sprengel's apparatus to the hole in the chest wall, packing carefully around the tube which enters the pleural cavity. Adhesions soon form between the lung and the parietal pleura in the neighborhood of the rent, and the pleural cavity is thus shut off. In the majority of cases, plugging the hole is sufficient, as the air in the pleural cavity is rapidly absorbed, and the absorption brought about by a Sprengel's pump may occasion hemorrhage if a wound of the lung be present. When an extensive hemothorax exists, which is giving rise to urgent symptoms, one of 2 courses may be followed. 1. Aspiration. 2. Thoracostomy. Aspiration is performed in exactly the same manner and with the same aseptic precautions that are observed in regard to aspiration of any bursal sac. The chest wall over the site of the proposed puncture should be thoroughly cleaned with ether soap, then rubbed over with ether, and finally painted over with iodine. The needle should then be introduced through an intercostal space, low down in the area of dullness, preferably in the case of extensive hemothorax, in the posterior axillary line. The fluid should be drawn off exceedingly slowly, as rapid evacuation is very apt to be followed by syncope, which may easily prove fatal. No more than 20 ounces should be drawn off at one sitting, and this is quite often sufficient to relieve urgent symptoms and make the patient more comfortable. Never forget to have brandy and strychnine at hand when performing aspiration. Dangers attending aspiration. These are 1. Syncope, 2. Risk of further hemorrhage from the lung. Syncope invariably follows the too rapid evacuation of the chest contents, and if the precaution against this error be observed, it will rarely occur. Should it happen, then strychnine, 1/30 of a gram, with brandy is the best treatment. Risk of further hemorrhage from the lung is a very real danger, and results in aspirating too much material at one sitting. We have seen this happen in 5 cases, and at the time of writing we have examined a further case at autopsy. In this last named case, 90 ounces of blood had been aspirated from the left chest, 30 ounces per day on 3 successive days, at the clearing station to relieve respiratory distress. On admission, the patient was blanched. Though the cardiac apex was pushed well over from its normal situation, the dyspnea was more a true air hunger than that due to collapsed lung and cardiac displacement. He died on the 10th day after admission to the base hospital, autopsy revealing the left side of the chest to be full of sterile blood, the whole lung being entirely collapsed. Here it was evident that as rapidly as the blood had been aspirated, it had been replaced by fresh blood, so increasing the dyspnea. The amount of blood in the pleural cavity, with the 90 ounces that had been aspirated, was sufficient to have caused death, for on admission and during the 10 days in the base hospital preceding death, this man was extremely blanched. 24 hours before death, he showed a bluish-white color of the lips, that is to say, an element of kynosis was present. This was undoubtedly explained by the fact that he had now only one lung to aerate a quantity of blood, which at the same time was too deficient to supply all the body needs. We have had similar cases which have been extremely blanched, owing to a copious hemothorax, and in which there had been excessive displacement of the apex beat. But we have often seen recovery take place in these cases without anything being done. It is a very sound axiom to avoid aspiration in the case of extensive hemothorax where the patient is blanched, unless it be absolutely necessary. The immediate dyspnea in these cases is usually due to loss of blood from the general circulation. If, however, the surgeon can definitely convince himself that the dyspnea and distress are due to mechanical causes brought about by the hemothorax, then aspiration, as above described, must be undertaken. Thoracostomy has been advocated in conditions of extensive hemothorax, the arguments in favor being 1. Evacuation of the extravasate blood, and so forestalling a possible pyhemothorax or pneumohemothorax. 2. Procuring collapse of the damaged lung by the pneumothorax produced, and so avoiding any risk of further hemorrhage. 3. Possible repair of the damage done to the lung and removal of the missile. We think that a thoracostomy in cases of extensive hemothorax has much to recommend it, and though we have not given it a very extensive trial, yet a few of the cases in which it was adopted, so far as we know, did well. Of 40 cases operated upon for this condition, we were able to follow through 10 of them, the remainder being evacuated from a casualty clearing station with every promise of doing well, though we cannot give their subsequent history. The 10 cases who were kept until they were convalescent followed the ordinary course of a thoracostomy performed for emphysema, and in not one of them did we observe further hemorrhage. The chest wound healed within periods varying from a fortnight to a month, and at the end of 6 weeks these men left as walking cases for hospitalship, able in every way to look after themselves. Operation. After thoroughly cleaning the chest wall and preparing the skin, an aspirating needle with syringe attached is passed into the chest at the lowest area of the dullness, and a small quantity of fluid is drawn off. A piece of rib about 2 inches long immediately above the space that the needle has entered is resected, after peeling off the periosteum in the usual way. A small opening is now made through the parietal pleura, and the contents of the hemothorax slowly evacuated, at the same time slowly inducing a pneumothorax. This proceeds until the pleural cavity is empty of blood and full of air. A large-sized rubber tube is now introduced, which drains any further blood and at the same time maintains the pneumothorax. We have always selected for the site of thoracostomy a point as low down as possible on the posterior axillary line. Dressings are changed daily, and at the end of a week the tube may be omitted and the wound allowed to heal. Some surgeons elect to perform a thoracostomy higher up, but we can see no advantage in doing this, since any damage which has been done to the lung invariably rights itself when once the lung has collapsed. We have always employed chloroform anesthesia for these operations, and have never seen any harm come of its use. Another method of procuring a pneumothorax to secure the same end is that of simultaneous aspiration and inflation of the pleural sac with an inert gas such as nitrogen. The method can be carried out slowly and without an anesthetic, and good results have been claimed from its use. The method requires both elaborate apparatus and considerable skill and experience on the part of the surgeon who undertakes it. Whenever possible, we have invariably left an uncomplicated hemothorax to nature, and the more we see of such cases, especially at a base hospital, in which they have for military reasons to be kept until they can walk and look after themselves, the more we are day to day becoming convinced that the percentage of cases of uncomplicated hemothorax requiring surgical interference is remarkably few. 2. Treatment of hemorrhage associated with a large open rent of the chest wall. The pleural cavity in this class of wound is necessarily infected, yet, like other serous sacs, it can well resist infection if put under the best conditions to do so. We must then consider both treatment of the wound in the thoracic parietes and treatment of the pleural cavity. The thoracic parietes. Excision of the wound, after a thorough cleaning of the skin and shaving of the axilla, should be carried out. Broken pieces of rib must, if soiled, be removed, and sharp protruding ends of ribs must be clipped away with bones forceps. The divided intercostal arteries must be clamped and ligatured, and a Carroll-Dakin dressing applied, if it be impossible to close the wound by a primary suture. The pleural cavity. A small piece of rib is next resected at the lowest point of the pleural cavity, and a large rubber tube inserted. This removes at once any serious exudate which may have collected in the cavity, and which is so apt to become infected. At the same time, a Carroll's tube may be left in the original wound, and a 0.25% solution of the hypochlorite of Dakin can be instilled 2 hourly, 2 drachms at a time, into the pleural cavity. At the end of 72 hours, if the original wound be clean, which should be the case, the lower tube can be omitted and the wound allowed to heal, at the same time discontinuing the instillation of the antiseptics into the pleural cavity. The original wound should now be dressed with every antiseptic precaution, the hole in the chest wall remaining plugged with sterile gauze wrung out of Dakin solution, while the wound in the tissues continues to receive the Carroll-Dakin treatment until it is bacteriologically sterile. This accomplished, the hole in the chest wall can either be closed by a suitably devised plastic operation, or it may be allowed to granulate and finally skin grafted if necessary. 3. Chest wounds complicated with injury of the abdominal viscera. A penetrating chest wound must not deter the surgeon from undertaking a laparotomy for repair of the damaged viscus. Fortunately, a severe chest and abdominal wound rarely coexist, but if they do, the abdominal wound comes first. Chloroform anesthesia should be employed, and the necessary laparotomy quickly carried out. This done, the chest wound, if necessary, can next receive attention on the lines already laid down. 4. Extensive surgical emphysema. This is most satisfactorily treated by excising the valve-like breach in the parietes and either suturing or better plugging the hole in the chest wall with a piece of gauze wrung out of Usol or Dakin solution. It is surprising with what rapidity the emphysema disappears when once the hole has been satisfactorily plugged. Treatment of complications. Complications most frequently seen at the casualty clearing stations are septobronchopneumonia, lung abscess, mediastinitis, and pericarditis. Pneumonia not only attacks the injured lung, but also the contralateral organ. The outlook in these cases is extremely grave, and the treatment rests with the physician. We have obtained discouraging results in this connection from the use of autogenous vaccines and needling the lung. The latter process consists in inserting an exploring needle into the substance of the affected lung. One puncture of the thoracic parietes will suffice for many punctures of the lung substance. At the same time, some blood-stained fluid is aspirated from the lung, and this forms the substance for the preparation of the autogenous vaccine. Stimulants and expectorants combined with digitalis should be prescribed and a nourishing, easily digestible diet given. Lung abscess. This extremely grave complication is usually the result of a piece of missile and clothing embedded in the lung, or spicules of bone may also be present. The missile must be accurately localized by means of the X-ray and a needle inserted with a view to striking the abscess cavity. If this be successful, thoracostomy should be undertaken with a view to removing the foreign body and draining the abscess cavity. We managed this successfully in 2 cases, though we failed in many others. Both cases died as a result of septic pneumonia, which was already established in both lungs. It is hardly worthwhile anticipating the condition, as so many cases with a foreign body embedded in the lung have escaped complications of this sort, and, after all, lung abscess is not common. Wherever a lung abscess develops as the result of a foreign body, it is, we think, worthwhile to try and remove the foreign body if the X-ray shows it to be accessible. At the same time, an autogenous vaccine should be prepared and given a trial, as we have had encouraging results from its use in the cases of lung abscess due to septic emboli. Mediastinitis and pericarditis. These 2 fatal complications, when once established, are amenable to no form of treatment. Treatment here should be prophylactic and consists in the entire removal of the foreign body, if possible, for that is the invariable cause. Mediastinitis, with a complicating pericarditis, is most often associated with gunshot wounds which have fractured the sternum, and in most cases the foreign body is lying just inside the anterior mediastinum, or wedged in between 2 fractured segments of the sternum. The wound should be excised and a Carroll-Dakin dressing applied. Cases of chest wounds, if possible, should be kept for from 5 to 10 days, according to severity, at the clearing stations before evacuation to the base, as they stand early removal by transport very badly. Treatment at the base hospital. The base hospital is concerned with the more remote complications which are invariably the result of infection. These are 1. Pyothorax, 2. Pyohemothorax, 3. Pyopneumohemothorax, 4. Chylothorax. In addition, the base hospital receives cases of unresolved, uncomplicated hemothorax and hemopneumothorax. Treatment of uncomplicated hemothorax and hemopneumothorax. By the time the cases reach the base hospital, the hemothorax is localized, that is to say, the barrier zone of adhesions between the unsubmerged margin of the lung and the parietal pleura has formed, and the hemothorax is shut off. These cases are kept in bed for 2 or 3 days after the journey to the base, and are then put into chairs and carried out of doors. No harm has ever come of this, and in every way the patients are better. During the hot season in the east, they have slept outside, carefully protected with a mosquito curtain. After 10 to 12 days' treatment in bed and sitting up in a chair, they are allowed to get up and walk. Again, this procedure has been followed by the most beneficial results in every case. Chest wounds in the east seem to do better and convalesce quicker than similar cases in the west, and there is no doubt that the warm, dry climate is more suitable to them. At the end of 6 weeks from the day of their wound, these men are fit to travel and to look after themselves on hospital ship should any emergency happen during the voyage. Treatment of septic complications. Conditions 1, 2, and 3 call for the same treatment, viz., thoracostomy. Pyothorax may be localized and occur between the lobes of the lung. Any case of apparently uncomplicated hemothorax should, if the temperature suddenly become irregular, be submitted to an exploratory aspiration. If evil-smelling contents in the form of a chocolate-colored fluid or pus be withdrawn, then operation should not be delayed. If, however, a chocolate-colored and odorless fluid be withdrawn, it should be immediately sent to the bacteriologist for investigation. Should he report infection, then operation must be performed at once. If a case of hemothorax suddenly becomes one of pneumohemothorax, this is invariably due to the presence of gas-forming organisms, and evacuation of the contents of the pleural sac is immediately called for. The operation should be designed so that the drainage can take place from the lowest point of the pleural cavity. The mistake so frequently made is a too high up opening, leaving the recessus pharyngicocostalis, an undrained sump in which septic material collects. We have in addition made 1 or 2 small stab wounds into the upper part of the cavity and inserted Carroll's tubes, instilling 1 or 2 drachmas of a 0.25% hypochlorite solution hourly or 2-hourly into each. This does no harm to the pleura and brings about a more rapid sterilization of the pleural cavity. Further, it causes no distress or inconvenience to the patient. A week after operation, blowing exercises are practiced with a view to expanding the damaged lung, and at the end of the second week, these patients are allowed to walk. The large tube is omitted at the end of the 4th or 5th day, as the use of Carroll's tubes and Dakin's solution very rapidly clears away infection, and there is at the end of this period little or no discharge. The wound rapidly heals, and these patients are fit to travel and look after themselves at the end of 6 weeks following injury. Chylothorax. This rare complication calls for no treatment. It is probable that if the thoracic main duct be injured, the circulation of the lymph will be eventually made good via the insula of Cruikshank. End of chapter 20.
Chapter 21, Part 1 of War Surgery, From Firing Line to Base. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Dr. Beth Thomas. War Surgery, From Firing Line to Base, by Basil HUGHES and H. Stanley Banks. Chapter 21, Part 1 Gunshot Injuries of the Abdomen. Abdominal injuries form an interesting and fascinating branch of military surgery, and the ultimate results so far obtained have varied in the hands of different surgeons. This can in part be explained by the different conditions which obtain, that is, 1. The distance and condition of the roads between the firing line and the forward units at which the surgical measures can be carried out varies considerably in different localities. 2. Some wounds are received during quiet times, others while active fighting is in progress. 3. Some surgeons elect to operate upon the cases that others would leave alone, and their lists may in consequence show a higher mortality. Type of missile. Out of a large number of abdominal wounds caused by every type of missile, those caused by bombs or other kind of high explosive are the most serious. The least serious, if such an expression can be applied to them, are those caused by rifle bullets and shrapnel balls. Situation of the wound. Abdominal wounds suitable for treatment are either of the penetrating or perforating variety. The point of entry may involve the thorax, spine, back, perineum, buttocks, upper thighs, flanks, or the anterior abdominal wall. If the wound be of the perforating variety, the exit wound may occupy any of these situations. Thus, in one case of a penetrating abdominal wound, the point of entry was just behind the right clavicle, and the missile, a shrapnel ball, was found beneath the skin of the anterior abdominal wall in the left lower quadrant. We can recall a case of a perforating abdominal wound where the point of entry was over the supraspinous fossa of the left scapula, and the point of exit near the apex of Scarpa's triangle on the right side. The missile may take any course, depending on the position of the man when hit and its own direction with regard to him. Character of the wounds. Almost every type of wound has been seen in this connection, from the small penetrating or perforating variety to wounds of large dimensions involving large areas of the abdominal or thoracic parietes. The abdominal viscera may or may not be damaged, despite extensive damage to the abdominal parietes, and conversely, an apparently superficial contusion of the abdominal wall may involve extensive damage of the abdominal viscera. Damage done to the viscera varies. In the case of the small intestine, many perforations may be caused by one missile. The large intestine, which is a more fixed structure, does not escape injury, though it is rare to find multiple perforations involving it. Wounds of the ascending, descending, and pelvic colons show a marked early tendency to be shut off from the general peritoneal cavity. Multiple wounds of the small intestine show a similar tendency, but owing to their number and distribution, this is often impossible. Consequently, extravasation with general peritonitis will result. The gall and urinary bladders have been penetrated in a number of instances, the latter more commonly. Again, the damage may involve solid viscera. The liver and kidneys have been the most frequently involved, the spleen less often. It may happen that the viscera escape damage altogether, but that the mesentery is torn. If this be the case, and the rent is considerable, then severe intra-abdominal hemorrhage is the usual result, and this is extremely fatal in a large percentage of cases. Should a large artery be involved, such as the aorta or the iliac vessels, death follows very rapidly. Wounds in the back, giving rise to abdominal symptoms, may not have opened the peritoneum. It is very common indeed to find in this connection a retroperitoneal hematoma, and in some cases when the missile has bruised the ascending or descending colon, a fecal fistula has formed along the track of the missile. Infection of abdominal wounds. Small penetrating or perforating abdominal wounds, though invariably infected, do not show the same degree of infection as wounds in other parts of the body. This is probably due to the greater ability of the peritoneum to deal with infection. In only one case of penetrating abdominal wounds have we seen gas gangrene in the peritoneal cavity, and this had occurred in a hematoma that was completely shut off in the right iliac fossa. Where a retroperitoneal hematoma exists, gas gangrene is very liable to occur if the missile and blood clot are not evacuated. Large tears of the abdominal wall are just as likely to become infected as large wounds in other parts of the body. A hematoma of the abdominal wall, the result of a contused wound, is liable to suppurate. A few such cases have passed through our hands, and the infection has proved to be a mixed one, B. coli being present in 3 out of 5 cases. Complications of the abdominal wound. An abdominal wound may be complicated by 1. Fracture of bone, 2. Chest injuries. Fracture of bone. The abdominal walls consist of both soft and bony structures. Thus, it is not uncommon to find penetrating abdominal injuries associated with compound fracture of the innominate bone, the vertebral column, or the ribs. If the fracture be very comminuted, pieces of bone may be carried in by the missile into the peritoneal cavity and cause grave damage to the viscera. There is also the risk of the fractured bone becoming infected, and this in gunshot wounds is usually the case. Paraplegia may or may not be present if the vertebral column has been injured, but should it occur, the prognosis is extremely grave. Early observations in cases of abdominal wounds. Former experience with a regiment has been invaluable in giving opportunities of observing cases of wounded men who die in the line or at the regimental aid post, and so never reach a clearing station or a field ambulance. It also gave opportunities of observing other important points in relation to abdominal injuries. We found that penetrating abdominal wounds, with the exception of those complicated by severe intraperitoneal hemorrhage, do not at once, or indeed for hours, if kept quiet, give rise to the abdominal symptom complex. The symptom complex is present by the time the wounded man reaches the casualty clearing station, as we witnessed, and after the motor journey this could not be wondered at. What so strongly impressed us was the difference in the general condition of such wounded men seen in the line and seen a few hours later at the casualty clearing station. So long as the men were not moved immediately, severe shock did not follow for many hours, if at all, in the case of many abdominal injuries. The following instances seen in the line may be quoted to illustrate how long shock may be delayed even after the most extensive and rapidly fatal abdominal injuries. Private wounded by a trench mortar, anterior abdominal wall in great part taken away, with complete prolapse of the intestines which were apparently intact. One of us saw him immediately after it happened. He was lying in the bottom of a muddy trench, and his viscera was soiled. The pulse was slow, regular, and good. He talked sensibly, and having seen his own viscera, asked jokingly if they belonged to him. He drank some brandy and smoked a cigarette. This state of things lasted for 15 minutes. While trying to fix him up with shell dressings, he quite suddenly collapsed and died in a few minutes. The change was remarkably rapid. Private sustained a large shell wound, tearing open the greater part of his anterior abdominal wall. Complete prolapse of the intestines followed. 5 minutes after injury, the pulse was 88, steady and good. The man was conscious and talked sensibly. The viscera were covered as well as could be under the conditions, necessitating some handling, which rapidly induced collapse and death 17 minutes after injury. Lieutenant Corporal had his abdominal wall torn open by a bomb, exposing his viscera which prolapsed through the wound. Seen 5 minutes after injury, the pulse was 88, steady and good, and there were no symptoms of shock. He asked for a drink, which was given. He was also given strychnine and morphia. The viscera were lightly covered over. He talked sensibly, expressing himself strongly about the German who had done it. Shock set in after 17 minutes and he died a quarter of an hour later. These are 3 cases on which the above hurried notes were made at the time. The class of case was puzzling, and the following comments were made by one of us after witnessing somewhat similar cases, many of equal, others of less severity. In cases of extensive damage to the abdominal walls, where viscera were wholly or partially prolapsed, it is difficult to explain the latent interval, varying from 5 to 20 minutes, in which the wounded man is cheery, talking, smoking, and able to drink. This is followed by intense collapse quite suddenly, and death rapidly follows. In not one of these cases was peristalsis observed in the prolapsed viscera. The pulse and circulation in the mesentery were good. A hot cloth, had it been procurable, would perhaps have been useful, as the sudden collapse was always associated with handling the viscera, but this was impossible under the circumstances. It is almost certain that the majority of penetrating wounds of the abdominal viscera are followed immediately by arrest of gut peristalsis, and unless the gut is full of liquid material at the time, depending on the time of the last meal and its character, extravasation will be small. Whether stimuli, such as handling the gut, or the shaking of the wounded man during transport, can set up peristalsis in an injured viscus requires confirmation, but there is strong presumptive evidence to show that it does. We have many times been impressed by the fact that if these wounded men be carefully moved to a place of comparative safety nearby, it may be an old trench, a shell hole, or more luckily a dugout, given morphia and made as warm as possible, they stand a far better chance of recovery than if hurried back immediately to a casualty clearing station and submitted at once to operation. We are able to make this statement as a regiment is always early informed of the death of its wounded. Further, we have often had to keep such cases in the line as a matter of necessity, hence our opportunities of observing them for 48 hours or more. This was not a regular practice, because whenever circumstances permitted, all wounded men were without fail taken back with the minimum amount of delay. There is one exception to what has been said above, and that is the abdominal wound complicated by severe intraperitoneal hemorrhage. Here shock is immediate and severe, and any operation to be successful must be undertaken much nearer to the firing line than the present casualty clearing stations or field ambulances. 6 of these severe cases were operated upon by one of us in a dugout situated in the communication trench. 4 died and 2 recovered. The 4 who died had sustained severe damage to the mesentery. The 2 who recovered were hit in the spleen and had suffered severe hemorrhage. Splenectomy was performed in both cases. In this dugout it was possible to give saline and to keep abdominal cases if necessary. After the battle of from amongst a lot of dead and wounded men, a number of the survivors were rescued. The fittest of the survivors were men who were suffering from penetrating abdominal wounds, the result of machine-gun bullets. They could be easily discerned from the other wounded by the fact that they were lying on their bellies. They could talk sensibly and had good steady pulses, and this 48 hours after being hit. The remaining survivors were extremely ill and toxic, all being the victims of gas gangrene. This was not so in the case of the abdominal injuries, for in not one that we examined could we discover gas infection, and we ascertained from other medical officers that it was not present in cases they had seen. Many others were dead, having died from what could be seen at a hurried glance to be gas gangrene. The bodies were black, blebbed, and through rapid swelling had burst the uniforms they were wearing, and the stench was characteristic. 3 of the men with abdominal injuries who were rescued had fecal fistula, apparently of the large intestine. During the fighting of 1916, some men wounded in the abdomen who had lain out reached the clearing station. A percentage of them developed fecal fistula. Others had an action of the bowels containing changed blood a day or 2 after admission, and one officer passed a shrapnel ball per rectum on the 6th day after being wounded. Many of these men recovered without operation and were evacuated to the base. One case, showing the advisability of waiting, is the following. Private wounded in the abdomen on July 1st, 1916, had been lying out for 18 hours. He reached the casualty clearing station 22 hours after injury. The wound was caused by a small piece of shell which had emerged. Pulse was 110 and good, and there was localized rigidity and tenderness in the region of the right iliac fossa. There was no vomiting, but the abdominal wall was retracted. The abdomen was opened, there was no escape of gas, though the small intestine was found to be punctured in 7 places. Plastic peritonitis was localized and well developed, and the great omentum was adherent. Fluid of a reactionary nature was present in the neighbourhood of the injured gut, but there was no escape of bowel contents. The perforations in the gut were sutured, and tubes were inserted down to the wounded gut and into the rectovesical pouch. The wound in the anterior abdominal wall was excised, and the abdomen closed with through and through sutures of silkworm gut. The small intestine was empty. The pulse remained good for 24 hours after operation. Vomiting and distension then appeared, and death followed 36 hours later. We feel strongly now that this operation would have been better left undone, and that this man, if left alone, might possibly have recovered, because his case did not differ in the least from a subsequent number of a similar character which recovered without operation. Without hesitation we can say that lying out in an old trench, a shell hole, or any spot affording cover, distressing as it may sound, has been the salvation of a large number of men who have been hit in the abdomen. Cases of men who were hit in the abdomen during quieter times, and to whom it was possible to give more attention directly after injury, are still more striking. Though hollow viscera have been involved, these cases are conspicuous by the absence of shock. 2 cases that we kept in a warm dugout developed fecal fistula. There was only slight distension, and with morphia they were comfortable. Both were evacuated to the base, and as far as we know both recovered, as no intimation of their death reached the battalion. Cases with damage to hollow viscera, when seen soon after injury, and provided they are not complicated by severe intraperitoneal hemorrhage, show a definite and constant area of localized tenderness. This area is quickly obscured by transport, and by the time the clearing station is reached, tenderness has become diffuse, vomiting has commenced, and the pulse rate increased. To sum up, a large number of abdominal wounds, not complicated by severe intra-abdominal hemorrhage, do not at once present symptoms of shock. If such cases are not immediately moved and subjected to motor transport, they remain for hours comfortable and present no symptom complex of peritoneal infection. They are, therefore, after a rest and the administration of saline and morphia, far better able to stand the journey in a motor ambulance, and their chances of recovery are thereby greatly increased. It is just a question of giving the protective faculties of the peritoneum and omentum a chance to assert themselves, so as to minimize the risks of extravasation and shock during transport. Initial points to be considered in the case of abdominal wounds. A. Fatigue. This condition militates strongly against all classes of wounds. B. The interval of time that has elapsed since taking food. During active fighting, food and drink are necessarily taken irregularly. A wounded man may have been several hours without food, in which case the hollow viscus may be empty when hit. On the other hand, he may be wounded during the period of active digestion, in which case there is the danger of both extravasation and hemorrhage. C. The nature of the food the soldier has been eating. This may be bully beef and biscuits, the emergency ration, or the ration issued during quieter times in the trenches. In the former case, extravasation has proved neither so extensive nor so serious. D. The time at which the bowels were last opened. In the trenches there is a tendency for men to shun the latrine. A number have been hit while there, and the whole surroundings seem to exert an inhibitory effect on the act of defecation. Consequently, when a man is hit, he may have 3 or 4 days' accumulation of fecal material in the large bowel. In a large percentage of the cases operated upon, Boulais, as hard as bricks, were present in the large bowel and rectum. Their presence forms one of the most difficult complications to deal with in the after-treatment, for they cause distension and a large degree of obstruction. Frequent enemata are required for their removal, and occasionally digital manipulation, a procedure which is both painful and distressing to the patient. Were it possible to administer an aperient to every man 48 hours before going into action, it would undoubtedly favour the chances of those hit in the abdomen. E. The nature of the missile. Pieces of high explosive are more serious than shrapnel balls or rifle and machine gun bullets. F. The presence of early shock. This practically always denotes intraperitoneal hemorrhage. These cases are of a very serious nature and will not stand a motor journey. G. The presence of other wounds complicating. Compound fracture of the bones of the extremities, ribs, innominate bone, and wounds involving the thorax and spine are frequent complications of penetrating abdominal wounds and should receive due attention. Their presence only increases shock and reduces the patient's chances. H. Position of greatest comfort during transport. The Fowler position has been advised, but men with abdominal injuries prefer the prone position and travel this way on a stretcher more easily. Problem of transport. This will depend upon the military exigencies. During active fighting, little can be done at the regimental aid post beyond giving morphia. Wounded men must be got rid of, and this may entail carrying them over rough ground, often under heavy fire, until the advanced dressing station is reached. At the advanced dressing station little can be done, owing to the rush of other wounded. The next stage of the journey is by motor to the field ambulance, and thence to the casualty clearing station. Roads may be bad, occasioning much shaking, and the patient's chances are thereby jeopardized. During quieter times, an abdominal case, if necessary, can be kept some time at the regimental aid post, warmed and given saline. The journey to the clearing station can be made more gradual, and the chances of recovery are thereby increased. It should never be forgotten that some men have morphia in their possession and dose themselves before the medical officer can reach them. Conditions in the casualty clearing station. During active fighting, many cases are arriving more urgent than abdominal wounds. Such are hemorrhages, severe laceration of limbs calling for immediate amputation, cases of gas gangrene calling for similar treatment, thus rendering the operating theatre unsuitable for cases requiring laparotomy. At the same time, the energy of the operating surgeons is being severely taxed, and this cannot favour the best results. When pressure of work is not so great, more time and care can be given to abdominal injuries. Consequently, their chances are more favourable. Classification of abdominal wounds. The following classification includes practically all the abdominal injuries seen in the present war. 1. Wounds associated with severe intraperitoneal hemorrhage. 2. Extensive injury of the abdominal wall with prolapse of the omentum and a portion of the gut, A. with perforation of the prolapsed gut, B. without perforation of the prolapsed gut. 3. Penetration of the abdominal cavity. It is here that a localized area of tenderness is helpful to the surgeon. 4. Perforation of the abdominal cavity. Here the course of the missile is more or less known. 5. Penetrating wounds involving the peritoneal cavity, but situated in tissues distant from the abdominal walls, for example, buttock, thigh, perineum, scrotum, and upper thorax. 6. Extensive wounds of the buttock involving the rectum and peritoneal cavity. 7. Contusions of the abdominal wall involving damage to the abdominal viscera. Diagnosis. Moribund cases arriving at a clearing station with a rapid pulse, pale, sweating, distended and dull in the flanks, are invariably cases of intraperitoneal hemorrhage. Often they die soon after arrival, some arrive dead. Those operated upon invariably succumb shortly afterwards. Cases of this kind, that we were concerned with, died during the interval in which efforts were being made to improve the pulse and general condition prior to operation. Injuries to hollow viscera show fairly constant symptoms. Pulse varying from 90 to 110, abdominal rigidity with retraction, general tenderness, rarely localized after a motor journey, and persistent vomiting of a greenish-yellow material. The last named symptom has proved to be the most significant and constant in connection with wounds of hollow viscera, for the persistence and degree of the vomiting seems to vary with the amount of extravasation. There is no passage of flatus or urine, and a peritonitic facies is present. Purely thoracic injuries resemble in some respects abdominal injuries. They differ in that these patients do not vomit persistently. The abdominal rigidity is unilateral, corresponding to the same side as the chest wound. Urine and feces are passed. There may be hemoptysis and cyanosis, with cardiac displacement, respiratory embarrassment, and a short irritating cough. It should, however, never be forgotten that a chest wound may involve an abdominal viscus. A wound in the back, resulting in a retroperitoneal hematoma, is often very difficult to differentiate from a penetrating wound of the abdominal cavity. Laparotomy has frequently been performed for this condition, and blood has been found free in the peritoneal cavity, although the peritoneum has itself been uninjured. With the latter cases, it is very rare to find retraction of the abdominal wall. On the contrary, there is distension of the gut of an apparently paralytic kind, which recovers itself in 5 or 6 days' time. We performed laparotomy on a few such cases, and in all a paralytic condition of the gut with distension existed, although the gut itself was uninjured. The condition is probably due to trauma or pressure of extravasated blood upon the retroperitoneal plexuses. Vomiting, sometimes of a persistent nature, is not uncommon. There is not the same superficial tenderness to palpation, and rigidity is present to a lesser degree. It is generally possible to palpate the posterior abdominal wall, and it is then that the tenderness is elicited. Abdominal distension and not retraction, definite tenderness on deep palpation when the posterior layer of the peritoneum is touched, with the absence of superficial tenderness, are the main points in the differential diagnosis between a retroperitoneal hematoma and an injured viscus. Wounds of the anterior abdominal wall, which do not penetrate the peritoneal cavity, may be associated with damage to a viscus. One case presented a severe tear in the liver, and in another the cecum was torn. In every case of injury to the abdominal wall not involving the peritoneal cavity, it is wise to wait a few hours and watch for developments. If complications of an internal kind do not arise after 3 to 4 hours, it may safely be assumed that there is no intra-abdominal lesion. Wounds of the thorax, thigh, buttock and perineum may involve the peritoneal cavity, and this should always be borne in mind. Treatment on the battlefield. Treatment commences at the time and place at which the wounded man falls. When active fighting is in progress, the regimental medical officer can do little on the battlefield besides loosening the kit, giving morphia, and taking away the water bottle. These men must often wait until after dark before they can be rescued or taken to a place of cover. But occasionally a wounded man with the loop of intestine prolapsed has been known to walk to the advanced dressing station. When the advanced dressing station is reached, further morphia should be given if necessary, prior to the journey to the casualty clearing station. This should be carefully noted on the tally, and if time and opportunity permit, the localized area of tenderness, which is always present at first, should be marked out with a skin pencil on the anterior abdominal wall. This is invaluable information to the surgeon at this last named unit, as the local tenderness practically always disappears by the time the unit is reached. During quieter times, the regimental officer can give abdominal cases more attention. In the line, we found it possible to get them warm and give them subcutaneous saline before sending them on to the advanced dressing station. When severe intra-abdominal hemorrhage has taken place, the patients stand the journey so badly that, if possible, it is advisable to operate at the advanced dressing station and even at the regimental aid post, for by doing so life is undoubtedly saved. As mentioned before, 2 cases recovered out of 6 operated upon in a dugout not far behind the front line, for in truth none of these 6 men would have survived carrying to the advanced dressing station. They were all operated upon within 10 minutes after receiving their injury. The bad results of similar though less severe types of wound which survived to reach the casualty clearing station must teach us that the practice of immediate laparotomy, though performed by us in only 6 cases, is not only possible under the conditions, but that it is the correct practice in order to save life. Men after operations other than laparotomy, which were of necessity performed in the line, have slept well under morphia prior to their removal to the advanced dressing station, despite the continuous din of artillery. A number of cases of injury to hollow viscera, which owing to battle conditions were kept in a specially constructed dugout, made warm, given saline and morphia, and sent down a few hours later to the advanced dressing station, reached the field ambulance and the casualty clearing station in a very good condition, and it was noticeable that cases which had received this early treatment in the line often recovered, for the battalion was rarely notified of a death. Early rest, with saline and morphia, is highly desirable in giving the omentum and peritoneum some chance to carry on their protective work. On reaching the casualty clearing station, abdominal cases should be put to bed with as little delay as possible, and after a preliminary examination it is wise to wait 3 or 4 hours. This will give the surgeon an opportunity of finding out which way the case is going, and at the same time it gives the wounded man a rest after the motor journey. Should the pulse rate increase, vomiting of a persistent type set in or continue, and be associated with abdominal rigidity and tenderness, then operation should not be delayed. If, on the other hand, there is little vomiting, and the pulse rate remains at what it was on admission, it is better to wait. If the missile is still in, and especially if its position is suspected to be retroperitoneal, an X-ray should be taken in order to guide the surgeon in his search for it. The early removal of the missile, especially shell, is most important, as fatal infection is almost certain to ensue if it is left in the retroperitoneal tissues. We have in rare instances localized the missile in the abdominal cavity. A second X-ray has shown that it has changed its position, and after 48 hours it has been passed in the stool, and this without any symptoms of leakage from the gut. Expectant treatment. If after 2 or 3 hours rest in bed the pulse rate has not increased, the patient has warmed up and become more comfortable, and especially if vomiting of a greenish-yellow material is not frequent or persistent, then it is quite justifiable to wait. After a while the pulse rate may fall and its quality improve. This is an indication that the intra-abdominal lesion is becoming localized. Sips of water may be given by mouth, and this is aided by subcutaneous saline. Bismuth carbonate is given 3 times a day, and tinctured camphor compound combined with it seems to have a beneficial effect in these cases. The abdominal wound should be dressed frequently with peroxide of hydrogen and hypochlorite solution, and a spreading infection should be carefully watched for. The temperature should be taken 4 hourly. These wounds do not usually give rise to serious infection. If, however, a spreading infection shows itself in the abdominal wall, it should be surgically dealt with without delay. At the end of 48 hours, one of the following events may happen. A. The pulse rate may have fallen and its quality improved. The presence of a definite localized tender area may be present. There may be a little distension with cessation of vomiting. The patient may have passed urine and perhaps some flatus. B. The pulse rate may be rising after a temporary fall, and distension with persistent vomiting of an obstructive type may have set in. Should the second of these conditions obtain, and it is apt to set in very rapidly, then operation should be performed without delay. 3 types of vomiting associated with abdominal injuries call for comment. A. Vomiting on admission and aggravated by motor transport. The vomiting may be persistent, or it may diminish and cease entirely. The cause is reflex, and it has invariably denoted severe peritoneal irritation by the products of extravasation from a hollow viscus. Should it cease with rest in bed, the damage done is probably being adequately dealt with by the omentum and peritoneum. Should it persist, our cases have shown extravasation on a large scale, such as would be caused by a severe rupture of the small intestine while digestion was in active progress, rupture of the urinary bladder, and the like. Persistent early vomiting is a grave sign and calls for early operative treatment. B. Vomiting which has ceased and commences anew after 48 hours is generally obstructive, and the obstruction can be traced to one of the 2 following causes. 1. Obstruction in the large gut due to the presence of hard sebae. 2. Obstruction owing to plastic peritonitic adhesions resulting from the injury. The first named, A, is by far the more frequent, but we have seen both. Vomiting class B is associated with distension and so differs from class A. Without operation, we have seen men suffering from obstructive vomiting develop a fecal fistula, which has saved the surgeon the task of interfering, and at the same time has perhaps saved the patient. Obstructive vomiting, if a fistula does not develop, calls for active interference, but the lesion is at this stage shut off and the outlook is better. C. Vomiting which is not peritonitic and where no excessive distension exists is toxic and denotes grave infection in the wound or wounds, especially if one be retroperitoneal. Vomiting associated with gas gangrene is well known and easily recognized, and is an extremely grave complication. On the 3rd day an enema is given. The ordinary turpentine enema has proved the most serviceable. Great perseverance is needed on the part of the sister, as the rectum and gut are usually blocked with hard, sibilous masses. Sometimes, after administration of an enema, a fecal fistula has developed. Sebae in this connection are perhaps the greatest bugbear to the surgeon. In the majority of cases, sebae in great part have been the cause of obstruction following operation, far more often indeed than plastic peritonitis, and by obstruction they have been the cause of fecal fistulae. Difficulty in getting the bowels to move after operation is well known to surgeons at the casualty clearing stations. When once the bowels have moved and the sebae have been evacuated, the danger as a rule is past. Obstruction setting in at the end of 48 hours has almost invariably occurred below the site of injury in the small gut, and has been traced to a large accumulation of sebae in the large gut. In only 2 cases did we see obstruction due to plastic peritonitis. Some surgeons have prescribed calomel, pituitrin, etc. soon after operation, and fecal fistulae have sometimes followed their administration, again tending to prove that the obstruction is lower down. Consequently, the bowel gives at its weakest point, namely at the site of the original injury. Retroperitoneal wounds accompanied by paralytic distension of the gut respond well to pituitrin and calomel. In 2 cases, fecal fistulae developed and discharged through the wounds. The fistulae followed the administration of a turpentine enema. Both cases were well and went to the base, passing feces by both fistula and rectum, the amount passing by the fistula steadily decreasing. It is very important in the case of retroperitoneal wounds to extract the missile, which is often high explosive with its concomitant piece of clothing, and to evacuate the blood clot as soon after injury as possible. Of course, a retroperitoneal hematoma and the penetration of the peritoneal cavity may coexist. Operative treatment. The operating theatre has been either a dugout or a marquee or a hut. The type of theatre in which we did most of our abdominal work was a wooden hut. The hut was plain and unpainted. It contained 5 operating tables, side windows, but no skylight. After dark it was lighted by means of acetylene. This was the scheme adopted at a casualty clearing station in France. At a base hospital in the Balkans, the hut was divided into 2 separate theatres. One of these was reserved entirely for civilian surgery, and in it only operations such as the radical cure of hernia, removal of appendix, removal of internal semilunar cartilage and the like, were undertaken. This theatre, the smaller of the 2, was fully equipped, so that there was no exchange of instruments. The larger theatre accommodated 4 operating tables of the service pattern, and was reserved entirely for the surgical treatment of wounds. All sterilizing was done in a sterilizing room, containing 3 high-pressure sterilizers. An anesthetic room, linen room, entrance hall, and an annex containing a boiler for providing hot water completed the installation. Skylights and side windows provided excellent lighting, and at night electric light was available. Unfortunately, the theatre was not dust-proof, and no operations except those of extreme urgency could be carried out when a Vada wind was blowing. Splints, surplus dressings, etc. were kept in a medical store close at hand. During the hot season, surgeon, assistant, anaesthetist, and theatre staff removed all their clothes and substituted sterilized suits made of butter muslin. Over this was worn a sterile jaconet apron, and outside all a sterilized white gown. Even in this clothing the heat was very severe and trying. Anesthetic. At the casualty clearing station in France, the anesthetic was chloroform followed by ether, and whenever possible a preliminary dose of morphia and atropine was administered hypodermically. Ether was administered both by the open and closed method, but by far the most preferable from every point of view was its administration by the endotracheal method. Captain L. Game, RAMC, gave endotracheal ether in a number of cases of abdominal injury for one of us, and judging by the after history and progress of the cases, the method proved far superior to either the open or closed method of administration. Diaphragmatic excursions are damped to such an extent that the surgeon's task is made much simpler, and the energy that such excursions entail is saved to the patient. Relaxation is complete, and there is no cyanosis or collection of mucus at the back of the throat. It is indeed the perfect anaesthetic for abdominal work, both from the surgeon's and patient's point of view, and perhaps from the point of view of the anaesthetist. In the East, where dust storms abound, ether anaesthesia is sometimes followed by a bronchitis, which rather complicates the after progress of a laparotomy. It is always advisable under these circumstances to give the anaesthetic warm. Intravenous administration of ether in very collapsed cases is probably the best, for it is also a stimulant and does much to combat shock. Preparation of the patient. After arrival at the casualty clearing station, the patient should be put to bed, made thoroughly warm, and given 2 pints of normal saline to which 4 teaspoonfuls of sodium bicarbonate and 1 ounce of brandy have been added. This is given subcutaneously. This preliminary is most essential and markedly improves the condition of the patient prior to operation. It is probable that the bicarbonate neutralizes the acid products of fatigue. The brandy acts as a stimulant on the circulation, so aiding their rapid removal, while the saline acts as a diluent and an aid to excretion. This mixture in all serious cases of wounds has proved after extensive trial to be far preferable to saline alone. At the same time, morphia is given hypodermically if necessary. At the end of 3 or 4 hours, it will usually be found that the general condition of the patient has very materially improved. He is now taken to the operating theatre. The operating table should be warmed by an apparatus if provided, or by hot water bottles, and great care must be taken in this connection not to burn the patient. All necessary shaving and preparation of the skin can be carried out whilst the anaesthesia is being induced. It should not be done in the ward or marquee, as this involves an exposure which does more harm than good, and further distresses the patient. Intraperitoneal hemorrhage. Most cases of abdominal wounds complicated by severe intraperitoneal hemorrhage die shortly after their arrival at the casualty clearing station, if indeed they survive the journey. Little success, if any, attends a laparotomy at this stage. Consequently, the operative treatment of such a condition will not be discussed here. We would only suggest that if operation is to be of any use in this fatal class of case, then it must be performed far nearer the firing line than either the casualty clearing station or the field ambulance. We mentioned before that we had the opportunity of operating upon 6 cases in the lines, but we never made a practice of operating upon them at the casualty clearing station, for the results were both hopeless and disheartening, and the time taken over the operation, which rather hastened the end, was more profitably spent in dealing with cases that were more likely to benefit. Wounded men suffering from intra-abdominal hemorrhage must be put to bed without delay, and every effort made to rally them before undertaking operation. It was during this interval that so many of them died, and the futility of an operation in such cases was obvious. Penetrating and perforating abdominal wounds not complicated by intraperitoneal hemorrhage. In addition to the abdominal wound, the surgeon has to reckon with fatigue, shock, mental complications, and other wounds elsewhere, which so frequently accompany an abdominal injury. We have frequently operated upon men with penetrating abdominal injuries, who have in addition other complications such as a penetrating wound of the skull, gas gangrene of one of the extremities, compound fracture of the bone, and the like. If such exist, then the surgeon has further to allow for a degree of bacterial toxemia and added shock. Operation. The operation must be carried out as quickly, gently, and deftly as possible, and in most cases the actual time varied from 20 minutes to half an hour. Prolonged operations under these circumstances are very badly borne, and any additional shock must be avoided. A further pint of normal saline solution, containing 2 teaspoonfuls of sodium bicarbonate and half an ounce of brandy, is slowly run into the subcutaneous tissues of the axilla during operation. We have always used Lane's bag for the administration of the saline. The abdomen is shaved, cleansed well with ether, and painted with iodine, dry preparation. The incision is determined by the area of maximum tenderness, and if possible is made paramedial. On opening the peritoneal cavity, the first point the surgeon looks for is escape of gas or bowel contents. Before the peritoneum is incised, its external appearance may be dark in colour, denoting some degree of intraperitoneal hemorrhage. All extravasated material and blood should be removed with gauze mops, and a systematic examination of the gut carried out. The small intestine should be quickly examined in its entirety, looking both for damage to gut and damage to mesentery. This examination is carried out quickest and with least shock by starting at the ileocecal junction. As each loop of small gut is examined by the surgeon, his assistant immediately returns it, if sound, to the peritoneal cavity. By this means, exposure of the gut is reduced to a minimum. As each perforation is met, it is immediately sutured with 2 layers of fine thread. When the small intestine has been examined and repaired, the surgeon next turns his attention to the large gut, and starting at the cecum, proceeds to examine the whole of the colon. Any perforations are repaired in just the same way as in the small gut. If necessary, the stomach, especially in cases of wounds involving the chest, the liver and spleen must be examined, and any necessary repairs carried out. At the same time, a search for the missile should be made, and this is most frequently found either 1. In the lumen of the gut, 2. In the bottom of the rectovesical pouch, 3. Wrapped up in the greater omentum, 4. In the abdominal wall. This done, the peritoneal pouches are cleaned out and mopped dry. In nearly all our cases we have inserted a drainage tube, both to the damaged viscus and a smaller one to the prerectal pouch. We have never drained the flanks. The abdomen is now closed with through and through sutures of silkworm gut, and 2 to 3 ounces of warm ether are introduced into the peritoneal cavity through the tube leading to the prerectal pouch. The tube should then be clamped with a pair of Spencer Wells forceps, and these should be removed 3 hours later. The removal of the forceps is often followed by a gush of blood-stained fluid from the tube. Dry dressings and a many-tailed bandage complete the operation, and the patient is immediately returned to a warm bed with plenty of hot water bottles. It may happen that when the abdomen is opened there is no escape of gas, blood, or extravasated products of the gut. The peritoneum clothing the gut may not be inflamed. In fact, no sign of local or general peritonitis may be apparent, although the gut may be distended. If such a state of affairs be met with, it is not necessary to explore the gut from end to end, for the cause of the condition is usually staring the surgeon in the face, that is, a retroperitoneal hematoma. Any surgeon who has handled many of these cases knows almost instinctively when the gut has been damaged. An inflamed, unpolished condition of the serous coat is almost pathognomonic of an injured hollow viscus, and in these circumstances the gut must be investigated. Again, the peritonitis may be localized, and if this is the case, only that portion of the gut within this area calls for examination. We have seen cases in which the peritonitis has been entirely limited to one half of the peritoneal cavity, the remaining half being shut off, and again cases have occurred in which only one of the abdominal quadrants has been involved. It may happen that the gut has escaped injury, yet one flank may be full of blood, due to a damaged kidney, spleen, or liver. The amount of work required inside the abdomen varies enormously, and every case must be dealt with as occasion demands. Excessive handling, however, must be avoided, for not only does it increase shock, but it tends to the spread of peritonitis in cases where this latter condition has become localized. Where early peritonitis is general, then the whole gut must be examined in a quick, methodical manner. What has been said so far applies generally to cases of penetrating abdominal wounds. The wounds of entry and exit, if the last named be present, must be excised, and often primary suture after excision can here be practised. End of Chapter 21, Part 1.